হ্যালো হ্যালো চেক চেক কত কত দিলাম ওখানে তোমাকে চেক ওয়ান টি 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 চেক ওয়ান টি সিক্স check hello check check one hello check 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 hey check 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 six check hey hello check 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 six hey check check hey check hey one two না এই ওই প্লাগ একটা প্লাগ খারাপ আছে ওখানে একটা বোর্ড নিয়ে আসো check hey one check 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 six check one two T check one two six 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 check one hey check 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 hey one check six check check hey 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 one check check six hey check check one T T check. One, two, 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 two. Check. Check. Six. Hey, hey. Check. 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 One.
Yeah, hello. Yeah, good morning. Thank you. One, two, three, four, five. Fantastic, fantastic. We start in 15 minutes.
Check. 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 One, two, two. Check. Hey, hey, hey. Check. 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 One, two, six. Check. One, two, six.
hello, hello, section, hello. Hello, hello, hello. Hello, 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 section, hello. Hello, 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 hello.
Console ready? Yeah. I think when the console is ready, on a day like this, on day 3 of a conference, you always request the console whether they are ready. They are really saturated by overwork. Good morning, everybody. And I think you had a very nice dinner. And those who want to attend the academy or want to learn or contribute to the science always reach in time. But we have to excuse them. Those who really attended the yesterday evening dinner till 11:30, 12, it was really fantastic sumptuous dinner. So we go on to third day meeting with the HCC Emerging Frontiers. The chairpersons for this session are Dr. Ashu Abhishek, Apollo Proton Cancer Center, Chennai, Dr. Shobhik Ghosh, Medical College, Kolkata, Dr. Gangi Reddy, S. Gangi Reddy from Tata Medical Center, Kolkata, Dr. Gajanan Roj from Bombay Hospitals, Mumbai, is very close to us, and Dr. Syed Ahmed, Manipal Hospital, Bangalore. Please take the chairs and start today's proceeding. I think you call the speaker, please, or I'll call on behalf of you, whatever you like.
Okay. Good morning, everyone. We'll start our first session today, which is HCC Emerging Frontiers. For the first talk, I would like to invite Professor Hyunchul Rim, who will deliver a keynote lecture on liver ablation back to beginning. Over to you.
As we said yesterday that Dr. Hyunchul Rim is from Korea, is an interventional radiology leader from Samsung Medical Center in Korea. Is a pioneer and global authority on image-guided thermal ablation of hepatocellular carcinoma, shaping both practice and training in loconeurial oncology. I've seen a glimpse of that in yesterday evening videos. Sir, it's all yours.
Good morning, everyone. Thank you for inviting me to this wonderful conference in the city of Joy, Kolkata. Today, my talk is not newest device or strongest energy and guideline. This is just a short story about the short journey looking for the root of local regional treatment during my sabbatical leave. Why look back? If we understand where HCC treatment is, new technology and faster systems and more powerful devices. However, successful treatment does not begin with the novelty, it begins with fundamentals. If you want to understand where HCC treatment is going, we need to understand the basic, the origin of local regional treatment. This talk focus on the historical origin of local regional therapy of HCC. I have a privilege for visiting Japan and personally interviewing with the 3 Japanese pioneers for TACE, microwave, and ethanol ablation. Those are Dr. Yamada, who conceived the transarterial chemoembolization for the first time, Professor Tabius, who performed the first clinical microwave ablation, Professor Sugiura introduced the PAI. I asked each of them, can you tell the story the day of your first procedure? Their answers were deeply insightful to me, so I'd like to share. Birthplace of HCC Frontier. That was not Tokyo or Kyoto. For microwave ablation, Wakayama University Hospital, TACE, Osaka City Hospital, ethanol injection, Chiba University Hospital. Limited imaging, rudimentary device, and no established guideline. However, these techniques became the global standard of care nowadays. What is the secret for innovation? I'd like to summarize with 3 characters. I hope you can recognize the meaning at the end of my talk, CBR. So let me start with the first, TACE. Professor Yamada, he was at the time 84 years old.
Really? 10 years.
Very
During
energetic.
that period, I often encounters the catheter intima
Injury, dissection.
injury dissection
I see.
for advanced
I
insert the catheter.
I see.
Yeah, but
Very interesting story.
but in such cases, alpha fetoprotein
No decrease.
decrease one day or 2 days later.
Really?
Quick.
So you recognize.
Sharply decrease.
Yeah. So maybe arterial occlusion maybe
Yes.
affect. So
Not
you.
only chemo.
So at that time you suggested
yes.
some idea. Okay. He noticed that some patients who developed intimal dissection after procedure paradoxically showed prolonged survival. This observation led to him to hypothesize interruption of hepatic arterial flow might have therapeutic benefit. But he didn't rush in clinical application. After conducting the animal experiment, he treated first patient in 1977 and eventually published his work in radiology in 1983, establishing TACE as a standard of care for intermediate stage HCC, as we all know. So, TACE developed from failure, complication. Innovative ideas discovered from complication. So C means complication. Moving on, second technique, microwave ablation, proposed by Professor Tabiuse. He's a general surgeon in Wakayama University. Interestingly, his original research topic had nothing to do with HCC. He was just studying extracorporeal microwave treatment to reduce postoperative adhesion after GI surgery. Through this experiment, he discovered focusing microwave energy through a needle-shaped applicator could generate sufficient heat to achieve hemostasis for the more induced tumor necrosis. This insight led him to apply microwave ablation clinically for the first time. So this is not original idea. What many researchers would consider secondary findings. Please think about it. He observed some potential of one technique. This was not a planned innovation, just byproduct of ongoing research, recognized by curious and open mind. So, B means byproduct of a research. Both pioneers, interestingly, had worked together long time ago in Wakayama University, same hospital as a hepatologist, as a radiologist and surgeon when they were young faculty. Moving on to the final technique, ethanol injection, Professor Sugiura in Chiba University, very famous for Okuda classification. Sorry. The origin traced back to the informal conversation during a dinner in GI department of Chiba University Hospital. After hearing the ethanol sclerotherapy for esophageal varices, some drunken resident, Professor Dr. Watanabe, asked, "Why don't you inject ethanol directly into the HCC mass?" But everybody say, "Are you crazy?" like that. But after that, Dr. Sugiura catch this idea, and he carried out the animal experiment, and later developed and popularized ethanol injection, marking the beginning of a local treatment for liver cancer. One behind story.
I will present to report, but reject.
Oh, really? Rejected.
But reject.
You cannot report. You cannot present. They reject.
So he submitted his original experimental work to the Yale Society annual conference, but the abstract was rejected. So innovation did not arise from just funding or equipment. Innovative idea from reject. From conversation, curiosity, and persistence despite skepticism and even early rejection. So R means rejection. So maybe you can recognize the secret of innovation is not so much complex, very easy. C, complication. B, byproduct. Rejection. R, rejection. Actually, these all three factors are very familiar with us, okay? But they developed new innovative ideas. Despite of innovation with adversity, limited imaging and rudimentary device, no established clinical guidelines. So we can learn the core principle of early innovation is persistence beyond perfection, patient-centered thinking, willingness to challenge established norm. They did not wait for ideal conditions. They worked with what they had. Lasting impact, TACE, microwave ablation, and ethanol injection now form a global standard for minimally invasive liver cancer treatment beyond just the frontier past. This historical perspective maybe give us some insight for future development of local regional oncologic therapies. Personally, I hope any young doctors in this room will develop really another innovative procedure near the future for the patient with hepatocellular carcinoma. So again, my talk conclusion, please remember CBR, complication, byproduct, and resection. Thank you for your attention.
Thank you, sir, for your
I think you take one or two questions, very quick questions from, sir, you take the seat there.
I am Dr. Sareen from Delhi. I enjoyed, and I remember how the PEI was developed in Chiba, and I actually worked with Sugi and also Watanabe and the whole group. And Omata had just come back from the US. And it was, I want to share how rejection can teach you. I was working on portal hypertension, and I was assigned to Junior Sugita, who was working on the dog model for portal hypertension, and Dr. Okuda assigned him to teach me. So every morning, 6 o'clock, he would start, and we finish by 6 in the evening. So I asked him, how many dogs have you done, and how many successful non-cirrhotic portal hypertension have you made? He says, I have done 308 dogs. And how many successful? He says, 8. And I said, only 8? He says, but 8. Wow. I made 8 animal models. So this is what rejection taught me. And I had learned PEI there, and I used to do PEI way back in India. So I think Chiba was a role model, and your talk is immensely useful for me. Thank you for sharing these thoughts.
Thank you very much.
Dr. Hyunchil Nemching, sir, you take a seat there, sir. We'll now have a recorded talk by Dr. Daniel Wang, who is a transplant hepatologist and hepatology researcher from Singapore. He is from National University Hospital and National University of Singapore with expertise in HCC and steatotic liver disease, and a regional leader in non-invasive risk stratification and outcome research. Console, can we run the talk recorded?
Especially Professor Akash Roy and Professor Mahesh Goenka for inviting me to your wonderful conference, and I apologize that I could not be there in person this round. So I've been tasked to speak on HCC in Meso-D, epidemiology and unique challenges. These are my disclosures. For today, we will go through the burden of MASH HCC, discuss the pathogenesis, speak a bit about risk stratification, surveillance, and novel strategies for surveillance, and then we will highlight a couple of real-world problems that we as clinicians face. More than 70% of the world's new liver cancer diagnoses are right here in the Asia Pacific, and I think this is an ongoing struggle that our countries in our regions face, and I think it's something that affects all of us, not just clinicians, patients, but we also need to rope in our healthcare administrators as well as public health leaders to tackle this problem. So why is it an issue? Well, although many recent studies actually state that the incidence of liver cancer might be stabilizing, I think we need to interpret this data with a huge dose of caution. The reason being that many studies actually looked at age-adjusted incidence of liver cancer, and so if one adjusts by age, then sure, maybe the incidence of liver cancer might not be going up further. But I think as clinicians on the ground, we need to realize that the burden on our healthcare system is not age-adjusted. Our populations are rapidly aging, and so if you look at absolute numbers of liver cancer deaths, those are actually increasing tremendously. So for example, in the Western Pacific in the last decade, the number of absolute liver cancer deaths actually increased by 18%, and in Southeast Asia where we are, the number actually increased by 43%, which is actually a huge load to our hospitals and clinics. So what's driving this increase in liver cancer burden? I think by now the answer is clear. MASH is the fastest rising cause of liver cancer. And if you look at this study, which we published a while back, we looked at actually each etiology of liver cancer, and we looked at the annual change. So of all the etiologies, MASH is the only etiology that is increasing. Alcohol appeared to remain stable, whereas viral hepatitis, Hep B and Hep C have declined, probably related to antiviral therapy and vaccinations. I think this is no surprise to the many experts here in the audience and clinicians. We know that Meso-D or MEFO-D is actually increasing, and in Southeast Asia, based on recent data, the estimated prevalence is around 33%. But I think we do need to also dive deeper into this data. While 33% seems okay, I think if you look at the studies that have come out from 2015 and above, which is more close to where we are now, the estimated prevalence is more like 40% of people who have actually meso D. So I think the burden will continue to increase, especially with globalization and the Western diet being very prevalent all over our region. And I always like to refer to this important study by the group in Sydney led by Professor Jacob George. And what they did was they tried to estimate the global proportion of HCC attributable to MAFLD in this case. If you look at etiology of liver disease, if you just look at the sole liver disease, then only 12% of HCCs worldwide are related to MAFLD. But I think if they actually took a deeper look at the data, and when they looked at, when they did not restrict it to people with only one etiology of liver disease, then they realized that actually almost half of HCC in total had MAFLD. For example, in people with Hep B related HCC, 40% of them also have MAFLD. In people with Hep C related HCC, actually 54% of them had MAFLD. So actually, in summary, half of the world's HCC, there's some form of MAFLD there. And I think this just illustrates the problem that we have on our hands. Growing up as a trainee many years ago, I was taught that, okay, HCC is more a problem in males. You don't really need to worry so much about the females. But I think this paradigm has changed because if you look here at this graph from a study we published a while back, it's very true for hepatitis B and hepatitis C. The mortality rates for males are way higher than that for females. But with the rise of MASH, we find that actually in people with MASH HCC, the mortality rates between females and males actually are not too different. And one contributing factor for this is that I think our patients with MASH HCC tend to be older, and in ladies, that's when they lose the protective effect of estrogen. Therefore, I think this paradigm is no longer the case where we can say that, oh, okay, if you are female, then your chance of dying from MASH HCC is much lower than males. So what's unique about MASH HCC? Well, I think all of us here have a lot of experience working with fatty liver disease, and it's a very slowly progressing disease. It takes roughly estimated about 7 years to progress from one fibrosis stage to another fibrosis stage. And I think what kind of throws a whole spanner in our surveillance programs is the fact that MASH can develop HCC even before cirrhosis occurs. And I think that really is a major problem because most of the major society guidelines only recommend HCC surveillance in those with cirrhosis, and therefore we have a substantial proportion of people that actually don't go for surveillance, but they end up developing MASH HCC. I think the big question is why do people with MASH develop HCC even before they develop cirrhosis? And I think this paper is really important, and it was published in Nature 2 years ago now. And what the authors found is that in people with MASH and type 2 diabetes, the extracellular matrix actually becomes more viscoelastic, meaning that it deforms and relaxes over time before cirrhosis or fibrosis actually appears. So this early matrix change is actually driven largely by advanced glycation end products from the diabetes. And these glycation end products accumulate in hepatocytes and the matrix. And that alters the collagen cross-linking and tissue behavior. And so in all these viscoelastic matrix actually provides abnormal biomechanical signals to hepatocytes and activates oncogenic pathways such as YAP and TAS, even though the liver is not yet stiff or cirrhotic. And then these signals make the hepatocytes proliferate more, become more stress tolerant, and more prone to malignant transformation. And therefore, I think this is probably not the only reason why people with MASH develop HCC before cirrhosis, but I think it's one of the contributing factors. So this is a study that was more recently worked on by our group, And I think we know that genetic risk is really important for determining HCC. But I think one issue is that many genetic risk scores or polygenic risk scores in the past, many groups actually tried to use polygenic risk to identify who's going to get MASH HCC, but the area under the curve for such polygenic risk models only achieve an AUC of about 0.6 or so. And therefore, our group started to think, what if we combine PNPLA3 genotype and clinical factors? Will that help to stratify HCC risk? And so this was a prospective study from Singapore. We had around 25,000 participants. And then we tried to look at it from a simple starting point. We just thought, okay, how does the PNPLA3 genotype influence HCC risk? And if we combine metabolic risk factors such as diabetes, obesity, and also sex, whether that can further help risk stratify HCC development. And we found that among those participants who are male and overweight and those with diabetes, the risk of HCC is actually further elevated among those with the PNPLA3 risk allele. And in fact, there is also data in this study that shows that in people who are male, they are overweight, and they are PNPLA3 GG, actually their risk of HCC approaches the threshold that may be considered cost-effective for HCC surveillance. I'm in no way proposing that we start doing PNPLA3 genotype in all patients to risk stratify HCC. I'm just trying to say that maybe in the future we might want to look at this a little more carefully and see if the incorporation of genetic risk can actually help us to risk stratify those who need HCC surveillance. And I think kind of piggybacking on this idea, our group in Singapore, we are actually working on deciphering non-cirrhotic MASH HCC. We are working in collaboration with our scientists from the Genome Institute of Singapore on generating a single-cell spatial atlas to detect serial changes in the microenvironment as MASH progresses to HCC even before cirrhosis. And also we are working on liquid biomarkers and liquid biopsies. This is some preliminary work from our group, and what we have found is that actually there are MASH emergent niches, and these niches actually are immunotolerant, and they actually arise earlier than cirrhosis. So even in people with early MASH, a little bit of fibrosis, we start seeing the growing of these niches that may be the trigger for subsequent development of HCC even before cirrhosis develops. So it's very clear that in people with cirrhosis, we should survey them for MASH HCC. But the problem, as we mentioned, is that almost 40% of people with MASH HCC don't have cirrhosis. And I think this is a major problem for our risk stratification pathways. And I think in the end, they actually have a lower chance of undergoing curative treatments such as liver transplantation because we don't survey them. Why don't we survey everybody with MASH for HCC? But I think this is an elegant study from the Mayo Clinic, and what they showed is that it takes a long time for MASH to progress. In this particular cohort in Mayo, it took 15 years for about 3% of the people with just NAFLD on NAFLD to progress to compensated cirrhosis. And therefore, I think if we start surveying everybody for MASH HCC, literally we will not go home at night. We'll be seeing patients till 1 or 2 a.m. and our nurses will probably revolt. And this is an important study from a couple years back, a meta-analysis that just showed that the incidence of MASH HCC among all patients without cirrhosis is really, really low. And this further highlights the fact that we cannot survey everybody indiscriminately. Alcohol actually increases the risk of HCC, and this is a study from Taiwan showing that in people with MAT ALD and ALD, I think the risk of HCC goes up further compared to MASLD. So the ASLD has come out about 2 years ago to say that further data are still needed to identify which patients with non-cirrhotic meso-D have sufficient risk to warrant HCC surveillance. But I would argue that actually now 2 years down the road, the data actually are emerging. So this is a study that we published in CGH last year, and this was an individual patient data meta-analysis that we reconstructed. And what we found is that the incidence of MASH HCC in people with advanced fibrosis is around 0.8% a year. While traditional estimates as said that, okay, if the risk of HCC is around like 1.5% in people with cirrhosis, that would be cost effective. But I think more recent estimates, more recent cost effectiveness studies, there's one from the US by Dr. Neha Parekh from Michigan, and their group estimated that in people with cirrhosis, actually if the incidence of HCC exceeded 0.4%, then that would be cost effective for HCC surveillance. So I think now there's more emerging data to kind of challenge the older concept of doing HCC surveillance only when the incidence exceeds 1.5% a year. We know that type 2 diabetes is associated with increased risk of HCC. So if I had a patient with advanced fibrosis and diabetes, then I would be really, really careful and maybe discuss with them about HCC surveillance. And I think there was this very thought-provoking study that came out from the VA in the US last year. It's published by Professor Binu John. And in their study of, I think, mainly males, actually the annual HCC rates of patients with type 2 diabetes and a liver stiffness of more than 10 kilopascals on FibroScan actually exceeded the thresholds that were considered cost-effective for HCC surveillance. Although I think there's been a lot of debate in the field at the thresholds that were considered cost-effective for HCC surveillance. Although I think there's been a lot of debate in the field. I think there are many letters to the editor about this particular study, but I think it certainly gets us thinking about HCC surveillance. And I think this was a really important study by Professors Jimmy Lai and Vincent Wong from Hong Kong. And what they showed is that if you can use a two-step protocol, so FIT4 followed by liver stiffness by VCTE, then if the FIT4 is more than one, the FIT4 is high and the subsequent VCT is more than 15 kilopascals, actually the HCC risk exceeds actually 1% annually. So that I think clearly is cost effective. However, I think if we want to be a bit controversial, if you look at this group, when the FIT4 is high and the liver stiffness exceeds 10 kilopascals, then the annual risk actually exceeds 0.2%, which in previous studies in non-cirrhotic patients with Hep B, 0.2% was actually considered cost-effective. So I think there's a lot left to be debated and discussed about when we want to offer HCC surveillance, and I think it's probably has to be individualized to the individual country's resources and settings. So for me, what I personally do for HCC surveillance, if the patient with MASH has cirrhosis, then there's no question HCC surveillance. Then what about people with advanced fibrosis? Personally, if I would do at least 2 non-invasive tests, and I think if both are elevated or consistent with advanced fibrosis, then I would actually offer HCC surveillance after discussing with the patient. I think in the interest of time, I'll just skip a couple. This is just to say that in people with a normal FIT4, they are not out of the woods in terms of HCC. This was an international study involving several sites in Asia, including India. I think Professor Anand Kulkarni also contributed to this study. And what we found is that in people with MASH without cirrhosis, actually 1/4 of them have a normal FIT4, which kind of busts our usual risk stratification algorithms. And I think we do in the future need to think about how we can better identify those at risk for HCC. This is some work from my colleague Sangwon Lee from Korea, where he showed that actually among people with MASH, it's those with fibrosis but a lower amount of fat, they actually have the highest risk of HCC and decompensation. What I think this kind of goes to aligns with the concept about the burnt out mesh. So I think about it this way: in people with fibrosis and a lot of fat, I think there's still ongoing inflammation, but as the fat slowly burns off over time, these patients end up with the fibrosis. There's limited fat, and then I think they start getting more sarcopenic. So I think these people are the ones that are really, really high risk of HCC, and I will actually monitor them more carefully. This is a taste of the future. A group from Japan looked at more than 600 patients with biopsy-proven MASH, and they used deep learning and digital pathology, and that could actually identify several HCC class features like immune cell infiltration, cellular atypia, that actually predicted the development of HCC. So I think this is one way how AI might help us in the future. This is another study from our international consortium, where we actually showed that in people with Hep B and Hep C, HCC surveillance was associated with improved survival, but actually in people with MASH and alcohol, right, surveillance was not associated with a statistically improved survival. So I think there's a lot of work to be done in terms of the modality of surveillance and what form of surveillance we choose for people with MASH. This is an important study from Dr. Amit Singhal's group showing that sensitivity of ultrasound for detecting early HCC within Milan criteria is less than 50%, and therefore we need alpha-fetoprotein. This is another study that we did a while back, several years ago now, where we showed that actually in people with MASH cirrhosis and you do ultrasound, actually more than 1/3 of the time, right, the radiologist cannot actually visualize the liver. So if they can't see the liver, they can't spot the tumor. And so we thought, okay, maybe if we do abbreviated MRI, where we only use 1/3 of the usual sequences for MR, maybe that might actually substantially improve visualization. But you can see here that, to our surprise, actually almost 19% of people with abbreviated MRI, the radiologist also could not, had severe limitations to visualization. Certainly better than ultrasound, but it's not perfect. And so I think there's a lot of work in this space, and maybe that's why we also have jobs for the future in terms of hepatologists. This is important study, I think from Korea, where they compared non-contrast MRI versus ultrasound for HCC diagnosis. It was a randomized single-center trial with more than 400 participants, really impressive study. And what they found was that in those who actually underwent non-contrast abbreviated MRI, there was a lower BCL stage at the initial diagnosis of HCC with a lower false positive referral rate, but actually the detection of early stage HCC, BCLC 0 and A actually wasn't significantly better in this particular study when you compared non-contrast MRI versus ultrasound. Just a final bit about blood-based biomarkers. I think now there are several biomarkers that are gaining traction. One is GET, and this was led by Professor Tira in Bangkok, and in this multi-center study, the GET algorithm had a higher area under the curve for detecting HCC, and this was across disease stages, etiology, or geographical region. But I think this is more of a case control study, so I think longitudinal studies will be more important. This is a phase 3 biomarker study that was published in Gastro last year, and they compared GALET versus alpha-fetoprotein, and they found that GALET actually substantially improved the detection of HCC compared to AFP. So I think this is probably one of the biggest studies on HCC surveillance that have been organized, and is led by Professor Amit Singhal. And they are doing a national liver cancer screening trial where they are comparing in the randomized trial standard of care ultrasound plus AFP versus GALET alone without any ultrasound, and the primary endpoint will be reduction in the proportion of late stage HCC, and I think the readout is expected in around 2 or 3 years' time. But I think we can talk a lot about advanced kind of biomarkers and imaging, but the reality is that even with the current tools that we have, HCC surveillance is severely underutilized, even in people with cirrhosis. This was a meta-analysis that we published in AP&T last year. And we looked at the number of people, or rather the proportion of people that actually receive any form of HCC surveillance, and the estimate is around 50% in those with cirrhosis. But if we look closer at the data, we looked at those who actually receive twice yearly ultrasound, and actually the proportion drops from 50% down to around 10%. So only 10% of our patients are getting regular twice yearly HCC surveillance with ultrasound. So I think a lot of unmet needs and work to do in this space. And this was a study that I think many in the audience also contributed to. We looked at the presence of policies to reduce the burden of HEC, and I'm talking about like public health policies or national policies, and we found that only 1/3 of countries in the world have some form of policy to reduce the burden of HEC. So I think HEC is a problem that we have to address, not just at the biotech level or finding out novel treatments, but we really need to also go back to basics, engage our public health specialists, engage the healthcare administrators in our countries to work on actually very simple things that actually may improve or reduce the burden of HEC. So with that, I will finish up. More than 1/3 of MASH HCC do not have known cirrhosis, and it's not cost effective to do HCC surveillance in all people with MESO-D. Non-invasive tests such as liver stiffness on FibroScan may be helpful to guide the need for HCC in MESO-D with or without surveillance, but I think the thresholds need to be adopted based on resources and setting. Ultrasound is probably less accurate in people with MASH cirrhosis. I think it's always important to take a close read at the report and see if the radiologist could actually visualize the liver or not. And if it could not, then maybe we either need to repeat the ultrasound or consider alternative modalities. I think the future for HCC surveillance in maybe 3 or 4 years' time might be shifting towards blood-based biomarkers. And lastly, I think HCC surveillance in cirrhosis is severely underutilized, and we do actually need to work with our public health colleagues to try to improve utilization. So with that, I would like to invite you to come to Singapore in July for the Puzzle Single Topic Conference, and we'll be very excited to host you here. And with that, thank you very much.
I think Dr. Daniel is available online. We can allow one question from the audience or the panel or the chairs. He is available online. So any burning question from your side, chairs? Anyone in the audience?
Hi, Daniel. Sorry we missed you out here. Do we have data on that specific subgroup which has got both MASLD plus Hep B? So we have got both these groups which are at risk for non-cirrhotic HCCs. And you know MASLD is 40%. And you've got a population which you see very frequently which has got Hep B also. So for these dual risk factors group, which are both at risk for non-cirrhotic HCC, do you find a different pathway coming together, or we still follow the same way?
I think that's a great question. I find actually the intersection of Hep B and MEFL or MESO very, very interesting. The data is actually like confusing and conflicting, but from what I understand, if it's just hepatic steatosis alone and Hep B, then the steatosis appears to provide maybe some form of a protective effect. But if there's a lot of metabolic syndrome like insulin resistance, obesity, hypertension, then I think that actually kind of accelerates fibrosis. So I will be really very careful in those with MASH as well as chronic hepatitis B. But I think in terms of going back to the question about surveillance, I pretty much would survey everybody with chronic hepatitis B and hepatic steatosis if they hit the thresholds based on the chronic hepatitis B alone.
This is Dr. Sareen from the conference. Dr. Huang, very nice.
Dr. Sareen.
There was a large study from China where they used about I think 800,000 patient data. Those who had a high ALT compared to normal ALT, the risk was about 1.8 folds higher. And we have been following this and in a way preparing a manuscript. The question is, do you think a high ALT in a non-cirrhotic MASH or MAFLD is a higher risk and can be used as a biomarker?
I think that's a great question. I think ALT, if it's high and elevated, it certainly portends an increased risk as what you mentioned. The tricky thing is that in patients with MASH, sometimes the ALT might also be normal, but yet there's a lot of necroinflammation going on that the ALT just doesn't pick up. So I think it might be a case where if it's high, then yes, we want to pay more attention. But even if the absence of a high ALT, then we are none the wiser from that sense.
And therefore, we should treat those with high ALT in the absence of fibrosis.
Yes, I
You
agree.
Okay, thank you.
Yeah, thank you, Dr. Daniel. Now I request Dr. Wansin Kang to deliver a lecture on from how to make unresectable to resectable HCC using IO combos in 2026, 2020.
Professor Kang is from Samsung Medical Center, Seoul, Korea, a hepatologist from the Liver Cancer Center with expertise in advanced HCC care, including systemic therapy strategies. Dr. Wansik, it's your all.
Right. Thank you for the kind introduction. And also, I'd like to thank the organizers and the NASL for inviting me to this beautiful city. It has been a very short period of stay. I arrived here yesterday at about 3 a.m. But then this 24 hours has been, it seemed like it's been like a week, especially enjoying last night's gala dinner. Yeah, so my talk will be just very brief. I'll just go brief introduction on the current status of immunotherapy for advanced HCC. And then I will touch on whether we should, how about reinforcing the immunotherapy to the current IOs and whether it will lead to better outcomes, and also whether we should resect or continue chemotherapy for the patients who respond to immunotherapy. These will be based on the recent outcomes from the ESMO 2025. And lastly, I will just brief touch on one of my clinical cases. So, as you know, the intermediate stage and the advanced HCC has been traditionally considered as palliative-only stage. So this is where we don't treat them by surgery or the transplantation or any curative intent, but rather our aim was just to extend their life extension at a modest level. However, there has been a breakthrough in cancer treatment. As you know, Professor James Allison and Tasuku Honjo, they both have identified the checkpoint inhibitors. So James Allison identified CTLA-4, which is the immune break between the T cells and the antigen-presenting cells. And when this is just to prevent overactivation of the immune cells. And also, Tasuku Honjo, he has found that PD-1 is the molecule, the checkpoint inhibitor between the cancer cells and the activated T cells, where PD-L1 engagement can actually deactivate the immune cells. And by blocking the CTLA-4 and PD-1, we can actually reinvigorate the immune cells so that the immune cells can actually get primed and then target the cancer cells. And based on that, ever since 2017, there has been tremendous a lot of improvement, advances in systemic treatments, especially with the IOs. And by doing so, nowadays, the first line of treatment for advanced HCC has shifted from tyrosine kinase inhibitors to immune checkpoint inhibitor-based therapies. So for example, atezolizumab, bevacizumab showed significant improvement of overall survival as well as progression-free survival in the pivotal IMbrave 150 study. And by doing so, the IMbrave 150 study, it actually opened a new gate, it opened a new era of immunotherapy-based treatment for HCC. And following that, there was Himalaya study where instead of combining the PD-L1 plus targeted agent, from the Himalaya studies, we started combining both dual IO drugs, not only PD-1 or PD-L1, but also the CTLA-4, so that we can actually improve the priming of the T cells and also so that the T cells can migrate to the effector site and kill the tumors effectively. And from here, it shows that the STRIDE treatment, the durvalumab treatment, showed a significant improvement of overall survival. And there has been a 5-year data that after 5 years of treatment, 1 out of 5 patients who have advanced HCC, they actually survive. So this is a really different meaning. And recently there has been a 6-year overall survival data has also come out, and it also shows that 1 out of 6 patients, they still survive after starting the Himalayas, after starting the steroid treatment. And what is more interesting is that recently the Checkmate 90W study came out. This is where we put more of IPI treatment up to 4 sessions, as well as the PD-1 inhibitor, the nivolumab, together. And here, although because of the high dose of CTLA-4 inhibitor, it seems like because of the toxicity, looks like they have a little bit of dip of the survival in the beginning. However, it shows a very rapid and very deep response of the objective response rate of up to 36%, which means almost 36%, they really can have, we really can imagine that these patients can actually translate to curative treatment. Then coming to this, then one might think that if we use more of the immunotherapies as well as the targeted agents, then we might be able to improve the outcome. And interestingly, there was this, the phase 3 double-blind placebo-controlled randomized global trial, which was IMbrave 152. It was based on the Morpheus liver study, the phase 1b study. And from that phase 1 study, it showed that by adding the anti-TIGIT, which is another, the inhibitory molecule, by adding an anti-TIGIT antibody to atezobev, it showed very high objective response. So they actually conducted a phase 3 study, but unfortunately, from the phase 3 study, it did not meet its primary endpoint. So between the triplet drugs, triplet treatment, and also the atezobev double treatment, the PFS was just 8.3 and 8.2 months. There was no difference. And instead, the treatment regimen, it showed increase of toxicity without any added benefit. So this was also shown similar findings from the French multicenter study, which is a triplet HCC study. This was initially phase 2 study, which was planned to go on to phase 3 study, depending on the results. So they also added ipilimumab to atezobev and compared it to atezobev alone. And from that, they also had disappointing results that it did not meet its primary endpoint, which was the objective response rate. And both arms showed quite similar results. Then now moving on to whether we should resect or continue chemotherapy for the patients who respond to immunotherapy. So this is the ABC HCC study, which was also presented in ESMO 2025 a couple of months ago. So the population was the patients with intermediate stage ACC who were ineligible for transarterial chemoembolization, but were not candidates for the curative surgery or ablation. And they asked to see whether the efficacy and the safety of atezobev is better than TACE alone in patients with intermediate stage ACC. So the study looks like they were randomized into 2 groups. One was just atezobev alone, and the other one was on-demand TACE as long as the patient is eligible for TACE. And the main inclusion criteria was intermediate stage ACC, but it also included vascular invasion as VP1 or VP2, so just a little bit a tip of the BCLC stage C patients. And the outcome was looking into the time to treatment failure strategy, because it actually shows better outcomes. It actually shows the real world, similar to the real world, because from here, the median time to treatment failure strategy showed 14.6 months for atezobev, whereas for the TACE group, it was only 9.5 months. And these results show that there is the superiority of systemic treatment compared to TACE in regard to the time to treatment failure that is expected to translate into an improved outcome. And there was another study, which was the Talent OP study. This was also a phase 3 study, which was targeting the patients with locally advanced HCC patients who have macrovascular invasion, but there is no extrahepatic spread. So the question was, in patients who responded well to the initial systemic therapy, would it be better to continue that therapy, or would it be better to proceed to surgical resection? So as you can see, the patient population was included major vascular invasion, including portal vein tumor thrombosis or hepatic vein tumor thrombosis, or even IVC tumor thrombosis, but those patients without the extrahepatic spread. And initially, they were treated with atezolizumab for 3 cycles, and then because they were considering the surgical treatment, they needed a washout period for the bevacizumab, so they only tried another 1 cycle with atezo without the bevacizumab. And when the patient has achieved a partial response or stable disease, then they were randomized to surgery followed by atezolizumab or the atezolizumab alone, just continuing the atezolizumab. And the primary endpoint for this study was time to treatment failure after randomization. So the outcome of this study showed that the study actually met the primary endpoint. So as you can see, this is the group where the patient had surgery after response to atezolizumab, and the red line here shows the patients who just continued atezolizumab despite having stable or partial response to the atezolizumab treatment. And looks like the patients who underwent surgery, the surgical arm, they have lower time to treatment failure. And also, this actually translates to overall survival data, although the data is still immature. But there is a trend toward benefit of the hazard ratio of 0.67. And it shows that the patients with advanced HCC who have responded to systemic therapy may be the candidates for surgical resection. Then, when we come to the real world, we can sometimes experience patients who actually respond to the immunotherapy. Then, who would really, we should send the patients for resection. So, this is a study done by the Japanese group. There was an expert consensus statement that was published in 2024 in liver cancer. And they developed, the general surgeons, they developed a multifaceted approach by expert opinion, survey data, and some of the clinical evidence. So the level of evidence is not very high, but this seemed to be a kind of very useful guidance. So they actually categorized the patients into resectable or borderline resectable 1 and borderline resectable 2, who are initially unsuitable for resection. And this study was already validated for the patients who underwent lenvatinib treatment, and now recently it has been published for the patients who were treated with atezolizumab. This was a retrospective multicenter study to determine the efficacy of conversion therapy following atezolizumab, and it looks like among the patients, 20% have achieved downstaging, and eventually 5.4% were eligible for conversion therapy. And the conversion rate for the borderline resection 1 group was 8.4%, whereas the initially unresectable patients who were in the BR2 group, it was 4.3%. And if we look at the overall survival, the patients who underwent conversion therapy, they had better overall survival, whereas the patients who maintained atezolizumab, they had slightly lower overall survival compared to those who had surgery and eventually achieved cancer-free status. So to decide whether the patient should go on to conversion therapy, we need to we need to establish the downstaging protocol. However, currently there is no consensus for the downstaging protocol. So eventually the best results can be achieved through multidisciplinary team management. So I'm just going to briefly touch on, introduce one of my patients. He was a 60-year-old male who had a history of chronic hepatitis C, who was treated with DAA and eventually achieved sustained virologic response. He did not have liver cirrhosis, but his liver function was Child-Pugh A5 and Alb grade 1, and his performance was very good. However, after getting cured from chronic hep C, he had follow-up loss for several years, and then eventually when he came back to the clinic, he was diagnosed with HCC with VP4, the portal vein tumor thrombosis in main portal vein, as well as the bilateral portal veins. His initial AFP was 42.7 and PFCA2 was 536. So we had, initially we had the multidisciplinary discussion, and he was enrolled in our IIT study where we combined the atezobev plus the proton beam therapy. So this patient was treated on first-line atezobev, and the proton beam therapy was applied to the main mass as well as the bilateral portal vein. And after 6 cycles of atezobev, he achieved a partial response. And you can see that the right lobe has been atrophied after the proton beam therapy. And after cycle 27, there was no arterial enhancement of the tumor at segment 7-8 here. And there was a slight, it seemed like an enhancement in the center of segment 8 tumor. However, it was just in stable disease and all the tumor markers has been normalized. So we had a systematic MDT reassessment, and we had a consensus for conversion therapy, and eventually this patient went to surgery. And eventually it was found out the tumor at the segment, in the border of segment 7 and 8, it was total necrotic, whereas the tumor at the segment 8, it was just it was shrunk to 1.4 centimeters. And currently he is in curative status without recurrence. So I'd just like to summarize that recent advancement of effective systemic treatments has provided additional opportunities for downstaging. However, we are also learning that intensifying immuno-oncology drugs alone is not always more effective. And IO combo studies support a paradigm shift, which is the bridge to cure for selected intermediate stage as well as for the advanced stage patients. And of course, the systemic and multidisciplinary team reassessment would be very important for a successful treatment outcome for the patients. With that, I'd like to finish my talk. Thank you.
Thank you, sir. Dr. Kang, it was a very good and insightful lecture. I was about to ask this question. This side, sir.
Sir.
On the chair. Yeah.
So it was a very good lecture. Sir, any experience regarding the PD-L1 overexpression in the HCC helps in predict the therapy, just like non-small cell lung carcinoma, all these things. Immune checkpoint inhibitor, HCC, PD-L1 overexpression.
I'm sorry, the biomarker?
Yes.
Oh, yes. Currently, unlike the colorectal cancers or non-small cell lung cancer, for HCC, we don't really have biomarker at this moment. There has been many studies looking into the correlation between the PD-L1 expression from the tumor and also the response, but it has been very contradictory results, and eventually seemed like the immunohistochemistry of the combined prognostic score or the PD-L1 expression does not really correlate with the response. So at this moment, I think one of the caveat of the biomarker area for HCC is because HCC has been traditionally diagnosed by LIRAD, the imaging diagnosis criteria. So in the era of immunotherapy, we really need to do more biopsies for these advanced patients before we treat them with the immunotherapy so that we can find out the biomarkers.
I had a question, sir. So, in fact, it was a very good lecture where you demonstrated that immunotherapy has really changed how we treat HCCs. One of the major reasons for unresectability is PVDT, and that's where the radiation and IO combination has worked. But also in some papers in IMBRAVE subgroup where some patients who were treated only with IO, the complete response rate were 8 to 10%, while radiation, when it is added, the complete response goes to 20%. So do you think that only PVDT is where radiation and IO combination will work, or in future probably a better combination, because we are working towards making unresectable resectable, and having a PAT CR can be, a radiological CR can be a better approach?
Right, that is a very good question. So from the IMBRAVE data, we can see that some of the patients who have portal vein tumor thrombosis, they just respond to immunotherapy alone. However, from our real experience, we know that we really need to maintain the patient's liver function as well as treating the patient with the IO. So for the patients who have portal vein massive proton bearing tumor thrombosis, they tend to have very high portal hypertension. And if we treat them with the proton beam therapy or radiation therapy together with the chemotherapy, not only the IO but also TKIs, that we have the data, we have already published the data that these patients have better outcome. And now we are conducting a study using proton beam therapy plus atezobev for those patients to see whether it really, whether it can be validated.
Just a last question.
I think we need to go ahead. Thank you, sir. Beautiful, mind-blowing lecture you have given. I will request Professor Hinchul Reem and Wansek Kang to come down to the front row, sir. We'll start the panel. You can now call the HCC Tumor Board session. Please, chairs. No, chairs, sit down. Please call the HCC Tumor Board, Dr. Ashish Kumar and the panelist, and to continue the sessions.
For the tumor board, we like to call upon Mr. Dr. Ashish, who will be the moderator. For panelists, we have Dr. Shantan, Dr. Sunil Dadij, Dr. Malikarjun, Dr. Girish Pati, and Dr. Keshram Amarjeet.
Thank you, Dr. Ashish Kumar, for joining us. You are always great, and he's from Sir Gangaram Institute, as we all know. We from the organizing committee have a very small request to Dr. Ashish, who manipulates things like anything academic. You can, if you can restrict your total session to 20 minutes, we'll be very happy. We are running very short of time, sir. Okay.
Thank you. At the outset, I would like to thank Dr. Mahesh Goenka sir and Dr. Akash and the entire team for inviting me here. So, my expert panelists are here, and I've been asked to limit my session to 20 minutes. So, all the questions, first I would like to involve the audience and then only take the opinion from our expert panel. So, this is a case of 58-year-old male who is diabetic for long and hypertension, dyslipidemia, and also takes alcohol about 30 to 40 grams per day for last many years. And now he presented with ascites, basically, increasing abdominal girth, pedal edema, hematemesis. There was no hematemesis, no melena, no confusion. So he only presented with ascites. And there was mild distress on examination. The ascites was moderate and spleen was palpable. So when we did his labs, platelet count was slightly low. Bilirubin was mildly raised to 0.3. Albumin slightly reduced to 2.9. INR was okay. Hepatitis B, C markers were negative. HbA1c 7.2. And AFP was normal, PIVCA marginally raised to 79. And this is the ultrasound which showed cirrhotic liver with ascites. He also underwent upper GI endoscopy which showed grade 3 esophageal varices. So these are the investigations which we carried out when he first presented, and we made a diagnosis of cirrhosis, decompensated with ascites, and etiology was MET-ALD. CTP was B, 8 by 15, MELD 16, large varices, non-bleeder, and comorbidities of diabetes, hypertension, dyslipidemia, and obesity. So first I would like to ask my audience, when you first see a patient who is diagnosed to have cirrhosis in your OPD, and whose baseline ultrasound does not show any liver lesion, only cirrhotics, and AFP is also normal like in this patient, how confident are you that this patient truly does not have HCC? And the second question would be, what is your experience with ultrasound missing HCC in your clinical practice, be it in the first diagnosis or during follow-up? How often is AFP negative? And what is your experience with PIVCA2? And do you order triple phase CT when you first see a cirrhotic patient? So any of the audience, and then we'll ask Dr. Girish for his experience. Anyone would like to answer?
My experience of missing HCC on ultrasound is very common. And I give importance to PIPCA2. If the PIPCA2 is very high and platelet is very low, and having diabetes also, I become suspicious. And if the renal function is okay, and if the patient, after explanation, agrees for triple phase, I go ahead with triple phase.
So in this patient, you would have gone for?
I will go ahead with triple phase.
Okay. Now I would ask Dr. Girish.
Yeah. So ultrasonography is around 60%, 50 to 60% sensitive. But thing is that if patient is very obese or is having excess fat, and very important is colon is overlying, if it excessive colonic gas is there, then ultrasound might miss. And of course, if size of the tumor is less than 1 centimeter, 2 centimeters, it's very difficult to get in. And of course, sometimes due to early cirrhosis, where SCC is growing, due to regenerative nodules, you cannot differentiate whether it is a regenerative nodule or SCC. So in that case, usual ultrasound misses 30-40% cases, usual misses. And alpha fetoprotein compared to PIPCA2, it is less specific. It is around 60% sensitive, and specificity is almost around 50%. Whereas PIPCA2 sensitivity is relatively high and specificity is high, particularly in early tumors, small tumors. And of course, not all the SCC is going to produce alpha fetoprotein. This PIPCA2, in case of the, it is, whenever we combine both of the two, then sensitivity specificity can increase to 90%. And definitely, we'll order triple phase CT scan whenever the patient is having cirrhosis, when USG and tumor markers are normal, like this case, whenever there are multiple metabolic factors. And if there is family history of SCC, if there is pre-cirrhotics and fibroscan score is more than 15, and of course, if there is FIB4 is more than 3.5. So in all those cases, we can go for ordering the triple phase CT scan. In case of particularly early SCC is evolving, and if there is sudden weight loss, the weight loss is very high, other comorbidities are found, patient is going to be very bad, then definitely we should go for ordering this deficient.
Thank you, Dr. Girish. So I would like to tell that PIVCA, at least our experience was not very good, and there have been certain studies, one of them from South India, where they have pointed out that in HCC, PIVCA may not be suitable for Indian patients. And the study which we did at Gangaram Hospital, we found that the PIVCA level, cutoff level which has been proposed by the Western countries may not be validated for Indian, and we need a higher PIVCA cutoff, because we see it's to be sensitive but not very specific at those lower cutoffs. Regarding ultrasound being missing HCC, it's very common. So now it is proposed by some of the societies that ultrasound lyrides has come, where similar to the CT scan or MRI lyrides, we can also do lyrides in ultrasound, where we have 3 categories with negative, subthreshold and positive. And we also look at the quality of ultrasound. So first thing to note in ultrasound is there a lesion, and what is the quality of ultrasound? So if the quality of the ultrasound is good, only then we can confidently rule out HCC. So this is the algorithm which has been proposed by some, that if ultrasound is positive, obviously the patient may have, if the ultrasound shows SOL, the patient directly goes for CT MRI. If the ultrasound doesn't show SOL and the quality is good, only then we can be confident and we can repeat ultrasound every 6 months for surveillance. But in intermediate cases, for example, if quality is not good, or if the AFP is positive and still the ultrasound is missing, then we have to go for alternate modality. So quality of ultrasound is very important, as someone pointed out. So key message from the first part is, when cirrhosis is first diagnosed actively, please rule out HCC. The surveillance will be meaningful only after HCC has been reasonably excluded. Baseline evaluation in all cirrhotic patients should include ultrasound, AFP and PIVCA, as Dr. Girish mentioned. And ultrasound is operator dependent. So poor visualization, if it is there, then we need to go for alternate modality. And AFP may be normal in about 50 to percent cases, and PIVCA cutoff needs to be validated for India, and emerging biomarkers like GALAD and GAD are promising. Now coming back to our patient, we did a triple phase CT scan which showed a big lesion which was missed on ultrasound. And this was about 7 centimeter lesion, and also there was portal vein tumor thrombosis. So report of imaging is cirrhotic liver with mild ascites, large 7 centimeter right lobe lesion, which was LIRADS 5, and there was enhancing thrombus in main portal vein, right portal vein, and also extending to left portal vein. So VP4 lesion in the portal vein. So complete diagnosis was HCC, large lesion in right lobe with PVTT, inacil BCLC C1, cirrhosis decompensated obviously, and large varices, non-bleeder. So with this, first I would like to ask the audience. So this is a patient with decompensated MET ALD cirrhosis with large varices. Will you consider liver transplantation upfront in this patient in presence of PVTT? Any one of them? Any one of you? Liver transplant?
We should not consider it even if there was no PVTT.
No. Okay. Dr. Shantan?
Yes, sir. So at this current stage of VP4 tumor thrombosis, definitely no. So, but upfront transplantation we definitely not consider. But if we can adequately downstage it, and if the tumor biology remains the same with adequate surveillance, maybe we can consider in the future. So maybe we need to treat the liver along with the tumor, with the maybe with the currently combination of immune checkpoint inhibitors, and gradually we can do the surveillance and then decide. But now, no.
So excellent, Dr. Shantan. So this is our INASIL guidelines, which we said that no upfront liver transplantation in case there's PVTT. So, but there's data that after downstaging, some patients may become eligible. So this was the initial study done in 2020 from Dr. Soin's group, where they had about 50 patients with PVTT, and they, after successful downstaging using multiple modalities, they were able to show that these downstage patients actually fared equally to those patients who did not have PVTT to start with. Subsequently, there were two meta-analyses. One was published in 2024 and another 2026. And all of these are meta-analysis of observational studies, and which showed that in carefully selected patients, after effective downstaging has been achieved, then some of these patients can be taken up for liver transplantation, but further studies would be needed. So upfront liver transplantation is contraindicated in presence of PVTT, and priority is to control both the component, the portal vein tumor thrombosis, as well as we need to have recanalization and the tumor. And if there is a good tumor response, then liver transplantation can be taken up later on after a suitable waiting period to know that, understand the tumor biology. So this was the imaging in our patient. But so upfront liver transplantation is out. We can take up after downstaging. So what are the modalities? How would you treat this patient? So what are the treatment options now? Will you consider SBRT for the portal vein tumor thrombosis? And how will you treat that 7 centimeter large lesion in the right side of the liver, right lobe? And what will be your opinion on tear? So anyone from the audience?
We can manage the cirrhosis and varices with EVL, and then we can go for IO and SBRT.
Okay, so you'll combine IO with SBRT after EVL. Okay. So Mallikarjun?
Yes. Sir, again, it is depend upon the expertise available in particular centers. But what we are doing is tear for the liver lesion and SBRT for the portal vein. So that's what we are doing it, because we have not found good outcome with the SBRT alone and focusing on both liver lesion as well as portal vein.
So you are combining both?
Combining, sir.
Okay. Okay. So,
Ashish, the rate limiting step in your patient seems to be the tests of liver function. The rate limiting step in your patient seems to be the tests of liver function.
yes.
The albumin is low and the bilirubin is high.
So
there is some thought suggesting that if you could improve the vascularity to the affected part, you might be able to give an add-on therapy later on. So probably an SBRT for the PVTT to see if the liver function tests improve and then follow it up with the next sequential therapy.
Yes.
Because
Yes, sir.
I missed part of it, but I may consider doing a TIPS in this patient. And despite having PBTT, TIPS might help both the varices as well as the ascites and then manage the patient.
Okay, sir. We'll come to the tips part later. So there's good data now emerging for SBRT for PVTT. This study was done from AIMS, and it showed that we can achieve complete response in about 1/4 of the patients with SBRT, and it is a usually safe modality. But it can control both PVTT and as well as sometimes can achieve recanalization. Another study that is from Dr. Sareen's group at ILBS, where 46 patients who underwent SBRT and many of them also had PVTT, and there was overall survival benefit and the toxicity profile was acceptable. And so there's been this systematic review on SBRT. So overall response rate is about 50 to 70% in patients with portal vein tumor thrombosis. So for PVTT, SBRT is good. But what about SBRT for the liver lesions? So for a large liver lesions, what determines the feasibility? So tumor size alone is not the rate limiting step, but as Dr. Dharmesh Kapoor mentioned, that residual liver function as well as volume are important. And we need to understand how much would, if we give SBRT to the liver lesion, how much would be the radiation would be received by the normal liver. And also child B patient would have a reduced tolerance, and presence of ascites would further lower. So is SBRT feasible for 7 centimeter lesion? Technically possible, but it may be risky. So it would be good for PVTT, but for the large tumor which like our patient has, we cannot target both of them through SBRT. So we would need certain other modalities. We can treat the PVTT with SBRT, and we can use TARE in selective patients. And we also need to be worried about the adverse effects because our patient is child B8. Doing TARE alone is also an attractive option, and many studies have shown that in presence of portal vein tumor thrombosis, it can be done. It can target both PVTT as well as liver lesion. And if the liver lesion is unilobar, we can go at a higher dose of TARE, Y90 in these patients. So it is a good modality, but it is very expensive and sometimes prohibitive for our patients due to cost. So SBRT for PVTT is good for effective local control and sometimes for even recanalization. TARE is also good modalities, but no single modality fits all patients. Sometimes we need to combine, sometimes we need to individualize.
So just one point, sorry. So now in India we have 2 proton centers also, one in Chennai and in Mumbai. So now size is not a limitation. Even the 7 centimeter and portal vein can be dealt with SBRT through protons.
Okay, but the dose would be...
In fact, we can escalate the dose, and the liver sparing is more than 40% when we treat with protons.
Okay. So this was new to me. Now the next question is regarding portal hypertension. So Dr. Sareen already mentioned that he would like to do TIPS in this patient. What about beta blockers, EVL? Someone said that EVL would be done. So I would directly ask Dr. Amarjit, what is your opinion regarding how do you manage portal hypertension in these patients?
Sir, this patient falls in CTP class, so with portable thrombosis, better to consider AVL primarily to prevent further esophageal variceal bleeding, as the patient is a probable candidate for immune checkpoint inhibitors as well as the locoregional therapy.
Okay. So, what about tips? Your opinion?
Yes, sir. I do prefer considering tips in this patient, as tips may enhance the enabling of decreasing the CTP scores in these patients and improve the patient's quality.
Yeah. So, portal hypertension management, we obviously need to start beta blockers in these patients because this patient especially had a high risk varices, grade 3 varices. But in presence of portal vein tumor thrombosis, the portal hypertension increases further. So we may also have to do EVL as a primary prophylaxis modality in these patients. We have to combine EVL and beta blockers in these. What is the role of TIPS? So TIPS was generally considered contraindicated in patients with portal vein tumor thrombosis, but the concern was that it can lead to tumor dissemination. And also it was thought that it would be poorly tolerated. But recently, many studies have come which have shown that fully covered TIPS stent can be used. And recently, even Dr. Jaime Bosch's editorial is that TIPS can be used, and Dr. Sarin also said that TIPS can be used, but we would obviously need more data on TIPS in patients with portal vein tumor thrombosis. And coming to the last part, this is about systemic treatment. We would require systemic treatment. And this patient already has large varices. So, and also he is CTP B8. So between lenvatinib and immunotherapy, which one would you choose? And if you are choosing immunotherapy, obviously bevacizumab-based therapy would be out. So would you choose for atezo monotherapy, stride regime, or ipi-nivo, which we have seen data? And there are also certain emerging drugs. So, but we also need to remember that the phase 3 trials, registration trials, did not involve VP3 patients. So can we still go for ipi-nivo or stride regime? So before Dr. Sunil answers, anyone from the audience, which systemic therapy option? Single therapy, atezo. Dr. Sunil. Mike.
This patient already has a child B cirrhosis. So combining IO plus anti-VEGF or IO plus IO would be difficult as an initial therapy. Given the choice, if you want to use IO, then the IO plus IO would be better because the bevacizumab anti-VEGF will be a problem with the large varices with red colored signs. And among the IO plus IO regimes, the STRIDE and ipi-nivo, I think the trials have not included those patients who have PVTT. So we need to combine therapy with immunosystemic therapy with a local regional therapy for PVTT also, because alone PVTT will not be, a systemic therapy will not be effective in this patient.
So I think, Ashish, the theme of your tumor board was very good, fragile liver, time. So we give the SBRT, look at what the tests of liver function are doing, EVL in the background. If you have a curative intent for any patient with HCC, which we should all have, we should be a little cautious in tips for PVTT, because portal vein tumor thrombosis is not synonymous with hepatic vein tumor thrombosis. Many of us believe in that philosophy, though it's not universally adopted. If this patient's tests of liver function improve, probably initial period only atezo, followed by atezo plus bev. When your baseline tests of liver function are bad, it's difficult to tread on the path of IO-IO. And ipi-nivo, already mentioned earlier by Dr. Kank, you have an initial Kaplan-Meier curves which are bad. Only later on it gets better, and there is definitely increased toxicity and mortality. So probably this should be discussed in NDTT, but first we should do the SBRT, wait for the LFTs to get better, and then only plan some kind of a systemic therapy. So that will also be benefited by the abscopal effect.
Thank you. Okay, modified LB score. So due to paucity of time, I would like to conclude. I'll not cover. So there are many systemic therapy options now available, which are first line. But for this patient, bevacizumab options are out. And then in India, camrelizumab is not available. So we have durvalumab, ipi-nivo, and tislelizumab monotherapy. Stride we have already heard. This is Tremi-Durva. This is the Himalaya trial. And ipi-nivo also we heard. This was good. The overall survival benefit showed was good. But there was initial poor survival for at least 12 months in the combination group, and then the survival curve separated. This is tislelizumab. The study was published on JAMA Onco in 2023, and it achieved good overall survival, which is non-inferior to sorafenib. Currently, it is available in India by one of the pharma company. The cost is 1 lakh per cycle, but again, it is almost equal to TKI is in the response rate. So my take-home message is always rule out HCC at the first diagnosis of cirrhosis, because surveillance will be meaningful only once you have ruled out HCC. And we must understand the caveats of ultrasound, AFP, PIVCA. Portal vein tumor thrombosis fundamentally alters prognosis and management, so we need to treat it very aggressively, and only then liver function would improve, as Dr. Dharmesh mentioned, and loco-regional therapy must be liver sparing, and upfront liver transplantation should not be done in patients with PVTT. SBRT is effective for PVTT control even in advanced disease. TARE is feasible in selected patients, but may be risky in CTP-B patients with ascites. No single modality would suit at all, so we need to discuss this in MDT. Portal hypertension management is integral in these patients. We have to discuss this with the patients. Can TIPS be done, only EVL, and systemic therapy should prioritize safety. So when patients with large varices or CTP-B patients, we need to be very careful. And treatment choice must respect the liver reserve. Thank you for your patient hearing.
Thank you. We need to close the session from the chairs. We close the sessions and we'll have a group photo. We'll request Dr. Hinchul Rim and Dr. Unsek Kang to come to the dais for the group photo, sir. Just wait, the photographer, please just wait. Let sirs come to the dais. And as we are having a group photo, we'll announce the next session. Swayambhu.
So we will move on to the 16th session on drug-induced liver injury. And for this session, I would like to call upon the honorable chairpersons, Dr. Jaydev Ray from Sri Aurobindo Seva Kendra, Kolkata, Dr. Shivraj Afzalpurkar from Nanyappa Hospital, Davangere, Dr. Pranav Maiti from ILS Hospital, Howrah, Dr. Sanjeev Kumar from Das Gastroenterology, Patna, and Dr. Saurish Roy from Apollo Multispeciality Hospitals, Kolkata. Request all the chairpersons to commence with the sessions, please.
Hello. As we are running short of time, only one of my co-chair is joining me. We start a very important topic. We always ignore to elicit the history. Let us see, invite Dr. Robert Fontana. I had listened to him yesterday also, how we can deal with the CAM. It will be experience management strategies, please. Dr. Fontana, please.
Great. Well, thank you for the invitation here. I'll go ahead and get right to it. These are my disclosures, and what I'd like to very quickly review with you is our experience in the U.S. with the Drug-Induced Liver Injury Network, what we're finding on trends over time, in particular herbal and dietary supplements, and then briefly some issues around clinical management. So as we all know, idiosyncratic DILI is a rare cause of acute liver injury, but it's important. Overall incidence in the whole population is about 10 to 20 per 100,000, although the incidence with an individual drug may be only 1 in 5,000 to 1 in 10,000. In the US, it's the second most common cause of acute liver failure after acetaminophen overdose, and it's a real problem in drug development in terms of preventing drugs from moving forward for human use due to toxicity. And fundamentally, the problem we all have is the clinical variables such as the dose, the duration, and simple host clinical factors do not predict who's going to get idiosyncratic DILI. So in this context, over 20 years ago, in the US, we were able to get some funding to prospectively study this through the Drug-Induced Liver Injury Network to identify the causes and outcomes in both children and adults. And this is a network that I've had the privilege to be a part of as the co-chair, along with Paul Watkins and 6 other major medical centers in the US. And so what are we seeing? So we have 20 years now of data. And all along, antibiotics are the most common cause of drug-induced liver injury that we're seeing. But you can see the proportion of green over time is going down. What's going up in place of that is herbal and dietary supplements. It went from 7% early on up to nearly 25% of what we're seeing currently. And in addition, as per our prior session, as immuno-oncology is coming more and more to the forefront in clinical practice for multiple tumors, we're seeing many more cases of those drugs causing clinically significant drug-induced liver injury. So this is a little finer granular detail. Augmentin is the most common drug that we see, and that's consistent over time. Bactrim or trimethoprim sulfamethoxazole is pretty constant over time. But in the US, INH is largely used for TB prophylaxis in healthcare workers, not active TB, where we're definitely seeing a downtrend in that, also because there's alternatives now recommended by the CDC. Nitrofurantoin can cause an autoimmune-like hepatitis. We're also seeing a decline in that. But as I mentioned, immunotherapy and some of the herbal and dietary supplements are actually on the rise. And interestingly, another network that I've been involved with for many years, we also saw that herbal and dietary supplements were going up as a cause of acute liver failure in the US, whereas INH and nitrofurantoin were actually going down in parallel. Now, we've had the good fortune of working with a collaborator who's an analytical chemist. And so in our patients who take these herbal and dietary supplements, we're very interested to know what is the putative hepatotoxicant. And we have a panel of known hepatotoxicants that we look for, and we get the products from the patients and we analyze them. And what you can see here over the different years of the study is that green tea extract was a common ingredient in many of these products over the 20 years. But ashwagandha is definitely on the rise, and then on the far right, turmeric-based products are also on the rise in the US as identified in these hepatotoxic products. So turmeric, you're very familiar with this ingredient. It's part of the Asian food ingredients. But it's what we're seeing in the US is not through food consumption, it's through very high doses of these manufactured supplements. This became very popular during COVID, and it hasn't really gone away. So there's a lot of lore that turmeric will make you feel better and help treat arthritis and so on and so forth. So a couple years ago, we presented a paper of 10 patients with clinically significant acute liver injury. Majority were female, Caucasian, median age was 56, and they were quite ill. They had an ALT of 1,000, and many were jaundiced. The duration of use of this high-dose turmeric products was, as a supplement, was 86 days. So this didn't happen right away. 50% were hospitalized, and actually one patient died of turmeric hepatotoxicity. And quite interestingly, the value of collecting DNA in these patients, we found an overrepresentation of an HLA B3501 in the cases versus the incidence in the general population. So this appears to be a risk factor for turmeric hepatotoxicity. And when we did the analytical chemistry on these products, we didn't see a whole mixture of ingredients, but what we found over time in the US is that pepper and pepperine is being added to the turmeric, and it's been known that pepperine will increase the bioavailability of turmeric in the body by up to 20-fold. So it may be that there's a component of dose with pepperine as to why we're seeing more and more of these cases over time. So what are we doing going forward? We're very interested in this from a public health perspective, so we're continuing to collect cases, analyze the products, et cetera. And we've actually set up a prospective FDA surveillance collaborative study where what we see in Dillon, we're looking to see around the country if that's also being reported nationally. We're continuing to do this ingredient analysis, but not just to identify the ingredients, but to try to identify the specific hepatotoxicant, and we're developing some in vitro assays to further study that. And then the genetics, as I showed you, is quite interesting here, and this HLA-B3501 is not only a risk factor for turmeric hepatotoxicity, it's also for green tea extract hepatotoxicity, Garcinia cambogia, toxicity, and polygonum, which is a leading cause of herbal toxicity in China. So clearly there's something about this particular HLA allele that's very important that we're going to study further. Now, we're also studying pathogenesis in a more global way, but genetics is a big part of our focus with the low incidence of this entity in the general population. And what we believe and why genetics may be important is that many people take the drugs or herbal and dietary supplements on a daily basis, and they do fine. They never have any liver issues whatsoever. And why is that? It's probably because they're metabolizing the product and excreting it through the liver or kidney in a safe pathway. But in some individuals, we hypothesize that they may convert the primary product into a hepatotoxic derivative that then can cause direct liver cell injury or, more likely, activate the immune system and the adaptive immunity, which is why patients oftentimes present 1, 2, or 3 months after they start taking the drug and then end up with the hepatitis. So that's our working hypothesis. And to further explore this, we did GWAS genotyping in all of our cases. And after we got to 2,000 consecutive cases of all different drugs, all different ages, and so on, we then looked at the GWAS profile of these DILI patients versus population controls. And lo and behold, we did find one single SNP, which was a susceptibility factor across all drugs. And it's in a gene called PTPN22. And the odds ratio was 1.4, and it was a risk factor across all drugs and all ethnic groups, which makes us believe that this is a bona fide real risk factor. And you may say, what is PTPN22? Well, it's a cytoplasmic protein that's found in lymphocytes that basically inhibits your T cells. And this particular polymorphism is associated with reduced activity of PTPN22 gene. So in other words, you're basically allowing your own immune system to be overreactive, perhaps to the stimuli such as a drug or other neoantigen. And actually PTPN22 has also been implicated in lupus, rheumatoid arthritis, and other autoimmune diseases. So it makes some biological sense as that this may be a bona fide risk factor for idiosyncratic DILI. Now, in addition to that, what we've been looking at the genetics on these cases, we don't find one HLA allele that's associated with all drugs, but we find drug-specific allele associations, as they've shown in this slide here. They're different for augmentin than flucloxacillin, than cancer treatments, and so on. But it's interesting that it's consistently class 1 or class 2 HLA alleles that we find associated with susceptibility to developing DILI compared to either treated controls or population controls. So what are we doing with all this information? It's hypothesis generating, and so we're continuing to do these genetic analyses, but we're actually going to take it to the next level because, as you know, we can now do whole exome sequencing, and we're going to probably be starting that in the next year to look at all of these cases using that technique. We obviously need more cases, both in the US and worldwide. We'd love to collaborate with others to try to get the sample size up for these genetic association studies. And with some of the more common agents, such as augmentin, we're actually finding a combination of SNPs, and a polygenic risk score may predict susceptibility. Obviously, the intracellular mechanisms are going to take a little bit of time, but we have some ideas on how to approach that, particularly with HLA binding with drugs. Now, in terms of clinical management, what do you do now? You first have to have this in the back of your mind as part of your differential diagnosis when you're seeing someone with acute hepatitis. But first, obviously, exclude all the other causes, acute hep A, hepatitis E, alcohol, and all the other things we've been talking about in this meeting. But if you have someone with suspected drug-induced liver injury-related acute liver failure with an elevated INR and mental status changes, those patients should be particularly get a lot of attention because they have a very low likelihood of spontaneous survival. And this is true here, US, Europe, and so on. 30 to 40% spontaneous survival, meaning those patients need to be urgently evaluated for liver transplant. We did do a study several years ago, as you know, looking at N-acetylcysteine for non-acetaminophen acute liver failure. And when we looked at the subgroup who had idiosyncratic DILI, there was a statistically significant improvement in spontaneous survival, particularly in early stage encephalopathy patients. So I think NAC is something that we should be considering in all of these DILI-related ALF cases. In addition to that, the treatment, as you know, is nonspecific. Fluids, antipyretics, antiemetics, and so on. But we do consider steroids, particularly for patients with drug-related eosinophilic systemic syndrome, those who have severe hypersensitivity features right from the get-go, and more patients who have an autoimmune-like phenotype with confirmation on a biopsy who are not improving after suspect drug use. There's more and more data to support steroid use. I lastly want to finish with this new score that we just published in CGH. We looked at the acute liver failure patients. We had 305 with drug-related acute liver failure, idiosyncratic, and we looked at 3-week outcomes. And again, survival is poor in this group in the absence of transplant, 36%. And we came up with a model looking at initial baseline features in bilirubin, INR, more advanced encephalopathy, more pressors, again, a sicker patient. But also, interestingly, the patients with herbal and dietary supplements did the worst. And I think this may be useful to you as you see your patients, that those patients are particularly of concern. And we showed that this new score actually worked better than the MELD score and the King's College criteria. And we're in the process of getting this up on a website so that anyone can use it worldwide to help with prognostication. And you may say, what were the herbals that caused problems in the US leading to acute liver failure and death? Ashwagandha, green tea extract, and hydroxycut. So to summarize, DILI is a rare but important cause of liver injury worldwide. We all see this. The agents may be different, the underlying diseases are different worldwide, but it is a real phenomenon. But it's difficult for all of us to diagnose because we don't have a confirmatory blood-based biomarker. In the US, antibiotics are the leading cause of DILI, but there's multiple drugs, over 200 agents that we've enrolled just in our own database. But there's important trends that we're seeing, reduction in INH and nitrofurantoin over time, but increase in HDS and the checkpoint inhibitors as well. Steroids, I don't have time to go into it further, but there is a role, I think, in a selected subgroup of patients. And obviously checkpoint inhibitors included. And then I'm hopeful that another group will be able to validate our findings on whether or not herbals really are associated with the worst outcomes with idiosyncratic DILI ALF patients. And then as we continue to unravel the mechanisms here, clearly we're on to the adaptive immune response being part of the pathogenesis of idiosyncratic DILI. We need to further understand, though, what are the molecular mechanisms leading to that association, and we're in the process of developing some in vitro biomarkers for use in humans. And lastly, I want to finish with this very important resource that you're probably familiar with, which is the liver tox database. It came out of the Dillon Network and largely single-handedly from the efforts of Jay Hoofnagel, who many of you may know from the NIH. And it's really a wonderful resource. There's over 1,200 drugs that are cataloged with the phenotypes, PubMed references, histology, cases, and so on. So certainly feel free to use it. It also gives you a likelihood of how many cases have been reported in the world's literature. And the nice thing about this is that it's continuously updated. And there's more and more chapters being put in there on herbal and dietary supplements. So certainly that's a tool for you to consider using in your clinical practice. And I'd like to thank all of my colleagues in the Drug-Induced Liver Injury Network. I'm merely a messenger here. This has been a huge amount of work with many of us involved for over 20 years. And that was us just recently in Washington at our last meeting. Thank you.
Thank you, Dr. Pontana. Please be seated with us. It's my honor to invite the next speaker, Dr. Harshad Devar Bhave, to hear the Indian experience from him. Dr. Harshad, please.
First, I would like to thank Akash as well as Dr. Goenka for the kind invitation. And my task today is to talk about the complementary medicine-induced liver injury with regard to Indian drug-induced network. And this is the outline of my talk, a little bit of background, followed by a couple of case presentations and causality assessment challenges, the geographical paradox, and then final conclusions. Now, the herbal and dietary supplements, or in India, it's complementary medicine. It's ingrained into the social life of the population, as well as healthcare, healthcare. And in India, it's about 70 to 80%. It's increasing. In China, it's up to 95%. And even in technologically well-advanced countries, you find that more than 50 to 70% of healthcare is associated with herbal and dietary supplement use. So with regard to drug-induced liver injury caused by traditional and complementary medicine, you'll notice here even the advanced countries is about 50 to 70%. In Japan, 17.1%, and in Indian network, it was 13.9%. Now, what are the top 5 causes of the drug-induced liver injury producing drugs in India? By far, anywhere in the country, more than approximately 50%, it's because of anti-TB drugs, because of the inherent potential toxicity of the anti-TB drugs. But you'll notice that the second commonest cause is actually complementary and alternative medicines. And throughout the country, it continues to remain the same. Now, when you compare both complementary medicine as well as prescription medicine, and that includes anti-TB medicines, you'll notice that the severity is slightly more than the prescription medicine. Fortunately, the mortality is about the same. It's about 13.6% with complementary medicine and 12% with the prescription agents. In that 1,288 patients, and about 13% were due to complementary medicine, the ingredients we could identify in only about 1%, one patient, and that I will mention a little later. So this is always a challenge because it's a polyherbal formulation that patients take in this country. Now, what are the comparison of disease severities? Because you know that drug-induced liver injury can mimic all forms of liver disease. And I mentioned about this just now. The mortality, 13.6%. But even with mortality from anti-TB drugs is about 14.6%. What about drug-induced liver injury causing acute liver failure? You find that mortality from complementary medicine is about 12%. Then mortality from anti-TB drugs is about 16%. The proportion of anti-TB drug is about 12%. Whereas the mortality remains the same. So it does not produce more severe liver injury than prescription medicines. But however, we have noticed this, and Dr. Sarin is here. We did this Asian study for patients from at least about 50 centers throughout the Asian countries. You notice that drug-induced liver injury due to complementary medicine constitutes to about 7.5% of drug-induced, or 7.5% of ACLF. And the mortality, fortunately, is about the same between anti-TB drugs as well as complementary medicine. Now, I'm thankful to my postgraduates who looked at the 6,000 odd patients with drug-induced acute liver failure published from India. And you'll notice that only less than 1% of patients were due to complementary medicine. So, by far the commonest cause of acute liver failure in this country is anti-TB drugs, and complementary medicine constitutes to less than 1%. Now, I'll start off with this case, which is very illustrative with the challenges that we encounter with drug-induced liver injury. A 50-year-old lady had developed jaundice, nausea, itching, hepatomegaly. All viral markers were negative. And this is what she took. She took these drugs for about 6 months, and this included several tablets and other concoctions. And I've listed the multi-ingredient formulation here. You can read through it. But you'll find that each of these had about 9 one of them had 9, the other one had 8, and the one that had 8, Punarva Vashtakvati, also contained Tinofolia cordifolia, that's Giloy, as well as neem. But when she came to the hospital, she already was quite advanced into the disease, bilirubin of 28.5 and INR of 1.9. And 10 days before, she had gone to various hospitals with the LFT that's just described. And then over a period of about 2 months, we gave her steroids, and that's what we do in India. We give them steroids. Surprisingly, they do quite well, and over a period of 2 months, she normalized. Now, as I'll mention to you that 57 ingredients were, this is what we counted, 57 ingredients were listed. So how do you incriminate one ingredient as causing drug-induced liver injury? So it's quite a challenging aspect with regard to causality. What we also did is we took these samples and sent it to the US, and I'm very thankful to Ikhlas Khan and his colleagues. We did mass spectrometry, and then lo and behold, you find that some of the ingredients were not even listed. So for example, this Withenia somnifera or ashwagandha, as Dr. Fontana just mentioned. And with regard to complementary medicine, because they take these polyherbal supplements, causality assessment becomes very difficult. Now, regarding ashwagandha, ironically, the first ashwagandha report was reported from Einar Bjornsson and the Dillon colleagues and published in Liver International, following which Cyriac Phillips published his series of about 8 patients. And then recently, it was about, this is from China, as well as they looked at the conglomeration of cases throughout the world. And finally, just a few months ago, the Netherlands pharmacovigilance authorities then put a ban on using this ashwagandha in India population. And I'll go through these reports below. This is the 14 case reports published by Einar Bjornsson. You find that both men and women developed it, predominantly hepatocellular. Cyriac published it a few days later, and that was 8 patients, and you'll find predominantly males in India. It was acute hepatitis, which cholestasis was more common. 1 person with acute and chronic liver failure died, but fortunately everyone improved. And this is from Netherlands, and you find that 12 patients were reported to Netherlands Pharmacovigilance Committee, and that this 7 was due to ashwagandha monotherapy, whereas 5 was due to multi-ingredient, and fortunately all of them recovered, and the time to recovery was anywhere from 1 week to about 3 months. And then, not just that, even WHO pharmacovigilance, the VIGI-base, has about 25 hepatotoxicity reports from ashwagandha that is reported to VIGI-base. So ashwagandha as a monotherapy as well as a polytherapy, it produces drug-induced liver injury. Now this is another patient, and you'll find here, this is 56 ingredients. And then when you listed it, you see this entire 56. And which one of these 56 do you incriminate as causing drug-induced liver injury? So what you can do is look at those that persistently comes up, and I've listed this ashwagandha as well as Tinospora cordifolia, which probably is the most commonest cause of complementary medicine drug-induced liver injury in our country. And I've given the entire Indian experience now. Now it was Abha Nagral, during the COVID time, he first reported on 6 patients in patients who had cirrhosis. It produced ACLF. Followed by letters to the editor, and I think this is common. Once it's reported, then everybody says, oh, I have seen a case, and they start reporting it. So this was 9 patients, fortunately no mortality. This was followed by Kulkarni as well as Cyriac, and they reported 43 patients, and again, most patients that had acute and chronic liver failure, mortality of 14%. And then another study from Bombay as well as throughout the country, not published yet, but only in the abstract form, of 55 patients, and then you find 20% mortality. What you also find, and I have summarized the whole thing below, so overall you have 121 reported cases, more in female than men. Mean bilirubin is about 13, AST/ALT more than 10 times. But you'll find that the ANA positivity or the signature, it produces some kind of drug-induced autoimmune-like hepatitis. And you'll see in about 55 to about 70% of patients. And only in patients who have an underlying cirrhosis does it produce acute and chronic liver failure. And finally, a case here, and this is only in an abstract form published from SGPGI Lucknow. This is a husband and wife combination. Both of them had diabetes. Both of them took what is this Rishyagandha, as cousin of Ashwagandha. And you find it's Withenia coagulans, and they developed significant liver injury. Both of them underwent liver biopsy. Both showed drug-induced autoimmune hepatitis. Both of them received steroids, and then finally it took about 5 months for both of them to get better. But you'll find Withenia coagulans or Ashwagandha has not been reported to produce liver injury. So you find many drugs in floating around in our population which produces liver injury but have never been reported. So what are the characteristics of the top 3 drugs then in our country? So I've listed this as Tinospora cordifolia. It produces both idiosyncratic as well as toxic. People think if 1 tablet can make me better, why not take 4 tablets? The unique feature, as I mentioned, the signature is drug-induced autoimmune like hepatitis, and the mortality, especially in those who have underlying cirrhosis, is about 17 to 20%. The next one is Ashwagandha. You have about 60 cases now reported. Again, the mechanism is idiosyncratic as well as toxic. It damages the DNA and reduces the glutathione, and that's how it produces liver injury. The clinical features are all across the board, but cholestasis is probably more common than hepatocellular jaundice. And mortality is well known, but especially in those who have underlying chronic liver disease. And Dr. Fontana mentioned about turmeric. Turmeric, we do not see much more often at all. That's because we use it as an ingredient in our food, but we don't take it in large quantities, and it's not mixed with pepper. Now, this is again a publication by Phillips, who, as you know, is a crusader against drug-induced liver injury caused by complementary medicine. And you'll find almost 13 of them listed here. And these are, if you can see, all of us have encountered this at some point or the other. But what is surprising is this. There are about 97 reports, and all of them have been reported from Western countries. Not one of them you can find that has been reported from India. So thereby suggesting that there has been some kind of a reporting bias, as also under-reporting from our country, and that I think needs to be taken care of. So with regard to all the drugs that I mentioned, this is Donald Rumsfeld quotation. So we have known knowns, that is, we know Ashwagandha and Tinospora. We know unknown unknowns, the unknown unknowns as well as unknown unknowns. So there's vast amount of drugs as well as complementary medicine that are there in the population. They produce jaundice. We do not know how they produce jaundice, what dose they produce jaundice, and also causality assessment, as I mentioned to you, because of the sheer polyherbal way in which people take these drugs produces certain challenges. So with regard to management, patient non-disclosure, and all of us have encountered this. They just refuse to mention that they are taking these drugs. So it requires an extensive detective style questioning. So it takes a lot of time. You require a medical Sherlock to make a diagnosis sometimes, because you really need to spend a lot of time. And with evidence-based treatment, we only know that corticosteroids really have helped patients because with Tinospora cordifolia, because they had a signature pattern of drug-induced autoimmune hepatitis. And most interventions, including all that I have listed, including NAC as well as plasmapheresis, are just anecdotal. So in conclusion, herbal and complementary medicine-induced drug-induced liver injury in India is the second commonest cause of drug-induced liver injury in India. It's the most common cause of drug-induced ACLF, not anti-TB drugs, and is a rare cause of ALF in India, as I mentioned, less than 1%. Tinospora cordifolia and Withenia somnifera are the 2 top drugs that produce drug-induced liver injury due to complementary medicine. And as I mentioned to you, most of these reports initially have been published in the West. Subsequently, they have been published in India. But so there's some kind of a geographical paradox, because I think we do not report these patients when we see them. And then finally, because of the sheer multi-ingredient nature of these medications, causality assessment becomes challenging, because TILI does not have a signature pattern. And because of the lack of hepatotoxicity reports, it just goes underreported. So, and finally, because Tinospora cordifolia produces drug-induced autoimmune-like hepatitis, corticosteroids are the drug of choice in these patients, regardless of whether they have acute hepatitis or drug-induced acute and chronic liver disease. Thank you.
We can have some question before the next session. Dr. Sareen, please.
Yeah, very enjoyable. I have some comments for Dr. Harshad. There is a difference between a dead animal and a live animal. And the way Ayurveda was developed was for live plants and live herbs. What we are using are converting these herbs and their cytokines and their juices and their blood, the plant blood is the juice, into some medicines. And for centuries it has been used. For example, you take ashwagandha. And ashwagandha is a very useful plant for centuries being used. And the way the toxicity is, because I analyzed all these 18 cases in some different capacity, all of them were based on, like the European, the Dutch reports, they were all based upon something where there was a contamination. The plant or the seed or the soil was very different. Even those with Philip were all those who had underlying liver disease, not with healthy people. So this is one comment. Similarly for turmeric, is used for centuries, 1500 before Christ. Turmeric is it was the molecule of the year on the Cell, 1994. But what you do is you just take out curcumin out of that, and that's not turmeric. So if you have live pure turmeric, it is the best anti-TNF agent in the world. You take a smoke puff, TNF goes up, and you take turmeric and it comes down. And these are huge number of studies from Richmond, Virginia. So that's my second point. Third is about Giloy. Giloy has 34 species, not Giloy, the Tinospora. Which type of Tinospora are we using? It is, we actually found 234 patients of Giloy toxicity because these were converted from Giloy into a product by some very famous people. So my message to you and to others is, before we say it is ashwagandha or it is Giloy or it is turmeric, we should look into live natural plant vis-a-vis a converted concoction of capsules or something. That's point one. And I therefore would like you as leaders to look into natural use of these products as food products rather than as a dietary, rather than as a medicinal product. This is my message to you. And to Dr. Fontana, I have a question. When do you do liver biopsy in a patient with DILI? And is liver biopsy helpful? Like there were papers where they said if there is more than 50% duct loss or there is a vanishing bile duct syndrome, you use steroids. So would you do a biopsy in your DILI patients, and is it recommended? So both to Harshad and to you.
Yeah, so the question was when to do a liver biopsy with suspected DILI. And I didn't have time to cover that, but in our network, we have over 3,000 patients now. Roughly half of them end up with an incidental liver biopsy, and it's largely because I think the clinician caring for the patient wasn't sure of the diagnosis. It's a clinical diagnosis. You have to rule everything out, but you're still not sure. So I think that's what drives the liver biopsies. Does it change their management? I don't know. I think if you find these autoimmune-like features on a biopsy with supportive evidence in the blood, that may then prompt you to consider steroids. But I'd say only for patients whose labs haven't been on a downward trend or improving. So I think there's a bias that we tend to biopsy sicker patients who are in the hospital and we're not sure what to do. But for the run-of-the-mill patient that you diagnose as an outpatient, never gets that sick, never gets jaundice, I'm not sure that a liver biopsy would change much. I don't know how it practices here.
The biopsy, as you mentioned, only in those whom we are not very sure as to what was the cause of a liver disease. I think that's probably the only reason we do biopsies. And then many times to understand the severity of the disease. The patients are, although they are few and far between, but when patients are listed for a liver transplant, and I know from colleagues down south, they tend to do a liver biopsy before they do a transplant. Dr. Sarin, your point is well taken. We have used it for millennia for these drugs. And as I mentioned, the mechanism is twofold. One is toxic, and you see when patients take these 4 different tablets, each of them contains the same drug. And I'm not sure how does a person remember that of the 6, one contains 8 product, the other contains 6, the other one contains 12, and many of them interact. So I think people so maybe there is a toxic level which they probably cross before they develop drug-induced liver injury. Per se, in patients who don't have underlying liver disease, you can get away. As I've shown you, most of the fellows who develop it have an underlying liver disease. Now, with regard to how do you identify, and we need to do more research? I think yes, but for somebody has to take it up. Probably the government has to take it up, and I bring this issue with China. Chinese also do the same. They are 95% of their medicine use is by complementary medicine, but they acknowledge the fact that it can produce liver injury. They do put in a lot of effort into finding out what the constituent or the ingredient that produces liver injury. I think that kind of openness is a bit lacking in our country. And Chinese they're not even the moment they know there's a problem, they just advertise to the whole world there's a problem. Please don't use these drugs. And they have journals which look at complementary medicine and publish their reports. So I think a combination of various factors probably will help us in advancing the knowledge of complementary medicine-induced, drug-induced liver injury.
Thank you. The last question from Professor Ghoshal.
Yeah, so my comment is whatever works will have to have side effect. Because the effect means these are multitude of effects, some of which are adverse effects. All the drugs that we use have side effect. Question is that what you are saying is right, it has to be known to the people, it has to be regulated, it has to be monitored. For example, homeopathy, if you read Organon and Metria Medica, is considered to be safe, but it doesn't work so well. Whereas Ayurveda, obviously it has pure ingredient, in combination will work, but regulation is important, and I don't agree fully that we don't report. We have got into the habit of reporting because of the busy clinician, they don't have time to report. So you are doing a good work, but more and more gastroenterologists and hepatologists has to do so that we get the report and then regulate through the government.
Thank you, Dr. Ghoshal.
Yeah, the message should not go from here that every one of us have seen the calamities and the bad effects of all these herbal medicines. But the message should not go that these are safe. And before that message goes, I will request Dr. Sareen to do a trial of comparing the two groups, the Ayurvedic medicine and the concoctions. So unless we prove that, the message here is that all these are dangerous and we'll have to be very careful.
Thank you.
I think
Dr.
we shift
Rohit, Dr. Fontana and Dr. Harshad. We'll move on to the next session, that is the panel discussion. I call upon Dr. Dharmesh Kapoor to conduct this panel discussion. The panelists are Dr. Woon Sung King, Dr. Amrish Soani, Dr. Ankur Jindal, and Dr. Manish Manrai. Are all panelists here? 4 of them? Yeah, audience. We'll call you for the photograph, sir.
Morning, everyone. In the interest of time, and Dr. Kuna has already told me we need to abbreviate this session. So the topic that was given to me was when the cure inflames the liver, checkpoint inhibitor hepatitis in patients with liver cancer treated with systemic therapy. So we all know that immune oncology agents are used in more than 50% of cancers in current day practice. And it's different when you are doing the pivotal studies than the real world experience. In the pivotal studies, the incidence of liver enzyme blips was reported only in up to 5 to 10% of patients, whereas in real world experience, it's almost 1 out of 3. And the injury which is occurring due to the immune checkpoint inhibitors in this context is called ILICI. So it is immune checkpoint inhibitor induced liver injury. So I would use this word in the interest of time. These are the various pathophysiologic mechanisms. So please understand that there are 2 different things happening. Dr. Kang very lucidly explained that one is happening at the level of the lymph nodes and the lymphoid tissue where the priming occurs, but mind you, that is for the CD4 lymphocytes. and the other effect occurs at the tumor site, which is primarily because of the effector cells or the CD8 cells, but many of which are exhausted. So that is also important to remember, that that's probably the reason that in the best case scenario, the IO agents are effective only in up to a third of patients. So you are dealing with two different classes of lymphocyte subsets. So one at the level of the priming and the one at the level of the tumor destructions. But the mechanism is that the tumor evades the human host response, and the immune oncology agents probably rev it up by preventing this pathway or interaction, wherein our own host immune responses are not effective against a given tumor. It's also worthwhile to remember that bulk of the experience came from malignant melanomas, which were metastatic, and non-small cell liver cancers, and it's only in recent years that we've started to use these agents in patients who've got underlying liver disease or who've got hepatocellular carcinoma. But mind you, these agents constitute almost 50% of the armamentarium in treatment of various cancers. So in the interest of time, this is basically an exercise in interpretation of tests of liver function in a patient who's on these systemic agents. So this is the story of a 55-year-old gentleman who's got type 2 diabetes for 7 years. He was diagnosed with MASLD 3 years ago. He presents to us with abdominal pain, early satiety. He does not have any remarkable clinical features. His tests of liver function are normal. The ultrasound suggested some liver observations, and therefore this was followed up by cross-sectional imaging. His performance status was 0, CPT A5, and ALB grade 2A. Now, just for this audience, the biggest challenge with the BCLC is that it is dichotomous. So that means if you have got very early or early, you are always PS0. That is certainly not the case. So oftentimes it's the test of liver function and the performance status of a patient which is going to define the treatment modality rather than the tumor morphology. So this is something which we must wrap our heads around. So we always think when we look at the BCLC classification that what you see on the left part of the algorithm is always a good performance status. That is certainly not the case. The endoscopy showed low-grade varices, there were no gastric varices, and he had mild PHG. So this is the imaging. So for any of the panelists, so do we think this is the baseline imaging? You can read the report. It's about a 12 centimeter large tumor involving segment 5, 6, 7, 8. You can see that the posterior segment of the right portal vein is attenuated. The right anterior portal vein is not seen. So Dr. Ankur, what would be the treatment of choice?
Yeah. This patient has advanced SCC, BCLC-C with portal vein thrombosis. So the first choice to me is the local regional therapy plus IO, followed by IO. So local regional therapy first with SBRT, if depending on the response, then IO.
All right. So you see the left lobe of the liver. So do you think it's safe to give this patient SBRT? So we should also not think of SBRT as a low-hanging fruit.
Maybe targeted SBRT to first the portal vein and then partial SBRT. Then.
All right, so he has got ascites, as you can see. So the answer to this, in the interest of time, is a systemic therapy. So what would be your choice of systemic therapy for a patient like this? Dr. Amrish?
Sir, he's a well-compensated patient with a low CTP score. So I will go for first-line management. He is having low-grade esophageal varices. We can give him Beva and Atiza combination versus stride regimen.
Right. So, point well taken. We chose to give this patient Atizo-Bev. And would you want any additional workup on this patient other than an upper endoscopy before you start the systemic therapy?
Cardiac.
Sorry, say that
He's
again.
a diabetic, so I need a cardiac workup.
Anything else? Dr. Manish? Nothing. Any other workup that you would do on any patient who goes on systemic therapy in your practice?
I would like to rule out occult V infection, so total anti-HBC would be part of my panel.
Excellent. Dr. Kang, you have any different protocol?
Yes, so for the patients we are planning to start atezolizumab, bevacizumab, we usually not only check the endoscopy, but we also check their blood pressure to make sure what their baseline blood pressure is, and also urinalysis to see whether this patient, because this patient has diabetes, I just want to check whether this patient has any proteinuria and also thyroid function.
Any thoughts on autoimmune markers at baseline? I mentioned briefly that he had ANA positive 1 in 40. Does that come across as odd to you?
Well, it's ANA 1 to 40, so it's quite low. So I wouldn't do any further evaluation for that.
Right. So points very important as practice points. Viral screening, anti-core total. The guidelines tell you that only prophylax those who've got surface antigen positive, but I think in a country like ours, we should also prophylax those who've got anti-core total positive. That's what we do, but this can be debated because it's very difficult when these patients have tests of liver function abnormality to have another variable. We must always use the urine protein to creatinine excretion ratios in patients who are on any VEGF inhibitors and also check their hypertension. So these are the things that we must teach every patient before we initiate these patients on treatment. So now coming to the core point. So this is what we did, baseline, a run-in period. This patient tolerated the first, second and third cycles of the A plus B regimen very well. I would like you to focus only on the tests of liver function. So you can see that the enzymes were very well till the third cycle, and in the fourth cycle, the ALT has started to climb up, and just before the fifth cycle, this patient's ALT has climbed up to about 5 times upper limit of baseline. So Dr. Kang, what we did was to wait another week and disrupt the 3-week interval of therapy. Would you do anything else, or what will be your approach?
For this patient, looks like he has a higher AST as compared to ALT level, and the bilirubin level, it seems like it's indirect bilirubinemia, and the creatinine level is starting to rise. So I would check for myoglobin and the urine analysis just to make sure, and also see whether this patient has any signs or symptoms of myopathy.
So the CPK was normal, the urine sediment was non-contributory, and oftentimes when patients have advanced HCC, it's very difficult to wrap your head around the AST to ALT because it's partly driven by the cirrhosis and it's to a very large extent driven by the portal vein tumor thrombosis. So I think, again, a very important message, because this comes from an expert's interpretation, that the tests of liver function tests, you always look at the worst value. So it's not necessarily that you continue to, think about what should be the ALT and what should be the AST. So it's about 5 times the baseline value. So it's not the 5 times upper limit of normal. So would your interpretation be any different? And what would you do for a patient like this? So we waited for another 1 week. The enzyme trend continued to be like that, and the bilirubin went up. So what would you do then?
So if we can rule out other kind of reasons, then I would suspect this patient experiencing immune-related adverse event, which is presenting as a hepatitis. So in this case, I would consider starting steroids.
Right. And what would be your protocol for starting steroids?
Usually we start with the prednisolone 1 milligrams per kg, and then watch this patient for up to about 3 days. And usually within that period, if the patient is responding, then we can just start thinking of tapering out. However, if the patient is not responding and is still progressing, then we might have to consider liver biopsy to make sure this patient has any other kind of reasons.
Right. So 2 important points. The guidance tells you that you should be starting dose of 0.5 to 1 milligrams per kilo. And second is that you do not always need a liver biopsy at baseline. You can do away without it. Your working diagnosis in this situation is that probably this is an IRAE, and that is producing a blip in the enzymes, and that is what we do. So in our unit, and we've been using these agents now for the last 4 years or so, we start them not on 1 milligram per kg, but we start them on an abbreviated dose of prednisolone, and that is the standalone agent that we use. And then this is what happened to this patient. So we continued to check this patient's enzymes. So one can be questioned as to why we did not follow the guidelines, but to be absolutely honest to this audience, that is what we do. So we start them on what is also called the Edison's dose of corticosteroids. That's what we do for our patients. And you can see the further trend of tests of liver function. So the enzymes continue to rise, and as you can see, they still remain 5 times upper limit of normal. So Dr. Ankur, what would you do at this stage? So I accept that you might criticize the unit for not giving the actual dose, but would you have done anything differently?
So in the low dose of the steroids, these enzymes are still high, so I will increase the dose of the steroids.
Right. And Dr. Amrish, you would do anything different?
I would like to increase, sir, at this point.
Right. Yourself, Dr. Manish?
Just probably try and increase the dose, sir. steroid to begin
Right.
with.
So what the unit did was to add mycophenolate mofetil in a dose of 250 milligrams twice daily. This is what we've been doing. So we were initially involved in the studies with the IO agents, and this was the protocol that we've been following. And then subsequently you find that this patient's liver enzymes, they start to settle. We have got some kind of a morbid fear of using corticosteroids in our population, not just in this particular cohort of patients, but also in our autoimmune hepatitis patients and also drug-induced liver injury. And that is for a host of reasons which one might not be able to discuss at this forum. But our generally starting dose of corticosteroids is this when the diagnosis is in doubt. Any one of you would have wanted to do a biopsy for this patient before starting steroids to prove that we are dealing with an immune injury, or would that be redundant?
No, sir, actually he's at the cusp of about grade 2 if you go by grading, so it probably is not required. Had it worsened, then maybe we could have gone for a liver biopsy.
So would you do anything different? Would you biopsy these patients?
I think this patient is responding to immunosuppressants, so I wouldn't recommend biopsy for this patient.
Would you have recommended a biopsy before we added mycophenolate mofetil?
No, I think I would just continue with without the biopsy.
Right. So we did exactly the same. This patient had a tremendous response to treatment, and as you can see, the tumor has almost reduced by a volume of 3. This is after 9 cycles. Now, in the interest of further management, would any one of you, now if you see the characteristics of this tumor, it falls well within the UCSF criteria. But however, we must remember that this patient had a PVTT. So the PVTT is gone. You can see that the anterior division of right portal vein is free now. And this patient has got a tumor which has shrunk by more than 50%. The alpha-fetoprotein values, I hope, projected well in the previous slide. So this was an AFP of 52,000, a PIVCA of 1666. And you can see that after 3 weeks of 9 cycle, this is 13 and 39. So would anyone be courageous enough now to push this patient for liver transplant, or what would be the plan of management for this patient? Dr. Ankur, you come from a transplant center. What would you do?
Yeah. The tumor was initially very large, and the portal vein thrombosis has now disappeared, and tumor size has also decreased. So I think we should continue the immunotherapy for a time being for 1 or 2 cycles. Then we repeat the image and then see if if it remains stabilized, then we push to transplant.
Sure. So probably that point is well taken. We should not rush into transplant. There should be a kind of a cool down period. The process of whether you would want this patient to be on a step down therapy before surgery is again debatable, but in the interest of time, we'll quickly move on to the next case. Again, this is a story of a MASH cirrhosis, which was diagnosed as a small HCC, but he was lost to follow-up, and then he presented with the symptoms, the typical African variety of HCC that we know of. However, his tests of liver function remained stable. He was albeit grade 2, performance status was good. He had grade 2 esophageal varices, short columns which are not bendable, no red signs, and he did not have any gastric varices or PHG, and the other markers were negative. So very quickly, any one of you would want to just have a look at this imaging and say what is peculiar to this particular imaging compared to the first one. So you see the various tumors. So this is a very bulky disease involving various segments of the liver. Let me please focus on the left side lesions also before anybody suggests anything radical. So there are multiple nodules, though this might not always 2 centimeters or more, but there is bilobar disease. So anything that catches you on this imaging? So I think the point I'm trying to make is what you see over here. So you see the biliary radical dilatation in this patient towards the periphery of the tumor. So this is what is something that one would want to highlight. So no 2 HCCs, even if the volume is same, are the same. So the earlier patient had a much more bulkier disease, but we did not have any biliary radical dilatation. But here you can see towards the periphery of the tumor, there is bile radical dilatation. Dr. Ankur, what would be your primary management plan for this patient?
I would consider the loco-regional therapy SBRT. Okay,
but this is bilobar disease.
Yeah, first target the large tumor in the right lobe, and then systemic therapy, followed by systemic therapy.
Sir, his bilirubin is normal, I suppose. If bilirubin is normal, I will
So
definitely go for.
Yeah, this is what his tests of liver function are. 1.58.
So I will go for systemic therapy.
Dr. Manish, yourself, what would be your thoughts?
That's probably systemic therapy, but we can also consider downstaging by some other means, though it's a metastatic disease, bilobar disease.
So I think I was a little surprised. So you can see that there is multifocal. Yeah, Ashish, yeah.
Will you not do biopsy in this? Because it was not.
Okay,
typical.
so biopsy to prove whether this is HCC or not.
HCC or a combination of HCC cholangio.
Right, so this was reported as LIRADS 5, point well taken, but we know that the proportion of patients with HCC, they can have biliary radical dilatation also. So this patient, for all practical purposes, does not have a cholangio, though you can answer that only on histology. And mind you, histology can also be deceptive because we are not studying the histology of the entire tumor. So we did not do a biopsy. What would be your plan?
This patient has multiple tumors, and also his liver function was LB grade 2. So,
Yeah.
And also this patient has portal vein invasion, I suppose. So in this case, I would consider the systemic therapy for this patient. However, from the CT scan, the sphageal varix was very enlarged. We can visually, it was visible. So in this case, I would consider not atezobev, but rather the stride regimen, because as you know, this patient is LB grade 2. You know, if the patient was in LB grade 1, then the atezobev would be more effective compared to sorafenib. However, this patient is at LB grade 2, so from the data, the benefit of the atezobev was not proved as compared to sorafenib for the LB grade 2 patients.
Right,
So-
and between the atezobev versus the Himalaya, what would be your preference?
For this patient, I would consider the Himalaya, the Dovatremi, the stride regimen.
Any particular reason for saying that?
Because this patient didn't have major portal vein invasion, and however, this patient's liver function was a little bit marginal. So although this patient was in Child-Pugh A, but his LB grade was 2, so I would suppose he would benefit more as compared to the atezobev. And also, the bevacizumab might also induce sphagovaricial bleeding. On the
Right,
course
so
of
the first
treatment.
patient had frank portal vein tumor thrombosis. This one didn't, at least on the imaging that I have projected here. And therefore, we treated this patient with atezobev. But you see that we have crossed the limit or threshold of giving the next cycle. And you see that this patient's tests of liver function continue to play havoc. His bilirubin has been going up. The enzymes are all over the place. We did a septic screen for him, which was negative. And then as per our unit, we started him on PRED 7.5 milligrams. In the interest of time, I would quickly go through the subsequent course of this patient. Enzymes continued to rise, as did the white cell count. And then when we did the septic screen again, he grew E. coli in his urine. He was treated with ertapenem for a week, and the vicelone or the prednisolone was reduced. And the test of liver function, they started to get better before they started to climb again. And then this patient, inflammatory marker and cultures were negative when we gave him the second cycle of atezobev. So basically trying to project that treating these patients as per the protocols might not always be very easy. There would be so many nuances to this treatment, but our unit's policy is that those who have got a bad test of liver function, for want of a better word, we would not be using the IO-IO combination. So stride we reserve only for those patients who've got pristine tests of liver function. So
Dr.
this is
Dr. Dharmes, you can take next 3-4 minutes time.
yeah, this is the CTCAE grading, which is done for all clinical trials. So this is the common terminology classification for adverse effects. Mind you, this is flawed. So this is not for HCCs. So please remember that our patients do not start with normal transaminases. So saying that they have got 3 times or 5 times is not really the case in this particular situation. Their test of liver function would always be abnormal. So just in the interest of time, the experience of the IO or immune checkpoint inhibitors in patients with HCC, especially the advanced ones, is recent. There are various reasons for which you might want to discontinue these patients from this treatment, and hepatitis is the second commonest reason for which you would discontinue them. Now, Dr. Wong, what is your thoughts on treating these patients with steroids? You said 1 milligram per kg. So do you go by the rule book, or do you think there are nuances to this treatment? So if you start every patient on steroids after you suspect IRAE, would you want to go with the full dose of therapy, or do you think you would have another protocol?
So your question was, if I start the patient on steroids, when would I stop the treatment?
Yeah, stop or add steroids. What would be your criteria for that? Would you stop steroids in this patient?
For this patient? Yes, he was responding to steroid therapy, so I wouldn't recommend maintaining the immunosuppressant, because we want to treat this patient with the IO drug. So I would start tapering out the steroids and then see whether this patient can be completely tapered out from the steroids and still maintain the safety. Then I would re-challenge.
Do you rerun your patients on autoimmune markers if you have done them at baseline? Would you rerun your patients with autoimmune markers if you have done them at baseline?
Yes, in this case, just for the differential diagnosis, I would just check the immunoglobulin G and other kind of the autoimmune markers.
Would you look at the exotic hepatotropic viruses like the CMVs and EBVs?
Such as hepatitis C virus.
No, the CMVs and the EBVs.
CMVs, yeah. If the patient was on the high steroids, then I would consider it CMV, but this patient was on low steroids, so I wouldn't really consider CMV at this moment.
Do you biopsy your patients before augmenting immunosuppression?
Before stopping the immunosuppressant?
Or augmenting?
Weaning? No, I usually don't do that. However, if the patient is not responding to steroids, then I would consider.
Yeah, so that's a very, very important point. If the patient is not responding, we should biopsy. So, yeah, so this is the real world experience on use of steroids. You could just take a note of this particular reference in the interest of time. Please remember that there are large databases which show that lower doses of steroids do as well. Our unit's policy is always to treat them with the adrenal dose. And does the corticosteroid therapy impair response to IO? That is the other question which comes to our mind. And I would refer you to this very, very large database from the Veterans Administration database, which is a huge population of patients treated with immune checkpoint inhibitors. Mind you, not all of them were HCCs, which shows that patients who develop IRAEs actually tend to do better, which is intuitive because we have been able to rev up their innate and adaptive host immune response, and therefore they probably do better. So these are the patients who have developed an IRAE. They tend to have a better survival. But mind you, there is a caveat to this, that only those patients who have continued steroids for more than 2 months, they are the ones who tend to do better. Those in whom we had to abbreviate the steroid therapy in the first 8 weeks of therapy, you could not. Other burning question is treating autoimmune patients with IO. The experience tells you that it is equally effective in patients who have got underlying autoimmune disorders. They might have more flares, but that apart, nothing. And I'll just lead you with this last practice point. So oftentimes we think that if we have treated our patients with IO and they develop the blip in the tests of liver function, it's very safe to stop that and start them on oral agents which are TKIs, but caution is recommended. And I would recommend everybody to read the LEAP-002 study, which was very different from the other seminal studies in this space. Thank you very much.
Thank you, sir. Would request all the chairpersons and the previous session speakers, Dr. Robert Fontana and Dr. Harshad, to come for a small picture, group photo.
Yeah, as the group photo is being taken, it's my proud privilege to go to the next sessions. And this is the most prestigious session of this conference. and this is first Bengal Liver Summit orations. And now I'll request the chairpersons, Professor Mahesh Goenka, who is the organizing chairman of this conference, and this gathering does not need any introduction of Dr. Professor Mahesh Goenka, who has made Kolkata in the map of gastroenterology of the whole world. And I request also Professor Premashis Kaur from Max Hospital, Ghaziabad, who was initially the director of gastroenterology of MAMC, Delhi, and ex-president of Indian Society of Gastroenterology, to chair the sessions and start the proceedings, sir.
Thank you, Kinsuk. Now it's my proud privilege to ask Professor Sareen to come and deliver this first BLS oration. We thought we'll start a series of BL oration for the future. I don't know whether it will be every year or every alternate year, but there cannot be any person better than Dr. Sareen to deliver the initial oration, which we are calling a Bengal Liver Summit oration. It will be injustice for me to even try to introduce Dr. Sareen. He's the most coveted, most honored hepatologist from India, who has brought India into the international scenario. He built up this big institute called ILBS, which he is heading for quite some time. And we all have been learning from Dr. Sareen over the last few decades. So I think in the interest of time, I would move on and request Dr. Sareen to deliver his oration. Dr. Sareen, please.
Thank you, Dr. Goenka. And thanks, Dr. B.N. Rao, to allowing me to take this talk before you, because I have the flight. So thank you for accommodating me. The topic given is actually very difficult, and it's the first time that I'm trying to look into the crystal ball for myself. I have no disclosures except to say I keep friends who never get intoxicated with laurels, and thanks Mahesh and Akash for this outstanding meeting. I wish I was there all these days. Liver, as you would remember, these are courtesy Adrian Rubin, Prometheus, the Titius, the Michelangelo, all of them thought liver was the major organ. And the major organ remained major and remains the major organ. I just trying to take you back. Ichor means feelings. And in Shakespeare, love, especially passionate love, whose rush cannot be easily controlled, resides in human liver. Remember, liver is also related to emotions. And don't let a girl or a boy hurt your liver. And also today in Africa, people will say, oh, you are my liver. They won't say, you are my heart. They'll say, you are my liver. So liver is central in love, romance, and life. And Eutychians and Babylonians knew how to look at liver, and liver was kept in the temples, and as you can see, gallbladder, it was used to peep at future. So liver has always remained the major organ for us to look, and what we know today as probably hepatoscopy was there, and haruspicy was the original way. The doubling time of medical knowledge was 50 years in 1950, and in 2020 it is 73 days. And therefore, to me, hepatology looks at crossroads. To me, after working a little bit in hepatology, I think I am at least still in the Stone Age, and we need a rocket speed. So what does the future hold for hepatology? Well, it will depend upon the questions we ask today. Is there a demand for hepatologists? Well, this is Roger Williams in his Lancet paper. The time between referral to a liver clinic and the first admission with cirrhosis or liver failure, the sick lot. You can see that the number of patients, they were never referred. Hence, we wait till the patient becomes sick. A dedicated hepatologist in the UK, as per Dr. Roger Williams, they required 1 per 1 million. Let's use that. In India with 140 crores, we need 14,000 hepatologists today, and we are probably 200 trained hepatologists. So there is a need for hepatology and hepatologists. Also, pediatric hepatology needs transitional clinics, and we need to grow them together. Second question, will fatty liver reduction reduce non-communicable diseases? This is future of hepatology. So I'm using this diagram to tell you the fatty liver is the fulcrum, and it is related to almost everything, including cardiovascular, respiratory, bone, renal, brain manifestations, endocrine organs, extrahepatic cancers, and the ALT should be less than 30 and less than 19 for every single disease mentioned in this diagram. And therefore, we need to see whether AI or something else will reduce the NCD burden. Can we achieve precision medicine and it will help management of fatty liver and CKM? This is the way we are diagnosing MAFLD today. Demographic, behavior, metabolic, and we find out major adverse cardiac events or liver events. We do screening, we diagnose using elastography, biopsy, and blood test. What the future can hold for us? Of course, genetic analysis. And for Indians, we have a new polygenic risk score. PNPLA3 is there, but GCK, SOD, ApoB, I'll show you how they are involved. Of course, you need to have gut microbiome, and you need to have metabolome and amino acid and lipids. We need to have DNAs, and we need to have newer methods of radiology. An active MAFLD will have increased levels of branch and amino acids, but progression will have decreased levels. So the way we are going to move forward in precision medicine is a huge unread story. This beautiful paper by Chen in JCI finds out the phenomic VAS, Phe-VAS, and he describes 7 subgroups. Low lipoprotein output in PNPLA3, so the fat is retained here, or you have a high normal lipoprotein output, which also causes a problem. I will not be able to go into details, but there are 7 endotypes. Now, does it affect us? So, low lipoprotein, you will have more of cirrhosis, steatosis, but less of myocardial and maybe more of diabetes. But high lipoprotein, you will have probably more of cirrhosis, but you also will have high HDL, which will change the whole readout. But you have 7 other subgroups, and some of them will cause more myocardial infarction, some more cirrhosis, but we are in the nursery stage right now. Let's look at what happens in India. We did a whole exome for about 1800 patients. Just to tell you, PNPLA remains both for males and females the most common, but we also have GCK, ApoB, SOD, and TM6, which is part of polygenic score, is much poor. So going back, precision medicine for India will determine which drugs will work for us and which may not be. So what are the future clinical trials? And this is from Jacob and Islam. So currently we do medicines which are effective, maybe 1 in 5. Precision will take us to maybe 40%, and personalize when you know the genotypes and phenotypes and do Phe-VAS. There is a place in UK called Crossbridge, King's Cross, which is highly specialized in personalized medicine. So our future trials would be, which will include both fatty liver, diabetes, cardiovascular. So we need basket trials for tomorrow. Future of gut microbiota is the question, and can our therapies depend upon that? So this beautiful paper in GI Physiology says increased intestinal permeability will increase the CVDs, kidney disease, and mixed health status. All depends upon the gut and the leaky gut. and the outcomes will depend upon that. And this is same true for liver disease also. So let's look at this. You have microbiomes which interact into the sinusoids with liver cells, or they will work in the circulation with immune cells, or they will work in the interaction in the lumen itself. Now you have to see which type of microbes are living, and can you change these microbes to change the liver cell health or the health of the immune cells. Remember, it is the polypeptides of the microbes which will change the way our liver diseases will develop or progress. So the future will depend upon testing leakiness of gut and gut microbiota based therapies, and I am happy Just is around, will remain the mainstay in hepatology, and India and Indians can probably lead this area. So this beautiful paper in Nature told you that an ingestible capsule can tell you from where the bacteria are taken. Today we are only taking the gut bacteria which come out in the stool. So here you have position and pH, time dependent capsules you can develop, and you can have 20 different locations, and you can say that yes, it is from duodenum, it is from jejunum, ileum and colon, and there would be differences between the stool and the ones which you pick up from different areas. This has been also developed now by IIT Delhi, and Indians can lead in this way. So for me, and I'm sure some of you, gut microbiome will depend and decide the next decade. And of course, extracellular vesicles, host and bacterial, can be a major game changer. I'll show you something which is an unpublished data of exosomes. Exosomes are readouts of the cells, whether it is hepatocytes or endothelial cells. So what we did was to develop from black carrot exosomes, and these black carrots we tracked into the animal where they are going in 2 hours or in 6 hours. So we are able to track that yes, these are getting not destroyed and they are used. And what we did was that these were used in animals first and then now also in human beings. They reduce plasma ammonia, improve cognition, they increase their increase in their good bacteria will inhibit the E. coli, Shigella and others, and probably can be used as a therapeutic agent. So exosomes and the cargo that they carry from and will take to which cell may be a huge potential future therapy. I'll switch on very briefly what I see for future. Can we eliminate hepatitis B? Today, I think we are at the cusp, there is a revolution. Let's say you have hepatitis B and it has in the nucleus CCC DNA. Current therapies are which inhibit the conversion from RNA to DNA, and you have nukes working here. But can you inhibit all the viral RNAs either by using antisense or by inhibitory RNAs? So the next generation drugs are the ASOs. I'll just give you the example, bepirovirsen, and 2 days ago they gave a big release on their 2 studies, and both the studies are extremely exciting. What they needed was to bring down the HbSAg should be less than 3000 international units. If you are less than 3000 international units, then ASOs can be very helpful. And of course, you have a series of siRNA based drugs. So what are we looking forward in the future? And this drug might get approval maybe this year. Today, the way we are treating, we are calling everybody, and this Lancet paper shows that most of the money in hepatitis B is spent on DNA, HbSAg, LFT, and the patients come and the small amount is used for therapy. But if you start treating everybody, the amount of money which is being used for drug becomes most important. So why not treat all? There can be huge debates, but I am giving you my perspective. We treat all HIV, all hepatitis C, all TB, but not hepatitis B. And if we start treating patients, all HbSAg positive, and just once do DNA and start treating them, maybe we will be able to achieve viral neutral or viral negative hepatitis B. And they can be used for bepirovirsen and other drugs. So every single death in hepatitis B should be a wake-up call for all of us and a reminder that hepatitis B control policies are imperfect and the decision on treatment has been delayed. So my plan and my goal is we should treat all, and I want to encourage you to test this theory. Future of liver biopsies, the NITs, the cell-free and circulating tumor DNAs. Liver biopsy will shrink. I just got the data of 2025. I think we did about 2,600 plus biopsies still, but I know they might shrink. NITs are two levels. One can be FIB4, but honestly, I find FIB4 very, very ineffective, very inaccurate, but still being used. Fibro, ELF or MRE will be used. But what they will tell you is how stiff the liver is, how much is the fibrosis, but they will not tell you why and what next. And for this, you need liquid biopsies at different time points. You need cells and the readout of cells. So this is the different stages. You will have cell-free DNA, you will have long non-coding RNAs or miRNAs or circulating RNAs. So non-coding RNAs, about 200 base pairs, are probably the best readouts of a cell. So you want to see steatosis, you will read which type of cells, you will do histones, you might do some of the histone complexes, and you might use microRNAs. So this is in phase in multiple centers in Europe. You want to do steatohepatitis, you might actually add cell-free DNA here. And let's say for HCC, you will use circulating tumor cells. The liquid biopsy will change, and all labs have to convert into liquid biopsies. You will have to see blood has to be separated, white cells and plasma. Every single hepatologist will have to change and start thinking of serial liquid biopsies. Coming back to exosomes as a readout of cells. Say your hepatocyte is under stress. The ASGO, ASGP positive and ASGO positive exosomes from liver, if they are more than 50 nanomicron, and we have published that, they will tell you the liver cells are dying and they are bad. These exosomes will give you an idea, yes, there is a liver cell death. Endothelial cells will have different. And what do these exosomes do? They will communicate to each other. They will communicate to each other and say, yes, hepatocyte is under stress. Now, can you take out exosome as a therapy? Yes. Today we are doing bone marrow, isolate the mesenchymal stem cells, or we take out from adipose tissue, or we take out from umbilical cord. Instead of doing all this, I can take out the exosomes from bone marrow or MSCs or cord cells, and I can use exosomes of these. Exosomes have the advantage that they are non-immunogenic, and they are the best cell communicator, and their cargo can be used to do readout of damage or regeneration. So our group is now actively involved into exosome as a therapy. I told you exosome for the plant as therapy for reducing ammonia, and exosome as a therapy as an alternative to MSC therapy. My few questions in this short time, all these are my questions, and that I want to derive future 10 years in this. Can I regenerate a failing liver? There is a deep jaundice, there is an acute liver failure or ACLF. So what I want to know is regenerative reserve. Can I diagnose the remaining liver reserve? Maybe, maybe not. Can this liver regenerate if I give time and I give support? Can I have new growth factors? And I must say, with all respect to Savneet, lymphangiokines, she has done incredible work in lymphangiokines. The paper is under review. How the lymphatics can work to regenerate before angiogenesis the liver. Bioartificial
xenoperfusion devices as ICU bridges, not as transplant, organoids and engineered liver tissue for auxiliary function, and iPSC-derived hepatocytes and BAL. I'm sure next decade will give us at least answers to some of these questions that I have. Transplant hepatology. In India, we lose about 200,000 patients and do about 5,000 liver transplant, 95% are living donor. India has 220 transplant centers. I hope by 2035 we will have 500. In 2010, I thought India should have 200 centers, and I am happy, a bit late. And for all of these, India needs hepatologists. This is from ChatGPT, AI, liver diseases and nutrition. Right now, there are about 165,000 health apps, and many of them are related to liver and they are being used. So I will not go into what the AI can do, but I'll just take from Mamta Bhatt's beautiful paper for machine learning tools for liver transplant and digital twins. So you have an HCC patient and he is likely to die based on them, and now you have a predict donor who has 30% or more fat, and they will do complete analysis whether with 30% also can this patient survive. So you will have a recipient and you have a donor, and you will identify the possible interactions and say, okay, 30% fat, no problem. My machine learning tool says you are okay. Are we there? At least we can start thinking whether the future outcome of transplant can be done. Can it improve the post-liver transplant management? Similarly, I have the digital twin, and it will tell you how it will change. And therefore, I can give you 30-day or 1 year and 5-year mortality risk using all those, and whether the liver cancer will come back or not. These are formative years for machine learning and AI. I'll now switch on to something else, and I'm very happy Dr. Reem is here. I don't know if you can recognize this genius. This is Kunio Kuda, the father of hepatology in at least Asia. And this is me, and this is 1986. What Kunio would do is 6.9 days he would work very hard, never stopping on 7 days, and just 2 hours in a week he will go for fishing, and he will take all his fellows with him. And for him, fishing was like prayers. Catching a fish and getting an idea was his best way of doing things. I would like to give tribute to my teachers, my very respected Professor B.N. Tandon, who taught me how to stand and walk. Kunio, one of the most amazing guys. His rounds would start at 7:30 and will go up to 11:30. He was the first to come at 6 a.m. and last to go at 12:30 in the night. I had the privilege of being with Sheila as well as Hans, amazing, and my unique mentor, Roberto Grossman. What was unique in all these? Dr. Tandon was in public policies. Kunio was a biochemist. He was never an MD medicine. He, Hans, was a pathologist but a molecular, and Sheila was an amazing clinician and scientist. But they were all hybrids. What India would need is hybrids. This is not to publicize the book, but hepatologists can do much more than just doing science. Future of hepatology in India is excellent because we are trying, and through this meeting, which made me learn and read, from reactive, ये patient बीमार है, इसको ऐसे ठीक करना है, no. We can be predictive, personalized and preventive. And Indian hepatology is best suited because we have clinical excellence, we have transplant gurus, we have Ayush, all Ayurveda, homeopathy in the best way. Good or bad, we can decide. And of course, we have public health leadership. India has AI, very good genomics and NITs. And one request to every hepatologist, be a pure breed as far as hepatology, and do not think it is a backdoor entry to gastroenterology. This is future tense hepatology. This is my slide, so please pardon if I have overdone or omitted. Interventional hepatology is a must, which I do. Endohepatology I learn. Critical care hepatology is my bread and butter. Immunohepatology, managing sepsis, the early markers in 45 minutes using digital microfluidics, oncogenesis, and of course, cholangio and HCC. To me, the next revolution will be on bile acids, and we do regularly 21 bile acids for our patients. Liver regeneration, modeling human liver and diseases and digital twins, humanized pig, US, mice and organs, and nano drug delivery, which bypasses the liver. So if you put a VEGF3 and a gold particle, the drug is taken away from the intestine into the lymphatics. We publish this. So you can bypass a sick liver by putting it onto a delivery device. Wes, we are waiting for HCV, HEV, probably Dr. P.N. Rao will tell us, and HCC. Hepatic hemodynamics is not just pressure, it is improving microcirculation of liver. How much pressure we require to perfuse a liver is absolutely untouched area. And of course, AI and ML as Blaise. And so many more questions for future tense hepatology. For me, hepatology has transformed me. It's a real translational science. Future will belong to liver. So start next generation sequencing of hepatologists. Make new hepatologists, make better hepatologists. This is the duty of all our teachers. ILBS has the National Liver Disease Biobank, and we are trying to convert everyone into a new area. It has liver innovations, virtual artificial reality, and yes, future belongs to those who give to the next generation reason to hope. And hepatology, I must say, future is hard to predict, but if you know your today and you ask right questions, maybe we can predict hepatology for tomorrow. But the best thing is yet to come, coffee. And coffee will remain one of the major food items for all of us. And thank you for allowing me to share some of my primitive thoughts. Thank you.
I sincerely appreciate and thank my friend Dr. Shiv Kumar Sareen for having delivered the most wonderful lecture, the first Bengal liver summation oration which has been awarded to him, and I'm sure he has shown us the different areas of hepatology which we should focus for the future development for this country. And I think we will try to become more innovative, more research-oriented, and also to be focused in different areas of clinical hepatology as per the pathway which we have shown. Thank you.
Thank you, Professor Sareen. While we honor him by the memento, I would request, I think he deserves a standing ovation for the masterly oration which he just delivered.
I think we will all keep this as a nostalgic moment of Bengal Liver Summit 2026. Thank you, sir. I'll request Professor Premasish Kaur to stay back on the dais. And
after this oration, we will have continuing the various talks here. We have the talk on hepatitis E by Dr. P.N. Rao, but I'm also announcing that we are starting the parallel session of endohepatology, which will be in the hall B. As you all know, that now the hepatologists are married to the endoscopist. and we have a combination of endoscopy and hepatology which is being practiced. So those who are interested in endohepatology can continue with the deliberation in the Hall B, and we continue with our program in Hall A here with a lecture, guest lecture by Dr. P.N. Rao. Dr. Premashi's car continues, and Kinsuk, you can invite the other chairpersons.
I think the next chairperson is none other than Professor Uday Chand Ghoshal, who is was the president of Indian Society of Gastroenterology. He is still not out of the team, and he was the HOD and of Department of Gastroenterology of SGPGI. And after that, he has joined as senior consultant and chief luminal gastroenterologist of Apollo Multispeciality Hospital, Kolkata, in our team. We also invite Dr. K.S. Narayan from Swet Sri Clinic, Dhanbad. And with this, we start the proceeding. Udada, you will call Dr. P.N. Rao or Dr. Premashish Kaur?
Yeah. It is my pleasure to sort of invite Professor P.N. Rao, who doesn't really require an introduction to the hepatologist. He is currently from the Asian Institute of Gastroenterology in Hyderabad and is a perfect combination of a great hepatology clinician and researcher. And he will be talking about hepatitis C vaccination in India from introduction to implementation. We all know that this is very important in Indian scene. Hepatitis E continues to be an important problem both in endemic form and epidemic form, and in pregnancy particularly where we are worried about viral hepatitis E, and the vaccination is important, and the vaccine has been now introduced in the Indian market. So, Professor Rao, please.
Thank you very much. Thank you, Professor Uday. And thank you very much, the entire BLS team, for asking me to take up this subject. And let me give a little bit of a prologue. It was in 1955 and 56 that the Delhi epidemic has started because of a water contamination. And at that time, later, when Dr. Purcell in 1970, when he discovered hepatitis A, Dr. Pavri, the then director of a National Institute of Virology, have sent the samples. And when they sent the samples, it was found to be, it was a non-A, non-B hepatitis. Subsequently, the pioneering work from Kashmir by Professor Kuru and subsequent small epidemics in Pune and Ahmedabad, they all proven to be hepatitis, the non-A, non-B hepatitis. And this followed a unique experiment by Professor Balayan, who is a Russian scientist, and he has ingested an extract of the fecal matter from the epidemic non-A, non-B hepatitis and produced the acute hepatitis himself, and his stool samples also revealed virus-like particles. And later, of course, the genomic transformation has occurred, and as we know that the hepatitis E is a part of an NA and B. One part has gone for hepatitis C and the other part has come to hepatitis E. What you see here is a HIV genotype and the presence in the world. India has only genotype 1 in contrast to the low endemic zones, where zoonotic spread resulting in the chronicity, particularly in immunocompromised individuals, and they may require ribavirin and peginterferon only in this population who are going to have a chronic hepatitis, not in the regular genotype A, which we are familiar with. Once the vaccine development has initiated, we had a preclinical studies were done establishing the immunogenicity in the mice, then phase 1 RCT with a 56 kilodalton candidate vaccine with a dose escalation doses, and later phase 2 double-blind RCT with a 56 kilodalton candidate vaccine named as a Nepal vaccine used in the Nepal soldiers. And it was very, very effective. In fact, as you can see here, but for some reason, it could not be further, did not see any further progress. Among the candidate vaccines tested, the Chinese vaccine called HEV-239 has undergone a large RCT with a long follow-up for both protective efficacy and immunogenicity. And this is the only approved vaccine as of now. And HE239 is a recombinant genotype 1 ORF2 capsid protein expressed in the E. coli, adjuvanted with the aluminum. It is administered in 3 doses, 016, just as for HBV vaccine, which is in fact is the placebo control for these trials. It was in 2010 that the first publication of this HEV-239 vaccine has undergone a double-blind RCT with a large number of subjects, over 48,000 in each arm. These subjects were followed for 19 months after the first dose. And if just look at the first set, the intention to treat, that means at least 1 dose they have received. And you can see here that the vaccine efficacy was 95%, and clinical cases 1 in the arm and then 22 in the hepatitis B vaccine group arm. And the per protocol set among the participants who have received all the 3 doses, you can see that it was nearly 100% efficacy. The next question is that the information which we need to know is that in an endemic area, how long these protective antibodies to sustain the prevent at least a clinical hepatitis, and subsequent exposure. This information is provided here. The same cohort has been followed for 54 months, that is about 4.5 years. And you can see here, during the 4.5 years and study period, 7 cases were confirmed in the vaccine group in contrast to the 53 cases in the control group, and the vaccine efficacy was nearly about 87%. And in those with the seronegative at the baseline, this is the percentage, one thing what has been seen is that those people who have had baseline seropositivity, that means previously they have been exposed already, when they were given the vaccine, in fact, the geometric mean has increased. That means we have got here what is called an hybrid immunity. That means naturally acquired immunity from an infection and the vaccine-induced immunity. So this is a very important thing for us to know, because sometimes whether to do the antibodies before starting the vaccine or not, and then that has to be decided. And that's what I said, that the geometric mean in these patients who already had a higher baseline values, and then in fact their titers were more than the pure vaccine-induced antibodies. Then of course the same cohort has been followed for the next 10 years, because we can say that the 5 years may be too short a time. And they have published recently in 2024, and in these, the 3 doses regime has revealed the persistence of the antibodies for at least 8.5 years with a protective efficacy about nearly 87%. Well then, let us see, what happened in the Kashmir epidemic, which Dr. Kuru has published. And here, what has been seen is that there was a gradual loss of the antibodies following the clinical hepatitis during the epidemic, 45% after 14 years and only 4.5% after 30 years, and thus they may get an infection and the subsequent exposure. In fact, a second epidemic also here described following that after nearly 30 years. And this is important for us to know whether the same thing is going to happen in a sporadic hepatitis and what happens to their protective antibody levels over the time. And let us now look at the HEV-239 vaccine in our country. And then we had they had 9 centers, and then we have Professor Prema Shiskar, and then to which is one of the persons who is with, along with Coimbatore, Dr. Vijay Prasad, and then about 7 centers, in total 9 centers in our country. They have revealed this is only mainly to see the protective efficacy and safety. And for the seroconversion rate was 89%. Interestingly, as you can see here, that even the placebo group also had about nearly 22%. That means they did not have any clinical hepatitis, but perhaps they had a subclinical exposure. And this was seen, similar thing has seen even in the Chinese trial also. About 10% in the control group who were taking the hepatitis B vaccine had indeed such kind of a antibody level, based antibody levels. So what are the key findings of HIV 239 in the general population? I already told you about the immunogenicity. Suppose somebody says, I am going to some country where there is an endemic area, and then I may not have a 6 months time. But there is a small study which has shown that an accelerated schedule of a 0, 7, and 21 days, from the China again, phase 4 trial, and it has been shown that is a non-inferior. And the safety of these has also been seen in some outbreaks in the Sudan. And as I told you already, that the natural immunity wanes faster in contrast to the hepatitis A, where we know that it is a lifelong immunity. And we have an excellent data from Kashmir epidemic that the incidence that just now Professor Uday Ghoshal has mentioned about the severity of this particular hepatitis E during the pregnancy. The incidence, the severity, and the mortality in the pregnant is a lot more higher, especially in the third trimester, as compared to the non-pregnant and comparative to the males at the time. So, the mortality rate I have already told you. HIV 239 has been shown to be safe and effective in the pregnant rabbits. Human data is still limited. But safety has been seen when inadvertently the HIV vaccine has been given in the Chinese study, and also when HIV 239 served as a control for human papilloma virus trial in the pregnant women. There was no safety concerns at that time. And the mass vaccination program in Sudan, again, we did not have any safety concerns. And therefore, the SAGE recommends prioritizing the vaccination in women in the childbearing age in areas with a significant and genotype 1 and 2, and because of a strong tropism for the decidua. Well, then, in rural Bangladesh, a last trial was conducted, and phase 4 double-blind trial for the those people who are women of the childbearing age. The results are still unconclusive, but what is important to see is that on the left-hand lower panel, you can see that there is some disturbing fact that among the pregnant participant, HIV 239 group had a higher risk of a miscarriage as compared to the control population. This is what is slightly disturbing, and that means that giving the vaccine during the pregnancy again is not completely safe. We need a lot more data on this particular issue. We know that the high mortality associated with acute HIV infection in cirrhotic people from Holiday Institute, Professor Acharya studied long ago, and the collated data from various centers in our country, in India, and acute HIV infection in causing ACLF and associated morbidity and mortality in ACLF and acute HIV causing as a hepatic insult, and we all know about that one, and therefore it becomes a very significant one. And the Chinese have seen in the people with the carriers, that means the ALTs were normal in them, they were hepatitis B carriers, and in this particular group, again, it was shown as a non-inferior to this chronic hepatitis B patients, suggesting that the protection levels, even at the lower antibody, I can see here that the GMCs were lower in chronic hepatitis B group, but still it was shown to be protective in these people. But then what we require to know is what is happening in patients with a cirrhosis of liver. And this is, of course, not decompensated, compensated cirrhosis of liver of a secondary to chronic hepatitis B. And again, this particular study suggests that this is safe and immunogenic in patients with the chronic hepatitis B with compensated liver cirrhosis, supporting its use in preventing HIV superinfection in these high-risk population. Well, then all these things, WHO, EASL, British Transplant Society, SAGE, and they highly recommend HIV vaccination in the vulnerable groups. And this European Society of Clinical Microbiology and the Infectious Diseases, and also for viral hepatitis, and they strongly recommend HIV vaccination should strongly be considered in women of a childbearing age in regions where genotype 1 and 2 circulate, particularly in Africa and then Asia. And HIV vaccination is recommended universally for patients with the CLD due to significant risk of ACLF from HIV infection. And for immunosuppressed people, particularly in the region where genotype 3 and 4, the zoonotic transmission is there, should be considered before planning for immunosuppression. And these are the recommendations given by the European Society. Well, then, what we know so far is acute hepatitis E is self-limiting in the general. However, its role in causing the ALF in general population, high mortality in the pregnant, cirrhotic subjects as a trigger, and then high mortality in ACLF cannot be underestimated. The natural acquired immunity from HIV infection wanes over the time, making them still vulnerable for subsequent exposure. This is known from the large epidemic from the Kashmir that it wanes off. I'm not very sure what happens in the sporadic one. And the safety and the long-term immunogenicity of the candidate recombinant HIV 239 vaccine has been established at least for 10 years as of now. And prospective data is limited about the safety and the effectiveness of the vaccine women during the pregnancy. Certainly one can consider before the pregnancy in the childbearing area. Preventing HIV vaccination has been recommended by many scientific institutions, which is mentioned here. And preventive HIV vaccination has been recommended for the high-risk groups like a chronic liver disease, cirrhotics, women of a childbearing age, and for individuals exposed to the high endemic areas during an outbreaks and an epidemics. And what is needed to be done is, and then this clearly has shown in this particular article, recent, targeting the high-risk population, addressing the logistics and financial constraints, enhancing diagnostic support for vaccination programs, and all these. And thank you very much for your kind attention. Right.
Any questions on the floor
Yes, sir.
on the HIV vaccination?
A very nice explanatory talk, sir. Sir, I just wanted to know 2 points from you.
Yeah.
One is that, sir, this vaccine is mostly targeted in high-risk group, and the dosage schedule is like 0, 1 month, and then 6 months. So, in case of acute outbreak, what are your views for that accelerated dosage or a 2-dose schedule for this vaccine, which has been studied?
No, this is a very short study, phase 4 trial, which has been done. We don't have any large study on this particular issue. But however, given even during the epidemics has been given, in Sudan outbreaks has been given, is found to be safe, and then no side effects have been reported.
Gives a cross genotypic protection, means does it give protection against all the genotypes?
This is only one the serotype. So I think, isn't it, Dr. Premashis?
This particular vaccine has been based on the genotype 1, but I was told that it is also effective against the other genotypes
Right.
in other countries, whichever is prevalent. In the other types,
Sir, use the mic,
you have
sir.
genotype 3 and 4.
3 and 4 also.
And we
same.
have genotype 1. But it is said to have cross sensitivity with the other genotypes also.
Sir, the question is just same question I am asking, the genotype, that is 1 and 4. The efficacy is more against 1 and 4, but there is a reduced efficacy with genotype 2 or 3. But basically 2 is more common in developed country. But the ability of the vaccine, based mainly on the literature from the Western countries, but it is available in 1 and 4. So should it is suffice, or we need to include all the 4 genotypes?
In fact, in the Chinese trial, genotype 4 were more than the genotype 1. In fact,
Yes.
that one. Yes.
Yeah.
2 is mostly the waterborne and which is common in underdeveloped countries, low and medium income. Genotype 3 and 4 is mostly in the developed nation where it is zoonotically transferred. So that vaccine has been...
Sir, one question.
But they have recommended the same vaccine for that also. Then even the European Society, where the zoonotic and then 3, 4 are existing, they are recommending the same vaccine.
Yeah, I think this is an important concern that you are raising, but obviously we need more studies on this. Now, Dr. Tushar, if you have a question, please be short. And this is the last question because we have to...
Sir, if someone suffering from genotype 1, how many days it protect? How many years it protect?
So he is asking for protective efficacy. How long does it remain protective?
The vaccine, you mean?
Yeah, that is what he is.
That's what is, no, it's the vaccine has been a largest trial has been done and then protective up to 10 years at least has been shown to be protective.
Infection, sir, infection.
Infection only. Even the clinical cases were much less in the group we have received the vaccine as compared to the control population even after 10 years.
And how much it protect from the genotype 2?
No, the question is again same that you are asking.
For all the genotypes, it's the same thing. Genotype 1 to 2, which are prevalent in the country. Ours is genotype 1 mainly. And the Chinese genotype 4 and 1, they have tried this vaccine. And there is only one vaccine which has been approved as on date.
Okay. So thank you. So we wind up. We are already running late. Thank Professor Rao for the very sort of complete and comprehensive coverage on the topic, and obviously question remains on the cross-reactivity of different genotype and the protective efficacy. We'll get more studies. So thank you so much.
Thank you.
Yeah, just time for the group photo. Please take a group photo of this session. As the group photo is taken, we go on to the next sessions. Infections in cirrhosis, risk, resistance, and readiness. The chairpersons for these sessions are Dr. Tarun Joseph from Tata Medical Center, Kolkata, Dr. Subhas Tiwari from the Critical Care Unit, Apollo Multispeciality Hospital, Kolkata, Dr. Shruti Kyal from our own institute, Apollo Multispeciality Hospital, Kolkata, Dr. Devesh Prakash Yadav, IMS BHU Varanasi, and Dr. Amitabh Sharma, Medicity Hospital, Guwahati. In this session, the chairs call the speakers and you take 1 or 2 questions after each session till you reach the case to consensus panel, which will be again of 20 minutes by Dr. Nipun Verma. I think first talk is by Professor Jasmohan Bajaj, Professor of Medicine, Division of Gastroenterology, Hepatology and Nutrition, Virginia Commonwealth University, Richmond, Virginia, USA. He'll be talking to us on keynote lecture, SBP Prophylaxis in 2025, Stewardship versus Safety, Who, What, and How Long. It's all yours, sir.
Thank you. Thank you again. And thank you for whoever is sticking in the audience. To talk about something that is so important, and especially important in the Indian context when we talk about multi-drug resistant organisms. So let's talk about SBP prophylaxis, how the trials actually came about. There are 2 trials, Gines et al. And Fernandez et al., both of which were based in Barcelona. And these were based a long time ago. And they all came for a very good place. SBP is still a very horrendous problem. And it actually has not gotten better. The prognosis of SBP is still bad. We want to prevent recurrence and occurrence of SBP. But first, we need to do no harm. That is the biggest issue that we face right now. Things that may have been coming from a good place previously are currently not in a good place anymore because we have to change with the times. So why is cirrhosis, patients with cirrhosis and only cirrhosis largely are susceptible to SBP? It's important to realize that how important the liver is for systemic and local and GI immunity. The liver is involved in the hepatic reticular endothelial system. If you have cirrhosis, it affects immunity in the circulation, the spleen, and in addition, when you have malnutrition, some other medications and alcohol intake, that make things a lot worse. In addition, we've heard a lot about the gut barrier. The physical gut barrier, the hormonal gut barrier, the microbes itself, the quality and quantity of the microbes are all impaired in patients with cirrhosis. So in addition to the multiple instrumentations, multiple hospitalizations that drive this exposure, this leads to translocation of bacteria and their products, and not just bacteria, but viruses, fungi, and their products, that leads to a pro-inflammatory response and then finally causes the liver injury that we think about. Now, SBP, the assumption is that it is actually bacteria just walking across the gut barrier causing SBP. That is really not the case. The bacteria first translocate into the mesenteric circulation and then come back into the peritoneum, which has a low ability to fight that. So if you look at all SBP, almost all of them will have a positive blood culture if it was actually drawn in those patients. So SBP is a systemic disorder masquerading as a gut dysfunction in these patients. So it is a very big deal, and many, many things have to fail before someone gets SBP. And we know infections have a very poor prognosis, and this study that is already many years old now, you can see the multi-drug resistant organisms were even higher then in India, but they are much worse now as more and more antibiotics are being used, abused, and overused, not only in India, but elsewhere around the world as well. So what is the current guidance for primary prophylaxis and secondary prophylaxis for SBP? The primary prophylaxis is an acute GI hemorrhage, ceftriaxone 5 to 7 days. This was considered better than the oral medications such as the ciprofloxacin or norfloxacin. Primary prophylaxis, and this requires an entire PhD to remember. I do not remember this at all. So anyone who has low protein ascites is given daily fluoroquinolones until liver transplant or death, or the new concept of recompensation, where the patient stopped drinking, hepatitis B is gone, hepatitis C is gone, and now the ascites is gone. In that case, you can also stop this. What about secondary prophylaxis? Cirrhosis after the first episode of SBP. Again, the same agents, fluoroquinolone or trimethoprim sulfamethoxazole. Again, until liver transplant or death or recompensation. So this is a problematic situation. So the questions to ask before any intervention, I'm not talking about SBP prophylaxis, anything. Is it effective? And if yes, for what endpoint? Is it safe? Is it adequately translated into practice, and does it need periodic reevaluation? And this is very important for all of these situations that we do. So let's talk about, is it effective? And the answer is no. As time goes on, more and more higher quality studies show that there's even lower effectiveness. Mortality change is not even adequately evaluated. So even if SBP occurrence or recurrence is low, if it does not translate into a mortality change, that's a big, big problem in these patients. So it maybe was effective at the point when we started in the 1990s. It's not effective anymore. What about some recent trials that are not necessarily focused on cirrhosis itself, on primary SBP prophylaxis, but just actual use of norfloxacin? In this study that is already published in 2016, multi-center French study, no change with fluoroquinolone therapy for mortality, absolutely none. And then the all-cause mortality does not show any change in the Cochrane database in 2020. So it's a big problem. What about non-absorbable antibiotics such as rifaximin? In this study with ACLF patients, they took simvastatin and rifaximin. Again, negative, no change in infections, hepatic encephalopathy, or anything once you reach beyond a certain stage. What about this study that was published right now that actually was for primary prophylaxis? With rifaximin versus placebo, properly done over many, many days, and 72 patients with rifaximin and 80 on placebo. Again, absolutely no change in the mortality or SBP occurrence in patients with rifaximin. So non-absorbable antibiotics, also not important. And this trial, which I presented on the first day, which was on instead of norfloxacin, they used cotrimoxazole, which is trimethoprim sulfamethoxazole. Again, no difference in primary prophylaxis. So these are prospective trials that were done. But what are the issues with prolonged antibiotics anyway? Clearly, I'm going to talk about the antibiotic resistance a little bit later. But remember, all these antibiotics have side effects: tendinopathy, nervous system problems, aortic dissection, and QTc prolongation. C. difficile, which is very, very common in patients on antibiotics, especially in Western countries, has a very high case fatality and increase with antibiotic use. And of course, unnecessary medications. It's expensive and it causes confusion. You do not want to give people added medications if they don't need it. And of course, antibiotic resistance is the creme de la creme of the issues that we are facing in this. And why? Because endogenous factors we just talked about, but there are exogenous factors, multiple hospitalizations, alcohol use, PPI use, antibiotic exposure can cause all of this. So this is a big problem in these patients, and we are trying to avoid this as much as possible. So primary prophylaxis in the real world across the Veterans Hospital, we took the VA database, more than 7,500 patients with their first SBP episode. Some of them were on primary prophylaxis, some of them were not, which means they failed their primary prophylaxis if they actually had the first SBP episode. And what we found is 1/5 of these patients were on SBP prophylaxis, and if you were on primary SBP prophylaxis and then developed an SBP, your prognosis was distinctly worse. And when we did an antibiogram for E. coli and Klebsiella, which are the number 1 and 2 reasons for SBP, it was horrendous across the United States when it came to the veterans. This study that was published in 2022 led to the banning of primary prophylaxis across the VA system. We actually got the antibiotic prophylaxis people involved, and they basically said, if you want to do it, fine, but we discourage primary prophylaxis for these patients. What about upper GI bleeding? Remember I said another primary prophylaxis is you give it for 5 to 7 days just to prevent mortality. And this analysis shows, meta-analysis, shows that even this, in published situations, did not lead to any benefit. No benefit at all. So again, primary prophylaxis is not really very good right now in patients with cirrhosis. What about MDROs in these patients? Every time you have an MDRO with SBP during prophylaxis, the patients tend to die. MDROs are the bane of our existence. And the more unnecessary antibiotics we give patients, the worse off their situation is going to be. And this is C. difficile. I told you it's also a problem. So outpatient spontaneous bacterial peritonitis, inpatient antibiotic use and PPI were significantly higher in those with C. difficile. So I know C. difficile is not that big of a concern in India, but at least in the United States and many parts of the Western world, this is a really big problem. It's hard to diagnose in patients with cirrhosis because they're often on lactulose. It takes longer for us to actually figure out whether they even had C. difficile diarrhea or not. And when it's diagnosed, it's often too late. And even if you give them FMT, it requires more than 1 or 2 FMTs rather than people who don't have cirrhosis to cure their C. difficile. So promises are broken with real-world secondary prophylaxis. I already told you about primary prophylaxis. It's kind of almost banned, and we don't use it at all. Secondary prophylaxis, things are a little bit in flux. This study I already talked about, if you have prophylaxis and you have MDROs, people do very badly. And in these 2 studies that we had done, in Trinetics and VA databases, secondary prophylaxis, this is people who have who have problems of recurrence. This is 2009 to 2011. You can see the secondary prophylaxis is in pink. The black one is no secondary prophylaxis. So secondary prophylaxis is supposed to actually stop SBP from recurring. It's the reverse. And as you can see, from 2012 to 2014, the curves separate, which means more and more recurrence if you were using secondary prophylaxis. And 2015 onwards, these are far, far apart. And we can only hypothesize that these patients are getting more and more and more resistant. 50% of people were on secondary prophylaxis, 50% were not. And this same pattern was across the VA as well as the non-VA databases. And so AMR is a failure of prophylaxis, higher recurrence. And most importantly, it's not just SBP, but other infections that are caused by similar organisms like gram-negative rods, such as UTIs, that also increased in this, also adding the biological plausibility of that this is directly related to secondary prophylaxis. Long story short, there was absolutely no mortality benefit. It was not even helpful. So even if there's an indication of things getting worse, you shouldn't be doing things for those patients. So these are the recommendations. They are watered down, and nothing here is very, very concrete. You can see the ASLD, There's a despite text saying that's not equivalent. Consider antibiotics as severe liver disease. This is UK, and this is our VA, which absolutely are like, it's so watered down that if you want to not use it, you can absolutely not use it. So what about liver transplantation? If we hear a lot, our patients with SBP, if they get a recurrence, and the recurrence is actually much more associated with, an incurable SBP or something which is really bad, why should we be stopping secondary prophylaxis in them? And what we found is there is no interaction for liver transplant. There is an interaction for SBP prophylaxis and death, which means if you have primary or secondary prophylaxis, you're going to die at a much higher rate in your first SBP and your second, third SBP episode. But this does not affect your transplantation. So if someone is on the transplant list, this should not stop you from withholding SBP prophylaxis if you think it is not going to work for those patients. And again, why is this important? Because antibiotic resistance genes, the gut microbiota cirrhosis, are much higher in people who get SBP prophylaxis. And fungal infections also go up. So this is just the tip of the iceberg that we actually follow. These patients get a lot of fungal infections, and the fungal infections, the number one cause was a bacterial infection. Very few people had a fungal infection without a bacterial infection. And it did not matter what bacterial infection, which tells you that it was exposure to the antibiotic that led to the fungal infection rather than a specific thing like that. The other thing that we often conflate is whether ciprofloxacin is the same as norfloxacin. It is not. Ciprofloxacin is much more systematically available. In the United States, we do not have access to norfloxacin. So we give Cipro, which is actually much more bioavailable. And CSF penetration is also very high with fluoroquinolones that can actually cause confusion. So a lot of patients who may have hepatic encephalopathy, be termed as hepatic encephalopathy, may actually be confusion because of the CNS penetration of fluoroquinolones. So again, beyond resistance, these patients have a lot of issues. So the times are changing. There's a real-world risk-benefit, AMR spreading like wildfire, SBP remains deadly, SBP organisms are not covered by SBP prophylaxis, 50% of patients are not prescribed secondary prophylaxis, and they do just fine. They may even do better than those who were given the SBP prophylaxis. Guidance and guidelines are very low in their evidence basis, and a higher number of clinicians are open to withdrawing it. So the benefit risk has changed to risk and benefit right now, and this is what it is. When we did an analysis of patients across the United States, what will you do if its SBP is ineffective, harmful, or not? They will withdraw and not affiliate. So most respondents were perfectly comfortable not initiating or even withdrawing these prophylaxis if there was solid evidence that these were not effective in these patients. What about rifaximin? Again, I told you rifaximin is ineffective, but there's also a use of rifaximin, and in the resistance, it was not the case. Rifaximin is not really associated with the resistance. So here is the proposed modifications. Primary prophylaxis, for want of better things, we would still continue for 5 to 7 days. Because if there's a little chance for these patients getting less systemic inflammation, that's fine. Primary prophylaxis without liver disease, without GI bleed, we would cease to advise. Secondary prophylaxis is now more nuanced. Case-by-case basis, shared decision-making is very important, and RCTs are needed. Another thing that I did not tell you in the VA database that we talked about where the liver transplantation was not effective, patients actually had ciprofloxacin-resistant infections, and they were restarted on ciprofloxacin on discharge, despite there being obvious evidence. So we need to stand out of that trap of actually assuming that everything that is in the guideline is gospel. So look at your patient. If your patient is not doing very well, this is really something important. So again, we shouldn't be starting things just because less is more. We have a tendency as doctors to want to do something. But remember, the best thing you might be doing for your patient is not doing harm to the patient. And I think at this stage, primary prophylaxis is associated with a lot of harms. Thank you so much.
Thank you, sir, for your clear and deeper insight into the SBP prophylaxis in current era, where is the now emerging MRSA, ESBL, and even fungal infection are going up. Thank you, sir. Take your chair.
Actually,
and
I have to leave, so if you can
so
take
just
questions.
Okay,
yes.
okay, sir. Just take 1 or 2 questions for sir.
Yes, from the audience.
Excellent lecture. In India, we tend to overuse, misuse, whatever called rifaximin. What's your opinion for, not for primary prophylaxis, in general for liver disease?
In any situation, PPIs, rifaximin, if they're not indicated, they just add to polypharmacy and they add to the expense, and patients often forget to take them the right way. So please use it according to the guidelines, which would be for hepatic encephalopathy prevention and nothing else. It is clear that SBP prophylaxis is ineffective with rifaximin at this stage. There have been very high quality trials that I just showed you. So again, if a patient does not have obvious overt hepatic encephalopathy, the patients should not be started on rifaximin.
Hi, just one very nice talk. Very enlightening, actually. I wasn't aware of all this new data. So do you foresee use of oral antibiotics which are active against multi-drug resistant organisms based on the antibiograms to be used for primary or secondary prophylaxis? Would you recommend that if I have a patient with, say, MDR organism and maybe a ferropenem may work? Would you consider doing that as prophylaxis or no?
If it's an actual infection, really you should be treating them for the urinary infection. But there is no guarantee that will not come back based on whatever their underlying disorder is. So if they're a transplant candidate and the MDRO is cleared, that is the time to actually transplant them so that the immune dysfunction that is actually driving that goes away. I'm not aware of anyone who's actually done a trial in which you have MDROs. But what they have done is actually treat SBP with stronger antibiotics right up front. If you have a hospital that has an antibiogram that shows that ciprofloxacin, like ceftriaxone, is not going to work. So you start with meropenem, do the cultures, and come back. So that will reduce the burden of MDROs in that patient. When you're discharging the patient, I don't think we have the ability, a strong evidence to give them a higher antibiotic. Because, the bacteria will learn and they'll get more and more resistance with that situation.
Dr. Rakesh Agarwal now. Dr. Rakesh Agarwal, yes, sir.
Hi, Dr. Bajaj, very useful talk. Do you think we were too hasty in introducing these antibiotics based on small data that those trials provided us years ago?
I'm not qualified to make the judgment, but the question really is, we want to do as doctors what is best for our patients. And if that showed some evidence, it probably worked then, but it doesn't work now. And I don't think we should make a judgment call for 30 years ago.
Is antibiotic resistance a major problem? Is it worth trying probiotics for the prophylaxis?
Probiotics are interesting. I don't think there is an actual evidence. And
no, but
no,
it has not been tried. No,
for SBP. Sorry?
But it has not been tried. That's why evidence is
No.
there.
That's why. So that's what I cannot recommend it without the evidence. And probiotics in patients with decompensated cirrhosis often have risks. I have seen lactobacillus sepsis, and it is really horrible. The thing that makes lactobacillus such a beautiful probiotic, it is very resistant to almost everything. So if it actually gets into your bloodstream and causes sepsis, it's a big, big problem. So before using it blindly, we do need to do some trials. And if you want to do trials, that's an excellent way to go for it.
Dr. Akash, yeah.
As usual, fantastic talk. Just like you said that those guidelines are so difficult to remember, there's another point of the end point of prophylaxis where they say, and it's not clearly written also, that when ascites resolves, you continue, discontinue, it's not sure. So I'm again not sure. Those who resolve, say they had an SBP with ascites and then the ascites goes. And they may not never land up to have ascites again. And some of them are there who have persistent ascites. So A, we are not clear on that, but do you think that these outcomes might differ between patients who continue to have ascites vis-a-vis those to resolve ascites completely?
So resolved ascites in the presence of diuretics is very different, or with TIPS is very different than people who resolved ascites because they completely recompensated. So if completely recompensated, it's very good to take away the antibiotics and everything else. Those are the patients in our practice. We immediately take away everything. The people who still are at risk for recurrence, which means their diuretics are needed, they had a TIPS placed, which it was so bad for the ascites, those patients, as you said, are much at higher risk of recurring. But if your policy now is to not start on prophylaxis, then it doesn't matter one way or the other. So primary prophylaxis, we don't do. Since 2012, ever since I published the C. diff paper, I have not started primary prophylaxis in any of my patients. Secondary, I still hold my nose and do this, but I want to make sure that I follow the culture.
Okay, thank you, sir. Now we are moving to our next topic, the gut microbiota in cirrhosis by Professor Uday Gosal, sir. Sir, now your turn.
Thank you, Dr. Jasmine Bajaj, for enlightening us over last 3 days in Bengal Liver Summit 1. And we hope that we'll call you back again when we do the Bengal Liver Summit 2. Thank you, sir, for enlightening us with the whole academic knowledge.
Thanks, Chair. I'll be talking about gut microbiota in cirrhosis, a primer that matters to the clinician. These are my conflict. This is the outline of my presentation. I'll give an outline of gut microbiota. I'll talk about evaluation for gut microbiota, which include culture-based method, study of bacterial genome, and study of gut microbiota metabolite, gut microbiota in CLD, including MSLD, and then clinical value of gut microbiota testing in CLD, and conclusion. Human gut contain microbiota, and this not only includes bacteria, which we called as microbiota, but also mycobiota, which is fungus and viruses, and most of these viruses are bacteriophage. And interestingly, microbial cell outnumber the human cell in our body. We have 10 to the power 13 human cell in our body, but there are 10 to the power 14 bacterial cell in our gut. The predominant bacteria are gram-positive firmicutes, and the less often are gram-negative bacteroids. And if you look at the pattern of bacteria, obviously they are different. For example, the upper gut typically contain bacteria which are gram-positive or those which can sustain acid. So which can sustain acid? These are Lactobacillus, Veillonella, and Helicobacter. On the other hand, lower gut predominantly contains the gram-negative bacilli, and many of them are anaerobes. Obviously, the number of bacteria is lesser in the upper gut than the lower gut. And they perform a lot of function. For example, metabolism of unabsorbed carbohydrate. They actually prime our immunity or modulate our immunity. They even actually helps in sort of behavior of the person, intestinal function, motility, and maintaining the homeostasis. Now, culture-based method was earlier method of studying gut microbiota, but let me tell you, culture-based method is not great. The reason is only 30% of bacteria are culturable. When used to culture about 2 or 3 decades ago, even little bit air being pushed during endoscopy will kill all anaerobes. Second is that culture-based method has another limitation because obviously it is microbiologically intensive. So therefore the recent technology is sequencing of 16S rRNA gene. We all know that the bacteria has 16S rRNA gene which is evolutionarily conserved. What does it mean? That as bacteria evolve to a better and better bacteria, the 16S rRNA gene remain the same. So like in mammal, we have the coccyx or the tail evolutionarily conserved. Similarly, bacteria has 16S rRNA gene evolutionally conserved. But this 16S rRNA gene has a variable region, and this variable region differ among different bacteria. So for example, this variable region includes V1 to V9. V stands for variable. And if you look at gut microbiota, even simple V3, V4 sequencing will give a little bit quite understanding that which phylum you are dealing with. So therefore, we are sequencing those, and the sample has been feces, because obviously it is easier to obtain. Upper gut fluid is the one which we studied quite often, and mucosal biopsy is from Brisbane group. Now these are the sequencing platform. You can use Illumina, you can use MGI, Element, Singular Genomic, PacBio, and so on. And they are doing the similar job. For example, if you are using something called Torrent ion channel sequencer. What happened is when the polymerization occurs, that means when a purine joins to another purine, there is a displacement of hydrogen ion, and that hydrogen ion displacement lead to change in the pH, and that pH change is obtained or sort of studied by this system and tell you this particular purine is present there. So what do you do in sequencing? You take a mixed microbial community which is present in your sample. Then you do DNA extraction so that you obtain the whole DNA, and then you do amplicon sequencing. Typically in metagenomic sequencing in one run, you get all the genome studied, and typically this is, I'm talking about bacterial genome. So briefly, we do sample preparation, we do library preparation where you see whether this is good DNA, and then you sequence that DNA and do data analysis. If you do a sequencing with the depth of 90%, you do phylum level identification. That's why in many of the studies you will realize they're talking about phylum, they're not talking about species, because they have done 90% depth of the sequencing. For species level identification or strain level identification, you have to do a depth of 99%, and obviously that means you typically do a V1, V9 enter sequencing, and the bioinformatics is more complicated because you have more data. Now, you all know kingdom, phylum, class, order, family, and genus. So phylum include Firmicutes, Firmicutes, Bacteroid, Actinobacteria, Proteobacteria, whereas when you come to a species, obviously as I told you, the depth of the sequencing has to be more. So what is dysbiosis? Microorganism in abnormal number is dysbiosis. Microorganism is an altered quality is dysbiosis, and microorganism is an abnormal location is dysbiosis. For example, if you get colonic bacteria in upper gut, this is dysbiosis. And this is a very complicated table I will not talk about, but typically this depicts what all you get when you do sequencing, for example, alpha diversity, beta diversity, and so on. But briefly, what is alpha diversity? Look at this. This is a garden. And in this garden, there are plenty of flowers. They look all similar. So this is low alpha diversity. Look at another garden. It looks very different from this garden, but still, this is very similar, low alpha diversity. But if you compare this garden with this garden, they are so dissimilar. So therefore, there is a high beta diversity. So what is beta diversity? When you compare individual from individual, this is beta diversity. When you compare with an individual, one particular, then this is alpha diversity. And this is small intestinal bacterial overgrowth. When your garden has too many uncontrolled plant growing in excess number, this is bacterial overgrowth. Now, diversity greater is better. So if you have low diversity, it is unhealthy microbiota. High diversity is better. And Jasmine spoke just before me, and this is one of his papers where he talked about several liver disease issues where microbiota really matter. And you can see the first column which depicts everything where microbiota is important in relation to pathogenesis of liver disease, development of complication, and therapeutics, and I will examine some of these issues in a greater detail. This is a meta-analysis which ISA and Holtman published from Brisbane, and what they did is they looked at presence of small intestinal bacterial overgrowth in patients with cirrhosis of liver and control, and they found, yes, there is a greater risk of bacterial overgrowth in cirrhosis of liver, and this is one of our studies from SGPGI which has been included in the meta-analysis. This is a meta-analysis which looked at whether there is a difference in the beta diversity in the feces of a patient with cirrhosis and healthy control, and it clearly shows, yes, cirrhotic patients have a different microbial diversity than healthy control. Now, hepatic encephalopathy, is there a difference? For example, a cirrhotic patient with hepatic encephalopathy, without hepatic encephalopathy, do the microbiota differ? Yes. Again, there is a meta-analysis showing yes. Spontaneous bacterial peritonitis patient versus no spontaneous bacterial peritonitis, there is a difference. It suggests maybe the gut from where the ammonia is being originated, maybe the bacteria which are translocating, there may be the reason for the difference. This is a study that we did, and in fact, I'm already showing the preliminary part of the result. This is an equipment called breath calc. So what do you do in breath calc? What you do is that in breath calc, you measure microbiota metabolite index. So the amount of hydrogen that is being produced in the breath over time in response to a substrate is actually microbiota metabolite index. We are not studying the bacteria, which are more difficult to study. Genomic approaches are difficult. So we are studying their metabolite, which is hydrogen and methane. And this is one of our DNB resident, and this is Dr. Akash, and we work together. This is a patented device that we produce. This is called breath calc. And what we found is if you have a patient with minimal hepatic encephalopathy, he produces more methane and more hydrogen in response to a substrate than if you have a patient without any minimal hepatic encephalopathy. Maybe encephalopathy is originating because of microbiota. Gut microbiota in relation to MSLD, very important. We know MSLD, you have first hit and the second hit, and most of the time the second hit is coming from the microbiota. We also know that if you have a particular type of microbiota which conserves a lot of unabsorbed carbohydrate from the colon, person become obese. And we know metabolic factor including obesity is important in MSLD. Let us examine the data. These are the two studies, one using a breath test where they showed MSLD patient has more often bacterial overgrowth than healthy control. This is our study where we use jejunal aspirate culture to look at bacterial overgrowth in MSLD versus no MSLD positive. And this is fecal microbiota dysbiosis by NGS. Again, there is a difference. And this is the meta-analysis of all the data which we published quite some time ago, that MSLD patient more often have bacterial overgrowth, may be important in the pathogenesis. But after all this understanding of the pathogenesis, should we order microbiota testing, for example, fecal microbiota testing in our clinic for patient with cirrhosis? The answer is no, because microbiota is an area where actually marketing has gone much above the science. The science is much at a lower level, but marketing has progressed so fast and the patient follows trend. So therefore we get a lot of patients in our clinic coming with a result of microbiota testing. They have spent a lot of money, but it doesn't clinically make sense. And this is an international consensus statement on microbiota testing and clinical practice. And they clearly suggest we would not be ordering fecal microbiota testing in our patient. It is currently in the realm of research. It is not currently in the realm of clinical care. Also, what is normal microbiota? We don't know. We know there is a difference in the alpha diversity among people who have disease. We also know that if we compare beta diversity among diseased population versus healthy, there is a difference, but what is normal that we don't know. Therefore, I conclude that there is an increasing evidence supporting on role of gut microbiota in pathogenesis of CLD, including MSLD. However, currently this is primarily in the realm of research. Future research needs to be directed to improve sequencing, AI-based interpretation, personalized test-directed therapeutic approach, clinical trial of microbiota-based biomarker, and physician awareness about medication in relation to biomarker related to microbiota. We thank you from our department. These are our faculty member and the resident at Apollo Multi-Speciality Hospital, Kolkata. Thank you so much.
Excellent talk by Dr. Yossi Goswal on gut microbiota and cirrhosis. We will have one to two quick questions because of lack of time.
Excellent talk, sir. So I have two questions. One, we just test bacterial, growth, not the virome or the fungome which is present. Is there any relevance to the disease?
Yeah, that's right. So you know why that 16S rRNA gene sequencing has come up in a big way. But if you have to study the fungus, you have to do 18S rRNA gene sequencing, which is not so widely available. That's why information on microbiota is not much. But I will refer to a beautiful article which was published in Nature Review Gastroenterology Hepatology on microbiota, whatever we know today. And the virus is most difficult to study because you cannot do all this sequencing there. The technology is totally different. That's why you don't have much information.
And the second question regarding SIBO versus dysbiosis. So is SIBO now considered a subtype of dysbiosis? Like
Yeah,
you said
surely. Because what has happened is SIBO has been there. SIBO was quite well recognized earlier. Suddenly there has been a plethora of articles on fecal microbiota because feces is the easier sample to obtain, and the 16S RNA gene sequencing became sort of quite noisy in the science. But I tell you that if you look at our GCN article, that is Gastroenterology Clinics of North America, dysbiosis means one, the SIBO, which is quantitative dysbiosis, two, qualitative dysbiosis, which is by NGS, alpha diversity, beta diversity, and third is anatomical dysbiosis, where you get colonic type of bacteria in a much lower number in the small bowel, that is also dysbiosis.
Dr. Uday, one question. How I clinically diagnose the deficiency of microbiota, and it need any challenge test like 14 days prebiotic period, then
You cannot really clinically diagnose that SIBO or dysbiosis, truly speaking. You need diagnostic technologies for that. But yes, you can suspect SIBO, not dysbiosis really. Suspect when somebody is having diarrhea, somebody is having lot of bloating, particularly after carbohydrate meal, somebody having brain fogginess when they have taken some meal, and somebody who has predisposing condition, for example, very slow motility, for example, severe hypothyroidism, or somebody has a setting like, let us say, prolonged PPI use and on PPI bloating has developed. But there is no way you can clinically diagnose with high specificity, though sensitivity may be good.
In practice, we frequently give metronidazole, like in diarrhea or
Yeah, no. If you look at all microbiology societies, they are talking about antibiotic stewardship. So indiscriminate use of antibiotic causes more harm to the society, to the human being, than not giving antibiotics. So therefore it must be discouraged. There must be more awareness on this.
Okay, thank you, sir.
Thank you.
So we will move to the next lecture, immunization strategies in the chronic liver disease by Dr. Rakesh Agrawal.
Good afternoon, friends. I've been asked to speak on immunization strategies in chronic liver disease. As you've already heard, patients with chronic liver disease have impaired innate immunity, adaptive immunity, both humoral and cellular, increased translocation of bacteria across gut wall, portosystemic shunting leading to bacteremia, and then they have ascites. When bacteria circulate and they reach ascites, they cause infection. So they are more prone to get infected. When infections occur, those are more serious. They can precipitate hepatic decompensation, and there is increased morbidity and mortality for several infections. If the infection is with a hepatotropic virus, then there is also worsening of liver disease. The risk of all this happening is dependent on the degree of liver dysfunction. It is more in those who have cirrhosis than in those who have moderate to mild fibrosis, and that in turn is more than when there is no fibrosis. In particular, once a person has decompensated cirrhosis, the risk increases even more. And in liver transplant recipients, there could be immunosuppressive drugs, and that's possibly the condition with the maximum immune suppression and risk of infections. So we do several things, and we heard about SBP prophylaxis. We use antibiotics. We control ascites because that by itself reduces the risk of infections. And there, if you use diuretics, that is better than paracentesis. We use physical measures and several other things. Of course, there are problems associated, as we heard from Dr. Bajaj. And then, in non-cirrhotic situation, we know that vaccines are the best available tool to prevent infections. And if you look at 3 of the hepatotropic viruses, even if we don't count hepatitis D, we have vaccines. There are vaccines for systemic and respiratory infections. There are childhood vaccines, and there are vaccines that we use in special situations where a person has been exposed, say, to rabies or chickenpox. So we have the solution. However, if it was that simple, then we wouldn't be discussing this today. The problem is people who have liver disease, they often do not mount a good response to vaccines, just like they don't mount a good response to infections. And even if you give them vaccines, there is a lower seroconversion, antibody titers are lower. We don't usually measure cellular immune responses, but when it is done, those are also impaired. And even when antibodies develop, they disappear very quickly. The immune memory is not good. And the biggest challenge is that the same factors that increase the risk of infection also impair the response to the vaccine. So those who are at the maximum need for vaccine, those with decompensated cirrhosis, those who have had a liver transplant, are also the ones who are least likely to benefit from vaccines. Also, there are some vaccines that have a live pathogen, for instance, measles vaccine, for instance, BCG, and those could multiply in these people with immune deficiency, and that increases the risk of complications, so there are safety issues. Now, so we need to look at it more carefully. However, the problem is data on this subject, that is efficacy or even immunogenicity of the vaccine, are quite limited. They are heterogeneous. They vary. Some of them have patients with milder liver injury, some have with more severe disease. The data vary across geography, depending on whether you are in a low-income country or high-income country. Data are usually for seroconversion, but there are very little data on how long the antibody persists and whether actually a person is protected with that antibody or not. Opinions are galore, and most of them, however, are from high resource settings and which are based for their population, not for our population. They are mostly not based on data and evidence. They have money, they can spend it. So they do what you heard from Dr. Bajaj, the more the merrier. The opinions themselves, even in those countries, are highly variable. And even though, as Dr. Bajaj said, we really need to look at whether it's actually used. Even though the opinions there are in favor of many of these vaccines, in practice, they are used very little. So we need to look at our setting, our epidemiology, our costs, our cost effectiveness. And the rest of the presentation that follows will be my opinion, Rakesh Agarwal's opinion. You may take it or junk it. So let's start with hepatitis B. We know that if a patient with chronic liver disease develops acute hepatitis B, they could have what we call acute and chronic liver disease or failure, and with a higher morbidity and mortality. Therefore, very often we recommend hepatitis B vaccination for anybody who has chronic liver disease of any type, till it is not because of hepatitis B itself. However, the problem is that vaccination in these people has lower seroconversion rates, not the 95% upwards that we see. And depending on the severity of liver disease, this could be as little as 15 to 16%. And actually, how often do we get acute hepatitis B in people with chronic liver disease? Very few, if any. So, but it's a cheap vaccine. We use it. People have tried other ways to improve the responsiveness. They've given higher number of doses, not 3, but give 4, 5, 6. Give double the dose. People have said that some newer vaccines have better adjuvants. But what works the best is that you immunize early in disease. When a person has milder illness, if you diagnose a milder chronic liver disease, vaccinate at that time rather than wait for for liver disease to worsen and then give it. And then when transplant is needed, if you think transplant is going to be needed, you give it as early as possible and ideally complete it 4 to 6 weeks before the immunosuppression due to transplant starts. Hepatitis A, and I'm going to spend the maximum time here because I see that that's a question that everybody is asking in the corridors. Hepatitis A is excreted in the feces, fecal-oral transmission. Actually, even though we feel that it is transmitted through contaminated drinking water, the most important mode of spread is close personal contact. There are some major features of epidemiology of hepatitis A that I would like you to know. The rate of transmission depends on the socioeconomic status, the family size, personal hygiene, and access to clean drinking water and sewage disposal. Secondly, the outcomes clinically depend on the age at infection. When infection occurs in the first 5 years of life, very few people get symptomatic infection. But as the age increases, once we reach adolescence, a large proportion of those who get infection will get jaundice, will get liver failure. And once infection occurs, irrespective of age, it leads to lifelong immunity. So these 3 factors lead to differing epidemiological patterns. This is what developing countries, say in Africa, have. Everybody gets exposed in the first decade of life, mostly without any symptoms, and they become immune, and hepatitis A is not a problem. This pattern seen in places such as Greenland, where till some years ago there used to be infection, but in the last 20 years virtually nobody has been infected, so nobody has antibodies till the age of 20. Suddenly beyond that a lot of people have antibodies, but they haven't seen disease in the last 20 years because the virus is not circulating. But then there are areas like US, UK that follow these 2 blue curves, and depending on what is the age at which seropositivity is 50%, this is classified as very high shown in red, low shown in green, and high or intermediate in the middle. Now, where do we fit in India? This is a paper published late last year, 2025, where nearly 15,000 samples collected for a COVID-19 sero survey across 20 states and 1 union territory in people aged 6 to 30 years were studied. And this is what they found. In India, across the whole survey, in the age group of 6 to 10 years, seroprevalence was 65%. This is different from 90% that we used to talk about earlier. 11 to 15 years, it was 76%. And these people who were born more than 20 years ago, it was 93%. So this is what we used to talk about. However, India is not one. And if you look at different areas, I'm sorry for this overlap. If you look at Kerala, their 50% positivity is reached only at the age of 25. So if you look at Uttar Pradesh, you see even now at the age of 6, the seropositivity is already 85%. So this is the pattern like we see in Africa. In West Bengal, here, it is somewhere in the middle. So seropositivity is very different across different parts of the country. That is why in the areas where there has been socio-economic development, Kerala, to some extent West Bengal, improved hygiene, there is a reduced force of transmission leading to people getting infected at an older age and symptomatic disease, whereas in Uttar Pradesh, infection still occurs very commonly in childhood, and therefore we don't see so much of clinical disease. Of course, a state is again not homogeneous, and there is variability between the higher and lower socioeconomic groups. There are vaccines available, mostly inactivated, but some live attenuated vaccines are also available, which are imported from China. Manufacturers recommend 2 doses, but WHO has clearly shown that 1 dose is adequate. So also for this vaccine, even with CLD, seroconversion rates are good. Response is weaker in decompensated cirrhosis, but not as bad as for other vaccines. And we can use these vaccines in cirrhosis. However, you need to think whether a particular patient needs or not. You need to look at age group. If a person is above 30, they were born in the era when they would have got infected in childhood. They are unlikely to be not having been exposed, so you don't need to give it to that. It depends on geographical location. Things will be different in UP and in Kerala. In UP, I would be very reluctant to give this vaccine because even today, children have been exposed. It also depends on cost. But if you decide to give it as early as possible. Hepatitis E, already Dr. Rao has discussed, so I'm not going to speak, even though I may have some differences of opinion on that, but I'll stop there. Now let's come to systemic diseases. Influenza. Influenza vaccine, there is a poorer response to vaccine in people with chronic liver disease, 70 to 80%. But if you go to decompensated cirrhosis, the data are very limited. In transplant recipients, if transplant was done in the last 4 months, response rate, antibody production rate is only 14%, and it increases as you go farther from transplant. There are inactivated trivalent or quadrivalent vaccines. Also, some live attenuated vaccines are available. In the healthy population, the protection that it gives is 35% to 60%, varying from year to year, and that's in the US. Whose strains the vaccine is developed for? And most of the recommendations are from those countries where everybody, every adult is advised this vaccine every year. Should we use this in India? To me, the applicability of this to Indian cirrhotic patients is not clear. The disease burden is unclear. We don't know how many cirrhotics actually get influenza. It's not a vaccine that other adults are taking. There, because it's being given to all adults, the liver societies feel forced to say it for everybody with liver disease, but that is not for us. Our epidemiology is different. We have less marked seasonality. So they give it just before the season. Season is limited. For our cirrhosis patients, we don't have so much of seasonality, so it will not last for a year. Vaccine strains are different and cost effectiveness considerations. Pneumococcal vaccines, again, same problem. The antibody response is poor. In patients with chronic liver disease, when they were given this vaccine, antibodies appeared at 1 month, but they had waned by 6 months. And this is a vaccine that is supposed to be given once in 5 years. Now, what do we mean by that? And the applicability to India is questionable. COVID-19, it was useful. We said that instead of 2, liver disease patients need 3 doses. There are some data to show that giving further boosters is useful and it is advised in some countries. But in India, I don't think we need to discuss this because vaccines are just not available in the Indian market, so we can't discuss this. Let's come to childhood vaccines. These, for pediatric patients with chronic liver disease, should be given as specified in the National Immunization Program. But if you are dealing with a live vaccine, measles, rubella, or measles, mumps, rubella, which is not a part of the national program but is used as an alternative to measles, rubella by some, BCG, oral polio, and varicella, again not a part of the national program. These vaccines, you need to be careful, and you should not use them in people who have undergone renal liver transplant recently. But if they have had past 1 or 2 years since transplant and they are on minimal doses of immunosuppression, then these can be given. There are certain vaccines that are used in certain situations. For instance, rabies. Please, there is no reason why a person who's been exposed to an animal bite should not be given rabies vaccine. Rather, because the vaccine may not induce antibodies as quickly or in sufficient amounts, these are the patients where, in addition to vaccine, you should also use passive immunoprophylaxis, which means even if there is not sufficient indication to give rabies immunoglobulin, that should be given. So to summarize, friends, vaccines may be useful. So routine vaccines we should give, post-exposure vaccination we should give, with the proviso that passive immunization should be combined. Hepatitis B, yes. Hepatitis A, individualized. Influenza, pneumococcus, depends on you. I've listed the factors that you need to consider. But if you do decide to vaccinate early and complete vaccination at least 1 to 2 months before transplant. And in transplant recipients or those who have even some decompensated cirrhosis, do not use live vaccines. Thank you.
Thank you, sir. Due to time restraint, 1 or 2 questions from the audience.
Shout from there, no problem.
Dr. Rakesh,
This is regarding we see a lot of patients with hepatitis A now, and these are mainly adults. And this is, the notion is that since the water supply and all has improved, they are using the other water sources. That's why they did not get exposure in the childhood. That's why they are getting the hepatitis A. But why the hepatitis E? It should be the same pattern.
Hepatitis A and E, I have said that for years, we somehow mistakenly think that their routes of transmission are similar. They are both fecal oral, but hepatitis E mainly transmits through water. There is very little person-to-person spread. Hepatitis A is person-to-person spread because the number of viral particles needed for infection is much smaller for hepatitis A than for E. Remember, polio is also fecal oral. Do we ever say polio transmits through water? Hepatitis A is very similar to polio. It's person-to-person transmission. So even though we have cleaned up a lot for hepatitis E that works because you needed a large inoculum. For hepatitis A that does not work because we have not yet reached that level of cleanliness.
Okay, thank you.
Sir, many vaccines give lifelong immunity, for example, hepatitis B and also measles, rubella. So do we have data that infant who had received these vaccine in the infancy and as they develop cirrhosis, do their immunity wane? Do we have data to show this?
To the best of my understanding, those data are not there. For many of these agents, such as measles, rubella, because of my other interest, I know, to say what is the what is the protective titer is not easily known. So you would need to, see the disease. The problem with that is that in the developed world, you don't have measles, so they will never get exposed, so they don't get that. That's where you get data from. So that's why we don't have those data.
And India, we don't.
Sir,
you know how we are.
Sir, single one. Regarding the timing, why it is better to make it must for the vaccination in a compensated state? We should not wait for the decompensation or pre-transplant or post-transplant like this.
Absolutely. So that's what I said. You give it when it's likely to be most effective. So if you think that you want to protect a person, the moment you diagnose chronic liver disease, give it at that time if you want to give it. Don't wait. Not even, if you think you would need to give it, then you want to give, then you give it even before they get cirrhosis.
Thank you, sir.
Thank you.
Thank you, sir. Now for the next we have the panel discussion. I'd like to call upon stage the panelists. The topic is defining and managing difficult to treat SBP. The panelists that we have are Dr. Rahul Kumar, Dr. Swapnil Dhampalwar, Dr. Piyush Ranjan, Dr. Ramit Mahajan, Dr. Prajna Anirvan. And moderating the session, we have Dr. Nipun Verma.
Well, at the outset, let me thank whole organizing team of Bengal Liver Summit, Professor Akash and Professor Mahesh Goenka for this opportunity, and I bring greetings from PGI Chandigarh. So today we are going to speak about defining and managing difficult to treat SBP. And this term, difficult to treat, is not very well characterized in the literature. So we'll see how people have described it and how we should take it forward. I bring greetings from PGI. So the format of presentation would be that quickly I'll brush up some facts for SBP. I'll present a case, discuss the management options with the panelists, and finally come to a conclusion and consensus. So we all know SBP is a spontaneous infection in the ascitic fluid without any surgically treatable cause. We all understand that it is because of bacterial translocation, bacteremia, seeding the mesenteric vessels, and then subsequently going the bacteria into the peritoneum and leading to the host response, which we define it as leukocyte count above certain level. It's common. It is several things have to fail, as Dr. Bajaj has mentioned, to cause SBP, which also pertains to a concept, emerging concept of immune failure in patients with cirrhosis. Culture proof evidence is limited in majority of our individuals because of paucibacillary disease, and the mortality is quite high, about 30% in global cohorts. In Indian cohorts, it is little more, 40% or so. And we must understand defining infection also includes the detection of pathogen along with the clinically apparent immune response, and systemic inflammation is operationalized with the criteria of SIRS, and sepsis and infection is not same. Sepsis connotes the organ failures and which is characterized by worsening in SOFA scores. For SBP, a presence of bug with neutrophil count above 250, which we take it today as infection. Presence of systemic signs is in the form of leukocytosis and fever is SIRS, and development of organ failures, we call it as sepsis. So all three connotes different things, and the outcomes are different in patients who just have infection vis-a-vis who have organ dysfunctions or sepsis. And we all understand the classification. I'll just quickly take you through the case. A typical case, who's a 40-year-old male consuming alcohol in large amounts over last 10 years, with recent intake in last 1 month, comes to us with jaundice and ascites over last 1 month, with reduced urine output, and he has a recent hospital stay of 2 days and some antibiotics which we don't know. There is no fever, no on examination there is hepatomegaly, parotidomegaly, and the signs of chronic liver disease. There is presence of marked ascites, grade 3. On investigations, patient was found to have leukocytosis. It was neutrophilic dominant, 22,000. The bilirubin was 12, conjugated fraction being 8 milligram per deciliter, AST, ALT being elevated 200, INR 2.3, creatinine of 1.6, lactate of 2, sodium being 130, and the albumin levels were low, 3 grams per deciliter. His ascitic fluid count showed 300 cells, 60% polymorphs, ANC count of around 180, low protein, high SAG, normal ADA, no malignant cells. So I would like to start the question asking Dr. Rahul, what do you think this patient is having, and what empiric treatment would you start?
Yeah, I think your serial tabs has shown that patient has SBP, and that's right?
No, this patient has a ascitic fluid neutrophil count of 180 and systemic inflammation, recent alcohol intake, jaundice and ascites.
And how much is the PMN? ANC is 180, is it?
ANC is just 180. And this patient has leukocytosis. This patient has a background picture of alcoholic liver disease and recent alcohol intake coming to jaundice,
I
ascites.
get it now. So I will still, very wary about brewing SBP.
Okay.
The tap is probably a little bit early, and although we are not hitting the numbers.
Right.
And since he has total whites that is raised, looks like that he may have a little bit of systemic inflammation going on.
Right.
And whether to start him on empiric antibiotics, my choice is always yes to when I feel that the patients are not, looking very well. And I start a little bit early, then wait for patient to deteriorate and show clinical signs.
Right. So I want to ask the opinion of audience and other panelists. How many of us think that this is alcoholic hepatitis? I think almost all of us, right? So this patient has alcoholic hepatitis fitting into ACLF by any of the criteria, EASL or APASL, has a single organ failure which is liver. The cultures are sterile. He has been started on volume resuscitation, albumin, nutrition, and alcoholic hepatitis based treatment with nutrition and thiamine. The real question is, how many of us actually consider that this is all sterile inflammation and not sepsis causing organ dysfunction because of infection? Can I have a show of hands showing that, what do you think? This is an infection? How many of us think that this is an infection? And how many of us think, is this sterile inflammation, alcoholic hepatitis, nothing else? So I think some of the doubt is still persistent. The ascitic fluid counts are yet not to the fulfilling the criteria of SBP, but still a patient who has a renal dysfunction, the likelihood of infections is close to 60 to 70% compared to patients who do not have renal dysfunction who are admitted in the hospital. So based on this observational evidence, empiric antimicrobials have been used. Now the real question is, what would you give? Would you give ceftriaxone? Would you give piperacillin tazobactam, carbapenem? What antibiotics? Dr. Amit?
His counts are 180.
Yes.
That might be because he had received antibiotics for 2 days.
Yes.
So this might have come. Earlier it was SBP, and now it's coming down actually.
Yes, and outside it was, the patient ascites was not tapped, and it is possible that there was higher counts before.
Right. So here, as Sir just mentioned, the patient is having a severe liver disease. He's got ACLF3 because he's got renal dysfunction, he's got coagulopathy as well, and he's got a severe alcoholic hepatitis, all of which make his probability of dying around 60 to 80%. So this could be a partially treated SBP. So here, the patient coming from another hospital would be treated like a healthcare associated SBP, and we should be starting PIP-TAZ.
Okay, so that's what we also did. This patient was started on piperacillin tazobactam. In next 2 days, the patient's condition worsened. The bilirubin increased to 20, INR also worsened. Renal failure sets in, and there is a new onset hepatic encephalopathy. The MELD worsened to 37, CLIF-C also worsened. And Dr. Swapnil, would you repeat a sepsis workup here, because the initial cultures were negative and your empiric treatment was based on your best educated guess?
Yeah, definitely. We will repeat a complete sepsis screen by all means, looking sourcing all the possible sites, urine, blood, ascitic fluid cultures, specifically in blood culture bottles, imaging. Right. And based on the current, giving piperacillin tazobactam to the patient is still worsening, we will try to hike up the antibiotic cover.
Right. So I'd request short answers because we have limited time. So this patient had worsening of ascitic fluid counts. Now the patient is fulfilling the criteria for SBP. The ANC count increased to 300. There is culture negativity, and the patient was subsequently hiked up from piperacillin tazobactam to meropenem and teicoplanin, again empirically based on educated guess that this could be a multi-drug resistant or a ESBL organism, which we call extended spectrum beta lactamase infection. But patient condition subsequently also worsened. And what happened next is, I'll be taking you through subsequent slides, but do you think this patient is a difficult to treat case, Dr. Amit?
So difficult to treat SBP has been defined as either infection with MDRO organisms or in a patient who has got a sick background, like this patient is now fitting into ACLF3. So obviously these are the two defining characteristics of difficult to treat SBP.
So right. So the two broad concepts which characterize difficult to treat SBP is the poor or the inadequate response to empiric choice of antimicrobials, and second, certain conditions where the SBP is linked to higher mortality. And when do we say there is an inadequate response to empiric antimicrobials? It is either the bacteria which is resistant to the antimicrobials, or there is a bacteria or a fungus which is not being appropriately treated with the empiric choice of antibiotics. Or there could be a surgically treatable cause which we failed to identify, and patients were given empiric antimicrobials in not the appropriate dose, so that antimicrobials are not reaching to the site with actual PK/PD targets. So in this given patient, Dr. Rahul, do you think there is a setting for secondary bacterial peritonitis? Well, I think this is very clear that, but what's your opinion? Could there be underlying secondary bacterial peritonitis in this patient?
Although the question is very good, like whether there is secondary bacterial peritonitis, when patients with cirrhosis who has PMNs high, who have been put on antibiotics, the differentiation between spontaneous and secondary may be just about semantics. There is an infection that is going on which we get to treat, or which we need to treat. So to answer your short whether there is a possibility, yes, of course there is a possibility that something else may be happening.
Yes, so there is a possibility, but given the condition that there was no surgically treatable cause, ultrasound was not showing any perforation, the counts in the ascitic fluid were not very high, the protein levels were not very high, and the criteria was not being fulfilled as described in this slide. Do you think, Dr. Amit, it could be tuberculosis or atypical bacteria?
For tuberculosis, when we calculate the SAG and the protein, the fluid protein should be high. So here there was a low protein ascites, I suppose.
And
the
again,
atypical
the
bacteria can be
ADA was also
ADA
12,
was
so
also
I think it practically rules out. So these two broad conditions are practically ruled out. So is this patient harboring multi-drug resistant infection, Dr. Swapnil?
Yeah, could be because of past hospitalization and recent broad spectrum antibiotics. However, we need to prove that by cultures.
So in your practice, when do you consider a patient to harbor a multi-drug resistant infection? And you can take help of this study also.
So in the clinical setting that the patient has a prior hospitalization and recent broad spectrum use antibiotics and a sick phenotype, then the likelihood of an underlying MDRO is high.
Right. So in this patient belonging to India, per se it's a risk factor. Broad spectrum antibiotic use, healthcare exposure, site of infection, especially in SBP, and outcomes are actually worse in patients who have multi-drug resistant infections. If we ask ourselves, do we have a data from India to show what is our local epidemiological patterns of SBP? So till now, there are very few studies showing 20 to 30 isolates, just handful of studies where data is available for epidemiology. So 2 years back, with 13 centers, this study was initiated in PGI, where we conducted a pan-India survey for culture-proven infections over the last 5 years. We could only get 319 patients with culture-proven infections, 2 minimum, but it gave us the prevalence of multi-drug resistance, which was close to 50%. And again, extended spectrum beta-lactamase infections, which are resistant to third generation cephalosporins, and the choice of antimicrobials there is piperacillin tazobactam or carbapenems. The carbapenem resistance has actually gone up to 30%, and if you see this community acquired infections also harbor multi-drug resistance close to 30-35%. Right. So this is our local epidemiology, and the risk factors identified were again presence of circulatory failure at presentation, nosocomial or healthcare setup, leukocytosis, the level of leukocyte count, that is this degree of systemic inflammation was again a predictor of multi-drug resistance, and the SBP prophylaxis, as we have heard from the previous speakers, that it is increasing the risk of multi-drug resistance. So while knowing the fact that this patient can have multi-drug resistance or carbapenem resistance, we are again making an educated guess as to what empiric choice of antimicrobials we have to give. And so since this patient was not responding and this patient has worsening of organ failures, do you think response step can be a useful tool? Dr. Amit, do you think, and why?
So response tab as per the EASL and the ASLD guidelines is shown to be very beneficial. So at 48 hours, if the patient shows a persistence of polymorphonuclear cells of more than 250 or a response less than 25%, or the patient is still symptomatic, has abdominal pain, tenderness and fever, it would suggest the patient has an infection with something else.
Right. So this was based on very old data, 1983, reduction of PMN by 25%. Was more seen in patients who survived, 92% compared to non-survivors, and this was based on the PMN half-life of 24 hours, but this was very old study. Now there is a recent study from Dr. Garcia Sao's group where they showed that it is not only 25%, it is also dependent on the host severity. If the patient's host severity is MELD score is above 30, then 80% decrease confers the maximum benefit in terms of patient outcomes. So they classified these patients into low risk with MELD of less than 30, more than 80% drop, and the risk of mortality was less than 6% in these patients. Whereas patients who have higher MELD score, less than 80% drop in PMN, and so this is a useful tool as to early suspect difficult to treat SBP so as to downstream optimize your diagnostic and therapeutic pathways. This is very important concept, and we must all remember that early response guides patient outcomes.
Nipun, can I ask you one question?
Yes.
Is it mandatory to do a repeat tap in patients with low risk and patients who are clinically improving?
Yes.
That definitely in this patient it is mandatory.
Mandatory. So I would say the exact condition where the patients are low risk, improving, but a patient who has a higher risk of multi-drug resistance like nosocomial infections, previous hospital stay, and the disease severity is high, we must do a response tap to assess. There may be differences of opinion in this because the evidence, RCT evidence is not there for it. Observational data do support it.
Yeah, can I just add to that point? I can speak about our practice back home in Singapore. If the patients are improving, we don't even do the second tap, because second tap tells you what is going to happen, but it doesn't tell you a point of action, what you're going to do with this information. If I'm not going to use this information, I'm just going to predict whether the patient is going to die or not die, the future will show.
So again, I'll take this point further because this is very important point. If we know that this patient is difficult to treat at the admission, we can downstream optimize our diagnostic and therapeutic pathways. I'll show you that data recently emerging. And I just want to show that patient's outcome is just not dependent on one thing. There are several factors. Apart from the effective first-line therapy, killing the bacteria, it is the host which has to come back. And the host severity in terms of severity, genetic risk factor, polymorphisms in terms of pattern recognition receptor polymorphisms, and resistance to antibiotics, everything confines. In this patient, actually, there was ineffective first-line therapy. We don't know what was the bacteria in this patient. This patient has a high severity ACLF, and there could be multi-drug resistant bacteria. In global study where we could understand that MDROs, CROs have a higher risk of death, ACLF in grade 3 with SBP has a higher risk of death, and community and non-community acquired, there is no difference in the outcomes. It is only based on the type of bacteria and the severity of disease, which is the most important. So summarizing our patient so far, patient has a risk factor for MDRO, CRO, but that emerged from day 3 onwards. There are multiple risk factors for mortality in this patient. There is a suspicion of bacterial versus fungal infection in this patient, and largely we have ruled out the atypical and secondary bacterial peritonitis. So how do we reach to a diagnosis in a patient at the outset so that we don't miss the patient's progression to multi-organ failures where the patients are likely to die even if we give the appropriate antibiotics? So that is the whole point of discussion today. So I wish to know the opinion of panelists. Can rectal colonization mirror the same pathogen in the ascitic fluid? What's your opinion?
So we routinely do rectal CRO in our patients in whom we are planning to start carbapenems, and if the rectal CRO is positive, then we tend to change the antibiotics from carbapenems to other antibiotics, maybe pylorus or
any
polymyxin B.
difference?
Yeah, the data, imaging data shows that the rectal swabs are quite ineffectual in predicting what the bacteremia or the complications are. There are two different things. It doesn't predict in summary. But earlier theories or earlier concepts were that we used to do rectal swab thinking that these are the organisms which we might find if the patient gets sick. Yeah.
So the emerging literature, this is Barcelona and Germany, they showed that those who are colonized, they are likely to get the infection by the same bacteria. The concordance is 80% in the Barcelona, and Germany it was 90%. And now there is another study which is longitudinal study, multiple time points, every 3 months colonization was tested. Patients were followed up for 2 years, and they could, I'll just take 5 more minutes. So another 2 years they were followed up, and they could show that the concordance between the infective pathogen and the colonizing bug was 97%. Our experience from PGI also demonstrates the similarity in 76% of individuals because our area is very high burden. So almost 70% of our patients actually have colonization, but patients who get infection, you can actually find the same bacteria in the colonization. and that can actually guide you your empiric treatment. And this has been recommended by surviving sepsis guidelines, experts from Europe, that patients who have negative cultures, who are worsening, you can adjust your antimicrobials based on surveillance. Again, this is best educated guess with some preliminary evidence. We demonstrated this in a randomized control trial whether this strategy can improve the patient outcomes. This was awarded Young Investigator Award in EASL last year under peer review now. A lot of criticism coming, and single center, high burden. This is just a proof of concept that this strategy can improve the patient outcomes if we use the colonization as a guide. Now people are moving towards more advances in the diagnostics. Malditov based the pattern of bacteria in LCMS can actually be mapped to the drug-resistant bacteria, and we can find out what is the type of multi-drug resistant bacteria just doing Malditov from Bactec bottles. NGS is something which is coming up in a big way, and in this patient, as we suspected, difficult to treat at the outset, NGS or a molecular test can actually increase the pickup of not only pathogens by bacteria but also by viruses and fungi. And in this study published 2024 showed that patients who were having sterile ascites when underwent molecular testing for specifically taking out the DNA from ascitic fluid and looking at the type of bacteria in them and the resistant genes, the presence of yield of diagnostics improved. Not only bacteria, the viruses and fungi were identified much more than cultures, and that could increase the sensitivity specificity. BioFire is another tool used to pick up a lot of pathogens, not only bacteria, yeast, viruses, and antimicrobial resistant genes, and it can improve the patient outcomes. And this was beautifully shown in these two studies that using NGS-based diagnostics can actually improve the decision making for antimicrobials in about 50% of individuals.
Nipun, we have to cut short a little bit. From the organizing committee,
Okay.
it's a request to you that we have to.
Okay.
Yeah, I'm Kingshuk from here.
Okay.
Yeah, please, Nipun.
Okay. So I'll just take one more minute, and finally in our patient, this patient was treated with empirical escalation of polymyxin B, tigecycline and anidulafungin because there were risk factors for non-improvement and fungal risk factors, but patient succumbed with 4 organ failures. And I think there is something which we need to do more beyond the guidelines for patients with suspected difficult to treat SBP, patients who are at high risk of mortality, patients who have MDRO. I think the colonization and molecular testing should be integrated. More data needs to be generated, and randomized control trials need to be done. And based on the drug-resistant patterns, let's say we have a multi-drug-resistant bacteria identified through NGS. You have carbapenem-resistant genes in them. You can actually guide your ceftazidime, avibactam, astronam combination, especially targeting specific type of resistant genes in these bacteria. And PKPD is something different. I'll not go into the details. Infusions improve patient outcomes. Increasing the dose, loading dose in the initial 48 hours can improve the patient outcome because the drug levels goes 12 times above the MIC levels and actually kills the bacteria and abrogates the mutagenic window of bacteria. And there are several research concepts which are emerging, like integrating the host response or treating the host response along with infections. Especially this paper, Lancet, just come that adding interleukin-1 receptor antagonist with the in patients with pneumonia can improve the patient's organ dysfunctions, which could improve the patient outcomes, but overall mortality was not different in this RCT. So I'd like to end this presentation mentioning that so the algorithm should be that we should suspect a patient to have difficult to treat SBP at the outset, especially if there is a setting of MDRO with high mortality. Start empiric antimicrobials based on your local epidemiological patterns. If you don't have that, you should look at the colonization status or molecular tests if available. And lastly, ancillary therapies in terms of organ support should not be underlooked. because the patient outcomes is dependent not only on pathogen treatment but also on the supportive therapies and the host management. And several research arenas include modifications of gut microbiome, eco-evo strategies, immune modulation. GM-CSF is one paper from ILBS, phages, antimicrobial peptides, which we could have gone in more detail, permitting the time. Thank you very much for your kind attention.
Thank you, Dr. Nipun. I would request all the chairpersons, speakers of the previous sessions and panelists to stay back for a group photo.
Swayambhu, one question please. Can we allow one question?
Okay, sir.
Yes, Dr. Nipun, excellent case you have described, but I'm just a different bit of idea of what you have presented in the last concluding slide. Antibiotic choice should be on the basis of the epidemiological study or antibiogram in hospital. The case we have described, forget your SBP part, count 20,000, renal failure, one organ failure, lactate of 2. Despite is it SBP or not, if you have at all to start with the antibiotic, first antibiotic comes into play, carbapenem. Why? Because 70%, if you take all the ICU throughout India, it is 70% ESBL, 60 to 70%, 30 to 40% are MDR. So what we did, we started meropenem in that case. Personally, I am giving my input. And after 48 hours, or if in between we are doing the static tab, we are getting the worsening report, immediately we go to add on polymyxin B or antifungal or tigecycline, whatever we think. Because the rule is that you have to strike it hard. Either it is systemic or it's a local, because it's a high MELD score, alcoholic hepatitis, one organ failure, lactate, and more than 20,000 count. So I think then the result will be maybe different. What we have shown that patient succumb, it may be patient will not succumb. You have started.
Point is well taken.
Yeah.
Point is well
Thank
taken. The problem lies with the fact that not all patients are started on carbapenem in all hospitals, and hospital policies differ. There must be differences of opinion.
No, sir. For this patient I have mentioned, because of this risk factor, it should be started with meropenem.
Yes, thank you.
I think we need to stop here and come for a good protocol, please.
So as we have the photo session in progress, we would move on to the last session for the day. It's Before We Part, Life Lessons in Hepatology. And for this session, I'd request the chairpersons, Dr. Pradeep Bhaumik from Agartala Government Medical College, Tripura, Dr. B.B. Pal from Peerless Hospital, Kolkata, Dr. Bijay Mishra from Utkal Hospital, Bhubaneswar, and Dr. Rajat Khandelwal from Apollo Multispeciality Hospital, Kolkata, to come on stage, please, and request the chairpersons to commence with the session.
Hello. Good afternoon.
There are two talks in these sessions. One is the ascites and AKI, 5 mistakes and lessons I learned from Professor Virendra Singh. The other one is ACLA, 5 mistakes and lesson I learned, Dr. Professor P.N. Rao. So first will be by Dr. Virendra Singh. You now you talk.
Yes, thank you, sir. Probably this is the session where we will learn from the giants of the hepatology. So nothing more to speak. I request Dr. Virendra Singh to please start your deliberation.
Thank you very much. I am thankful to the organizers of this conference, Dr. Goenka, Dr. Akash Roy, and Dr. Ghosal. And I'll be speaking in next 15 minutes regarding the ascites and AKI. See, there is nothing very special in this, but what we commonly commit mistakes, I'll be highlighting those. This is a 42-year-old male, an alcohol consumer in the significant amount. Last alcohol intake 6 months back, presented with the progressive abdominal distension for 15 days. He had thrombocytopenia, sodium was low, creatinine was 2, bilirubin was 2.5 and 1.4. The OTPT were mildly raised, albumin was low, INR was 1.5. Hepatitis B surface antigen and anti-HCV were negative, HIV was negative, the anti-HBC total also was negative. Patient was carrying 1 week old report of the renal function test. The serum creatinine that time was 1, and the ascitic fluid did not show any SBP. So the serum creatinine has risen over a period of 1 week. So this fits into the definition of AKI. See, so this patient is having a decompensated cirrhosis with AKI. So what should we do? There is any doubt, no doubt regarding the AKI, so we started with the albumin for 48 hours and then terlipressin. But the repeat serum creatinine did not come down. This was 2 only. So where is the problem? The problem is that we have to find out the other cause, maybe some infection. The mistake which we probably did was we believed the SBP negative report of the previous hospital. So what we did a repeat diagnostic tap and showed a SBP. This is what happens. This is a common mistake. We believe the other report, or not only the other report. Sometimes what happens, we have admitted patient, we did the diagnostic tap, the cell count is not fitting into SBP, as happened in the last case, which Nipun showed. And when the response is not proper, then you repeat it, then you do the diagnostic tap, then the SBP diagnosis is made. So this was SBP, and the urine did not show the proteinuria or the microhematuria, or the RBCs were not there, and there was no abnormal renal ultrasonography, and he was treated with the IV cefotaxone and the albumin. And we continued. On day 3, the serum creatinine came slightly down, 1.5, and the urine output could not be measured in last 6 hours. This is the AKI definition. I will not go into the details. These are the different types, HRS1 and HRS2, the HRS AKI and the HRS NAKI. This is the gross difference between the ATN AKI and the HRS AKI. In ATN AKI, there is a history of nephrotoxic drugs or the bacterial infections or proteinuria, hematuria. The urinary sodium is higher, and when you do the angel, this will be raised. In HRS AKI, there is no history of the nephrotoxic drugs, bacterial infections are negative, proteinuria is not there, and the urinary sodium also is low. Patient continued on antibiotic, and then the serum creatinine came down to 1. So the first mistake which we did, we started the treatment for AKI. We should not have started unless you have ruled out other causes of AKI. So this was the first mistake. Then patient came after 6 months, and we did the upper GI endoscopy. There were large esophageal varices, no RCS, no GOV, and the CTP was 9, MELD was 16, creatinine was 1, sodium was 132. He was put on the spironolactone and the torsemide, 50 and 5 mg. Norflux prophylaxis was continuing, and there was no past history of upper GI bleed. So this patient needs a primary prophylaxis for varicose bleeding. What should be done? Whether we should put this patient on beta blockers or do bending. See, this is a question. And this patient was started on the beta blockers, 40 mg per day. Both are equally effective, and various studies have proven, and putting these patients on propranolol is very easy. So, and this is, the meta-analysis has shown that the beta blockers are better than the no therapy or the placebo for the prevention of the varicose hemorrhage. And the 19 RCTs have also shown that the NSBB and EVL were equally effective, and there was no difference of mortality. And the NSBB or the EVL can be used to prevent the first varicose hemorrhage in patients with the medium or large varices. Then after 8 months, patient came with the decreased urine output for 1 week. LVP was continuing. He required LVP in last 2 months. The sodium was again low and creatinine was 2.7. The proteins were low. INR was 1.8. We did the ascitic tap. There was no SBP. Then, since there was a raised creatinine and the hyponatremia, we stopped the diuretics and started on albumin. Even after starting albumin for 48 hours, we repeated the serum creatinine, which was again 2.6 only, so not much improvement. So this was HRS-AKI stage 2, and the urine volume was 500 ml in 24 hours. Urine sodium was 14, and protein was 244 milligram. MAP was low in this patient, 64 millimeter of mercury. So this was HRS-AKI stage 2, started on terlipressin and the albumin, and then on day 3, the serum creatinine came down to 2.2. But again, this was not adequate. See, we should look at the response in such patients. See, if you do the response, non-responder, if the serum creatinine decreased by less than 25% of the pre-treatment value after 48 hours, partial responder, if there is a decreased creatinine by more than 50% from the pre-treatment value to a final value of more than 1.5, and complete response when this has gone down to less than 1.5. So here this is a patient which showed no response. So what we did, we stopped the propranolol in this patient and then continued terlipressin and albumin, and on day 6, the serum creatinine came down to 1.2. We continued the treatment of terli and albumin, and on day 8, the serum creatinine became normal. So the second mistake which we did in this patient was stop diuretics only and not the beta blockers after development of AKI. So we should stop the diuretics as well as the beta blockers and start treatment for AKI in these patients. Then after 12 months, again, another problem in the same patient. He presented with the upper GI bleed. He was undergoing the LVP thrice in last 2 months. The platelets were low. The sodium again was 121. The creatinine was 1.2. Bilirubin was not much raised. The protein was low. And the INR was 1.8. Ascitic fluid did not show SBP. And he underwent upper GI and the varicose bending was done because he came with a bleed. Beta blockers were stopped and terlipressin was started, which continued for 5 days. And then when we discharged this patient, we also started this patient on propranolol. And at 14 months of follow-up, then the ascites kept on increasing. Creatinine was 1.2, sodium was 130. We increased the dose of the diuretic, the spironolactone and the torsemide, and continued the Norflux prophylaxis. Propranolol was continuing in the same dose. After 1 week, the MAP was 68 millimeter of mercury. Serum creatinine further went up, and the serum sodium was 120. So this was definitely a case of refractory ascites. And for this management, we stopped the diuretics, and the ascitic fluid did not show SBP. Now the question is whether we should stop the propranolol or not. See, it is very difficult to control ascites because this is a refractory ascites. So we stopped the propranolol. So now the question is tricky here. For the secondary prophylaxis, we have to use the dual things, the beta blocker as well as the EVL. So what to use for the secondary prophylaxis? Ideally, both beta blocker and the bending are required, but using beta blockers in refractory ascites makes ascites control difficult. Therefore, We again committed a mistake by using beta blockers for the primary prophylaxis in a patient who is likely to develop refractory ascites and varicose bleeding. So, used beta blockers for the primary prophylaxis in a patient who was likely to develop refractory ascites and varicose bleeding. So, use varicose bending only for the primary prophylaxis in such patients. Then after 17 months, the same patient came with the LBP thrice in last 2 months. And then the sodium was again low, urea and creatinine was 70 and 1.1, bilirubin was 2 and 1.2, the INR was 1.4, the ascitic fluid, there was no SBP. So there was a hyponatremia, and this was dilutional hyponatremia. For moderate hyponatremia, we usually control if it is between 120 to 125, use the water restriction to 1000 ml per day and stop diuretics. You can take help of the albumin infusion. After 24 hours, the serum sodium became 121. He was started on tolvaptan 15 mg per day. Patient became lethargy next day. After 24 hours, the serum sodium was 130. So our patient developed the osmotic demyelination syndrome. Rate of increase of the serum sodium should not exceed more than 8 milliequivalents per day in 24 hours. Our patient's serum sodium increased to 9 milliequivalents per liter per 24 hours, and this might have been due to the malnutrition in our patient. So these are the guidelines. We should not increase the sodium very fast, and especially you have to be careful in patients who are the malnutrition. So the fourth mistake was that used tolvaptan in a patient who was having malnutrition. We will have to be very careful in these patients. And then after 19 months, presented with the jaundice worsening ascites, decreased urine output, and he was again following the routine of LVP thrice in 2 months. And sodium again, here was 127, the creatinine was 2.2, bilirubin was raised 7 and 4.1, enzymes were quite high, and the INR was 2.5. The ascitic fluid did not show any SBPs. IgM anti-HAV, IgM anti-HEV, anti-HCV all were negative. HbSAg was positive. And the IgM anti-HBC also was positive. And HBV DNA was 3000 units. So the diagnosis here was ACLF. The acute was the acute HBV hepatitis. The chronic was cirrhosis because of the alcohol. He was put on tenofovir. See, so this was the fifth mistake which we committed. Did not vaccinate for hepatitis B. So we should be very careful in dealing with such patients and vaccinate them for hepatitis B. So to conclude, do not start treatment for AKI unless you have ruled out other causes of AKI. Stop diuretics as well as beta blockers after development of AKI. Use beta blockers for primary prophylaxis in patients who are likely to develop refractory ascites and varicose bleeding. Use tolvaptan carefully in patients who are having malnutrition. Vaccinate for HBV all patients with the cirrhosis who are HbSAg and total anti-HBC negative. Thank you.
A very, very educative lecture by Professor Virinder Singh. So I think we can have the discussion in a joint manner after Professor Rao gives his lecture. So his topic is ACLF, 5 mistakes and lessons I learned.
Thank you very much. Unlike Professor Virinder Singh's scenario, where it's more or less standardized for quite some time, our ACLF is different. Concepts have been changing over years, so although I must very much try to see the case basis, but it was not possible for me. So I will do the generalizations I will tell. Can I have my slides, please? Yeah. So I would rather slightly change, as said, rather than the mistakes, and I said the clinical pitfalls and the clarifications which I am seeking. And ACLF is like a big ocean, and like all the oceans, the waters collide with each other while keeping their independent identity. And I would see that it is only wine in a different bottles labeled differently. And that's what is ACLF ultimately, that's what. And why the ACLF matters is that it remains one of the most challenging syndromes we encounter. I'll come to my mistakes a little bit later because this prologue is important for us to understand what are the mistakes in general which we have done or the pitfalls, clinical pitfalls. It is characterized by the rapid deterioration, immune dysregulation, and frustratingly narrow therapeutic window. And then multiple definitions, not only these 7, there are more 13 or even 30 definitions have been proposed earlier, what is an ACLF. And because of these variations in the definition itself led to the challenges in the diagnosis, management, and research in ACLF due to the inconsistencies across the regions and the populations. And this simple looking depiction, you can see that just concentrate on the lowermost row, that irrespective of whatever definition if you use, as the disease severity increases in ACLF, the mortality is almost identical. Well then, regarding the definition, this is a wonderful thing which from AIMS it has come regarding the definitions. And if you see here, the Americas have used more of an easel cliff definition than their own Naxal definition for an ACLF. And most of the Europe and the Mediterranean countries have stuck to the easel cliff definition. Southeast Asia and Western Pacific have mixed proportions. So what definition are you using it in your patients, That's again a big question for us, for us to analyze. This, of course, yesterday Akash Chaudhary has shown you that they are trying to combine and then come to a proposed unified ACLF definition, that is the Kyoto consensus which is there. And this is out of the box, but still I wanted to talk about this one. This is a recent review and the meta-analysis confined to the compensated liver disease because according to our APASL definition, even the compensated liver disease or a chronic liver disease, underlying erstwhile chronic liver disease is also prone for ACLF provided you have an acute hepatic insult. And this interestingly, the comparisons between the China and India have been brought out in this particular thing. The 90-day mortality appears to be similar. You will notice that alcohol remains an important precipitating acute insult and cause of the underlying chronic liver disease in an Indian context more than the Chinese context. And also, over the time, it has changed from viral to the alcohol, alcohol becoming both as an acute insult and also the underlying liver disease, both is the more changing patterns are also, in the last 10 years, changing patterns have been depicted in this particular article. Well then, what are the pitfalls which we had? Initially, I reserved the diagnosis of ACLF for patients with overt multi-organ failure, often waiting for major laboratory escalation before labeling it. What is the lessons learned? Early identification of an ACLF, particularly the grade O or a pre-ACLF. This is another term which is now increasingly used as a pre-ACLF is critical. And dynamic monitoring of a system inflammation, circulatory changes, and subtle renal dysfunction. Just now, Virender has told you how important is these subtle renal dysfunction changes, especially with the creatinines, can facilitate a preemptive interventions. Evidence, data from Canonic and then APASL ARC studies highlight that timely recognition and early organ support substantially reduce the 28-day mortality. regarding the pre-ACLF, this is the one with the easel cliff, they have said. And you know that there are differences are there. I don't have to tell you about this one. Acute decompensation, further decompensation, and an acute decompensation is not considered in APASL definitions, but there it is considered as this one. What are they? Because on the right-hand side, you can see, to make it more complex, and they have, again, the 6 clinical phenotypes have been projected. And acute decompensation, we know that. Non-acute decompensation, what is that? They are defined as a so-and-so, occurrence of a progressive liver-related complication that does not lead to the hospitalization. That means when it comes to the OP, and then that is a non-acute differentiation. And they also said SDC, UDC, pre-ACLF, that is a stable decompensated cirrhosis and unstable decompensated cirrhosis and a pre-ACLF. I mean, this is how, if you get in this, already we are confused with, we are totally immersed, what is the definition itself. Now, the subtypes have come, 6 clinophenotypes, which one are you following? The last one, if you see pre-ACLF, who develops an ACLF during the 3 months of a follow-up, they call it a pre-ACLF. According to the definition, he will not fall into ACLF. So this is the confusion, which you cannot bring a case based in ACLF now. This is what they said. But ultimately, whatever definition you follow, but both agree on one aspect. That is that the scoring systems which they have said, they are much better than the usual things which we follow. There's a MELD-NA, and then CPT scores. But of course, ARC said, ours is better than the Cliff score on the right-hand side, what you see, but that's not going to matter much. Well, then what is important is that to differentiate between organ dysfunction and organ failure. On the left-hand side, you can see that what are the criteria for the organ dysfunction. This is irrespective of whichever definition you follow, because organs dysfunction and failure do not follow the rules of your criteria, whether it is easel or a cliff. They follow their own criteria. So the similar criteria is that the important thing to see is that you have to identify, and at the time of an organ dysfunction, prevent them from going to the organ failure. That is the most important point which one has to make it. Second pitfall is that the liver-centric management approach, focusing primarily on the hepatic parameters while underestimating the systemic dysfunction, especially the renal and then circulatory failure. Lesson learned, ACLF is a multi-system inflammatory disorder with the liver as the primary insult but not the only target organ. Evidence multi-organ dysfunction, not the liver enzymatic elevations alone, will determine the prognosis. Well, then, what is important, irrespective of whatever you feel, what is the acute insult is the one which is you have to remember. On the right-hand side, you see that the ASIL acute insults which are there, that is alcohol and then infection. On the right-hand side, lower panel, you got then our ARRC, ACLF, what are the acute insults? As you know that they are primarily liver-related hepatic insults are there, that is the hepatitis B reactivation, AS, DILIs, and so on and so forth. And whatever it is, we have to identify what are the acute insult which is causing the organ failure, and at that stage itself, and one has to act upon this one. Right then. Third is that underestimation of sepsis as a central player, treating infection as a secondary phenomenon, or assuming that the sterile inflammation in an apparently uninfected individuals. Lessons learned, sepsis often acts as both as the trigger and propagation of an ACLF. Up to 60% of an ACLF cases in South and East Asia and also in the other have infectious precipitant, most commonly bacterial dislocation. And Vipul has told you already that they are not to forget the fungal infections, and then upfront one has to look for it, especially they have been on antibiotics. So on the left-hand side, you can see the algorithm which NACSELD, that is ASLD, ACLF, they follow, because theirs was entirely different trajectory. They were mainly concentrating right from the beginning on the infection part in a cirrhosis liver, but later they termed it as ASLD, ACLF guidelines they have given, they have got it. And you know the 7-day therapeutic window which the ARC has been propagating, that is the SIRS and then sepsis and then organ failure. So you have to, the first therapeutic window is the golden period at which time you have to act upon very severely. 4 is that a delayed liver transplant referral. Pitfall is that deferring the transplant referral due to hopes of a spontaneous hepatic recovery or an organ recovery, pending the stabilization of the other organs. Lessons learned is that the window for transplantation is very narrow and unpredictable in an ACLF. Evidence, survival in ACLF grade 3 beyond 28 days without an urgent transplantation is a dismally 15%. And for this, all the 3 associations have given their guidelines. And the EASL CPG guidelines 2004 says that delaying the liver transplantation for patients with a severe ACLF, ACLF 2 or 3 according to their grading, increases the risk of a wait list and post-transplant mortality. So early recognition is important. And the ASLD, they said that expedited liver transplant for patients with the cirrhosis and ACLF and or critical illness may be indicated in selected patients because their patients are entirely different. They are patients who come with infection itself. Whereas the ACL ARC says that, and in general, they said that they taken as a more than 11 ARC scoring and then to categorize early recognition for patients with who are referred for the transplant. And in general, they have taken that the ARC score of 8, that's a grade 2, is associated with the non-transplant mortality risk of 20% at 4 weeks, which can be considered as a minimal R score cutoff to ensure the benefit of an early LT, right? When indicated, early liver transplantation avoids complications of a sepsis and then multi-organ failure. 5th is that neglecting the non-medical determinants of the outcomes. While understanding the behavioral, nutritional, and socioeconomic factors. Lessons learned, recovery and long-term outcomes hinge equally on psychosocial, nutritional rehabilitation, and then alcohol relapse. And then I don't have to tell you that nutrition has been the most important, one of the most important things, while you are treating the other aspects, nutrition is usually neglected. And all the associations, and then everyone says that the nutrition is a very, very important factor. There are some more, but I restricted to 5, which is as directed, and thank you very much.
Thank you, sir.
Request the
Now the
chairs
session
only
is
to
open
take
for discussion.
1 or 2 questions, please, for the lack of time.
Thank you, sir, for the nice presentation. Now the session is open for discussion.
I have 2 questions. One question for Professor Virinder Singh. Sir, actually you used tenofovir 300 milligram, but as we saw in your slides that most of the time this patient had renal complications. So would sir tenofovir would have been would entecavir or tenofovir alafenamide would have been a better choice than tenofovir? Your comments, sir.
See, the standard practice is giving the tenofovir. There are not many studies regarding the TAF, and we could have given TAF also in this patient. They are equally effective, but this patient was under our follow-up, and we have started him on the tenofovir. These are all old patients.
What our general practice is that sometimes these have occurred earlier when entecavir resistance has occurred in some of the patients. Then we have done it this one. If it is there, you can still use the but give spacing. Give it an alternate day or gives it with twice a week in this one, and then carefully follow the creatinine. That will.
Dr. Virendra, you showed us that how the sodium went up with tolvaptan, and it was 9 milliequivalents in 24 hours, and you said the usual should not be more than 8. But you can't predict in a given case. So how do you see to it that we know sometimes tolvaptan, the sodium goes up very rapidly. So how do you control, and how do you don't know before you start the tablet that what will be that rate of rise? Put the mic on, please.
Sir, you can
The best way in these patients is look at the malnutrition, look at the history of alcohol, and if they are having malnutrition and they are having alcohol intake also, in that case you give the lower dose.
This was
you
15 milligram. You gave 15 milligrams.
But I gave 15 mg, that was the mistake. And then we can give 7.5 mg, or what we can do, we can repeat sodium after 12 hours. So early recognition will be, suddenly we repeated the sodium level after 24 hours. And by the time the report came, patient was already in the altered sensorium.
But was there a requirement to increase the sodium? It was 122.
See, he was having a tense ascites. It was 120, 121. So these patients, if they have tense ascites, if you put them on the tolvaptan, the diuresis is very fast. So hoping that the sodium also will improve, and then the ascites also will get controlled. So we started on the tolvaptan. This is not a one patient, we use it many times. It is quite frequently used by me. But I have to be very careful. One, the creatinine should be normal. Second, the MAP should be adequate. It should not be low. And there should not be any SBP. And now we also look at the malnutrition. If the patient is having a good nutrition, there is no SBP, the creatinine is not raised, the MAP is good, then only I will use it, otherwise not. And another precaution which I take is, we put them on the midodrine for at least for 2 days, and then build up the MAP, and then from 3rd day onwards I put them on the tolvaptan. You can see the response is phenomenal. See, those patients, they come with the tense ascites, and then you can see the urine output goes from 2 liters to 3 liters. It is like a tap opens. So this is very useful drug, not so commonly used, but you have to be very careful, especially in these situations, as well as encephalopathy. If patient is having encephalopathy, do not give, because the thirst is there. He will not be able to take water, so he will develop the renal dysfunction. So these are various problems. Try to give a lower dose if you are putting them on the OPD, and otherwise use tolvaptan when the patient is in hospital.
Another knee-jerk reaction by most of the residents is that, start them on 3% saline, this is another thing, and very carefully this one. In fact, in some of the cases when the patient is completely okay, that means he is able to take, even oral is good enough, if he doesn't have any other symptoms.
See, the problem which is committed by, the mistake which is committed by the intensivists or the general physicians, this is what Dr. P.N. Rao is saying. See, they prescribe the salt capsules also. They come to know that the patient is a cirrhotic, having ascites, and they come to know that the sodium is 120. They will immediately put them on the salt capsules, and patient will come with the tense ascites. And some of them will develop the renal dysfunction. So they have to be very careful. Don't give them the salt. Don't put them on 3% hypertonic saline. If somebody requires a immediate correction, means if they are for the renal transplant immediately, liver transplant immediately, then you can give them the 3% saline. Otherwise not.
I have got one question for Professor P.N. Rao, and I think Professor Goenka can also answer this.
Yeah.
Sir, you said about this liver transplant, so in SELF. So how early should we refer a patient immediately to the liver transplant unit? Suppose he lands up in a hospital where I work, which does not have liver transplant facilities, but I have a patient of ACLF who has, so am I mistaken if I refer this patient immediately for transplant? ARC score round about 11. Say day 1, day 2, I refer it. Or I wait, I give the different treatments, and then I refer to, I think Dr. Goenka knows about it. Yeah. So
No.
this question I think is very important.
Request for a brief
Yeah,
answer,
yeah.
sir, for the
And then,
time.
you see, the easel cliff, they are entirely different. Theirs is a cirrhotic population, decompensation, that they are different things. They are already listed, and they clear and then put them onto the transplant. Whereas ours is that is an acute insult and then a hepatic insult. And then in these patients, even if hepatitis B reactivation started also, they may not improve very immediately. It takes quite some time for them. And that's the reason the ARC, they said that this therapeutic window is 7 days. That is the most important thing before they develop any infection. After they developing the infection, you will not be able to do anything. That's why they said in first 7 days itself, you have to decide in a way. The other things like a delay precipitation, they are all unpredictable.
Thank you, sir. Thank you all the chairpersons and Professor Virender Singh and Dr. P.N. Rao. Please join us for a group photo. And with that, we come to the close of the 20th session. And
3 minutes to 5 minutes validity function, just at the end of it. So please stay back. The lunch is open. You can have it outside or inside the faculty room, wherever you're comfortable. We have some other assignments for the post-lunch. So those who are here, I'll just tell you that we have a Physician Connect program, which will be in the Hall B, starting at 2:30. This is primarily to educate and interact with the physicians. And then we have a public awareness program in this hall, where we expect not only a public of Calcutta, but also some press to interact. Akash, can we have the announcements? So I'll use this opportunity to thank everybody for being here. Some of the people have already left, are in the process of leaving. We had very interesting abstracts, I think. What was the total number, Akash? 106 abstracts came, which is a large number for a midterm INASL meeting. And we had several sessions which ran parallel to this, where we had various levels of presentations. These included oral presentation, distinct posters and presidential posters, and general posters. So Dr. Akash will tell you the results. I'll request Nipun, Dr. Nipun Verma, who represents INASL here. Dr. Dhiman and Dr. Ajay Duseja is already on the way back home. So Nipun, can you join us on the stage? Nipun, as you know, is from PGI Chandigarh. So I have a special affinity for anybody who is from PGI, including Dr. Virender Singh.
Yes. First of all, thank you to all the students, whoever are here. You have traveled from far, and it's actually you who make all these midterm INASL important, because this imparts knowledge to you. So we had 4 different sections that we are divided into. Firstly was the general poster section. So the second prize in the general poster section, and if you are there in the hall, please come over, and if your friend is there, please come over. Dr. Gokul Vasu for the second prize in general posters. Dr. Gokul Vasu, are you there?
You're Dr. Gokul? Your friend. From which place are you? Stanley, Chennai.
The first prize for the general poster section goes to Dr. Shami Das. Dr. Shami Das is from Apollo Multi-Speciality Hospital, and he gets the first prize for general poster section. Now we have posters of distinction. Here also we have 2 prizes. First of all, the second prize for the second best poster of distinction is Dr. Jasvinder Nain. Dr. Jasvinder Nain, if you're there.
Anybody knowing?
Anybody?
Somebody come.
Yeah, I think Manu. So Jasvinder is from PGI Chandigarh doing PhD out there. The first prize for the best poster of distinction goes to Dr. Adil Kalam. Dr. Adil Kalam. He's from Army Hospital R&R. Congratulations. So we had selected total of 8 presidential posters, and from them we have the best presidential poster, Dr. Amresh Kumar Mishra. Dr. Amresh, if you are here, anybody from the team? Anybody? Okay, we'll pass it on. Now we come to the oral plenaries. We had 6 oral plenaries selected from those 106 original submissions. The third prize for the oral plenary goes to Dr. Abik Haldar from PGI Chandigarh. Abik's work was on rifaximin in myosteatosis. He's from PGI Chandigarh, currently an MD student. Congratulations, Abik. Now we have a very special award for the second prize in the plenary session is somebody from Singapore. We had 4 abstracts from Singapore. This is from Changi General Hospital, Singapore, Dr. Saktivel Elangovan for his work on chronic kidney disease in ACLF. And the first prize for the best oral plenary goes to Dr. Naga Saujanya Chamurthy from AIG Hospitals, Hyderabad. She has a work done on the GAT score and HCC algorithm. Dr. Naga Saujanya from AIG Hospital, Hyderabad.
Thank you, everybody. Thanks for being here. And I must use this opportunity to thank the whole team of Apollo Multispecialty Hospital, the consultants, the residents who worked relentlessly for a couple of weeks to a few months. And of course, the audiovisual team, the hotel team, the event people, the Maisha. And special thanks to Dr. Kinsuk Das and Dr. Swambhu for carrying on throughout from the first minute to the last minute of this whole Congress. If I have to ask any question about liver disease now, I'll be asking Kinsuk and Swambhu because they must be saturated with knowledge on liver. Thank you very much. See you again on next Bengal Liver Summit.
Check. Hey. Hmm. 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 Hmm.
Mr. Khandelwal, should I start? Second ko first kar. So good evening, everybody. This is Dr. Mahesh Goenka. I'm the director and head of Institute of Gastrosciences and Liver Transplant at Apollo Multi-Speciality Hospital. I thank all of you for joining us today for this evening. As you may be knowing that we were doing a big meeting where we had huge number of international faculty as well as the national faculty who had come to this place. And over the last 3 days, we deliberated on the advances in liver disease. But I thought this is also a right opportunity to interact with people in general and also with press to tell you about liver disease. What we have planned is that there will be about 3 or 4 talks, and after that you can ask us any questions or ask for any clarification. So the first talk will be by Dr. Uday Ghoshal. Dr. Uday Ghoshal is a senior gastroenterologist and head of luminal gastroenterology at our hospital. So he would talk about liver disease as such, and then I will talk about fatty liver disease, and then we'll open for discussion. And then there are 2 more talks which we'll take later on. So maybe Uday, you can start with, and then I would follow it up.
Okay, what is this? Acha. Good afternoon. Dr. Goenka already introduced করলেন আমি 2.5 years ago Apollo Multi-Speciality Hospital Kolkata join করেছি. Okay, I was earlier in Sanjay Gandhi Postgraduate Institute of Medical Science as head and professor. Now I joined here to particularly take care of luminal gastroenterology. So if you look at from mouth to anus, adult, the GI tract is 9 meter. So this 9 meter GI tract, মানে আমাদের মুখ থেকে নিচে পর্যন্ত GI tract যে পাইপটা রয়েছে তার দৈর্ঘ্য হচ্ছে 9 মিটার। এই 9 মিটার কি করে ফুডটাকে আমরা যে খাচ্ছি which gives us energy, that food is digested. Digested মানে হজম করলো, and তারপরে ওই ফুডটা আমাদের পুষ্টি যোগায়, and বর্জ্য পদার্থ অর্থাৎ excretion হচ্ছে যে ফুডটা which is not digested goes out. Now look at this liver. This liver is just the side of GI tract. It is about 1.5 to 2 kilogram, 1.5 to 2 kilograms. So God has given us a liver which is 1.5 to 2 kilogram. But we need only about half a kilo. So that means God has given us extra liver. কারণ এই লিভারটা very vital. Look at this. It helps in digestion. তার মানে ফুড যে আমরা খাচ্ছি সেই ফুডটাকে হজম করার জন্য পিত্ত লাগে। The food that we eat, to digest this food, you need bile. And this bile is produced by the liver. Second হচ্ছে whatever extra food we take, part of it is stored in the liver because nature wants that we should survive. So if we fast, আমরা যদি না খাই কয়েকদিন উপবাস দিই তাহলেও কিন্তু যাতে বেঁচে থাকি, that's why nature has given this organ extra size so that the food is stored. Next হচ্ছে ডিটক্সিফিকেশন হয়, তার মানে কি কোনো ফুডের সঙ্গে যদি এমন কিছু পদার্থ ঢোকে যেটা শরীরের জন্য ক্ষতিকর, লিভার সেটাকে ডিটক্সিফাই করে, পয়জনটাকে নিউট্রালাইজ করে। নেক্সট হচ্ছে আমাদের পূর্বপুরুষরা চরক সংহিতা, সুশ্রুত সংহিতা, they said all the diseases begin in the gut. That means heart attack, partly related to the gut, GI tract. Brain problem, partly related to gut. Because this liver and gut maintains our metabolic health. Metabolic health মানে লোক দেখুন, this is a fat man. Being fat is bad. So we must keep lean, not fat. So you'll say, how to know whether I am lean or not? Look at your height. In a male, in a man, if height is 150 centimeter, just subtract 100. So that is your ideal weight. So 150 centimeter man must be 50 kilo. And if it is a female, then subtract 105. So that means 150 centimeter height female should be about 45 kilo. So being fat is bad. Second thing is, who is the enemy of liver? Who is the major enemy of the liver? Alcohol. Alcohol is bad. So this is an enemy for the liver. Third is some of the food. If you take food in excess, particularly calorie-dense food, burger and all those. So then you become obese. And fourth is, interestingly, some medicine can be toxic. Some medicine can be toxic to the liver, and I'll tell a little bit. So what protects liver? What is friend of the liver? Look at this, black coffee. The black coffee helps to keep your liver healthy. Second is being lean, keeps your liver healthy. Third is exercise, keeps your liver healthy. Fourth is not taking alcohol, keeps your liver healthy. And if your liver healthy, you don't get aged early. Okay? Buda hai na taratari. Everybody wants to remain young. So if you want to remain young, please keep your liver young. You become fat, take a lot of alcohol, so then your liver become old early, and when your liver is old, you become old. So what is the safe limit of alcohol? Somebody will ask me. There is no safe limit, truly speaking. Truly speaking, there is no safe limit. It is best not to take it. But unfortunately, some people got addicted to it. Okay? Some people got addicted to it. And they unfortunately can't stop. Then what happens is that you take a small amount, like maybe 2 drinks or 1 drink a week type is good. Less is always better. Look at this. These are herbal medicine. And typically herbal medicines are propagated to be very healthy. They don't have side effect. একটা কথা আছে না, যে গরু দুধ দেয় সেই গরুই কিন্তু লাত মারে। তাহলে এটা হতেই পারে না, just there is a medicine which works, but it doesn't have side effect. No medicine in the world is safe. But what you have to do is, যে গরু লাত মারে তাকেও কিন্তু তার থেকেও কিন্তু দুধ নেওয়া যায়। Okay, you have to learn the art. Similarly, whatever drug causes side effect, these drugs we typically monitor. Suppose if I am giving a drug and I know that drug damages the liver, I will periodically test for liver function. But unfortunately, these drugs which are typically called herbal medicine, the ancient drugs of India, they are good. But if you are not regulating those drugs, the current situation is a little bit like this, then maybe not so good. So if somebody asks me to take this medicine, I will avoid taking. It is like an aeroplane which is not regulated so well, so there is a greater chance of crashing. Also, these drugs are in multiple. Like if I am giving one drug of our science, it is only one single component. But these drugs are typically having multiple component. Multiple component. হয়তো এমন একটা ওষুধ আছে যার মধ্যে 50টা ওষুধ আছে। তাহলে 50টা ওষুধ থাকার জন্যে you don't know which one is causing what and how they are interacting. So that's why it is better to avoid, But again, this is going to be a good science. Integrative medicine is a great initiative of the government. Every All India Institute of Medical Science type institute have a department of integrative medicine. So we'll find out in time what is safe. but till then, let us be controlled. Now, what is bad for the liver and body? Ultra-processed food. In fact, Professor Goenka took a beautiful lecture on ultra-processed food. What is ultra-processed? Let us look at that something is a meat, and that meat you are taking, which is there for 30 days, because it is preserved, it is packaged. Now, if the animal meat could be packaged for 30 days with chemical, what this chemical is going to do in our body, it is going to do the same what it has done to the animal meat. So do not take those food, very bad. They damages the liver, they damage the gut. So কোনো animal protein like মাংস যদি preserved হয়, ওই মাংসটাকে এমন সব কেমিক্যাল দেওয়া হয়েছে যাতে মাসের পর মাস ওটা থাকতে পারে, বাট সেই কেমিক্যালগুলো অ্যানিমাল মাংস আর আমার মাংসকে আলাদা করে দেখবে না। রিমেম্বার দিস। সো আল্ট্রা প্রসেসড ফুডস আর ব্যাড। নাও ড্রাগ ইনডিউস লিভার ইঞ্জুরি, হ্যাঁ অনেক কিছু ওষুধ আমরাও যেটা প্রেসক্রাইব করি, দে ইনজিওর দ্য লিভার, বাট লেট মি টেল ইউ, when we prescribe, we tell you that this drug is indispensable for your illness. এছাড়া আমরা চিকিৎসা করতে পারবো না। সেই জন্যে আমরা বলি 2 সপ্তাহ অন্তর বা 1 মাস অন্তর আপনার লিভারের টেস্টগুলো করাবেন। সেই লিভার টেস্টে আমরা ধরতে পারি যে 10% লোকে যদি লিভার ড্যামেজ হতে শুরু করেছে, সঙ্গে সঙ্গে উইল আইদার মডিফাই দ্য ড্রাগ অর দ্য স্টপ দ্য ড্রাগ। সো দেয়ারফর ড্রাগ ইনডিউস লিভার ইঞ্জুরি, at least in our science, is not such a great killer. Now, many common drugs, like many must be taking antihypertensive and diuretics and so many others. They may damage liver, but not very common, maybe occasionally, and we monitor. And thank you so much. Any question, I'll be happy to answer.
Thank you, Dr. Ghoshal. I must introduce the faculty on the dais. We have Dr. Akash Roy, who is our liver specialist working at Apollo Multi-Speciality Hospital. We have Dr. Robert Fontana, who is our international faculty, and he is from Michigan. He is the professor of gastroenterology and medicine from Michigan. And we have Dr. Ajit Bidoria, who has come from Rishikesh, All India Institute of Medical Sciences. And you already heard Dr. Uday Ghoshal. So Uday has introduced the subject, liver normal में क्या करता है, और यदि लीवर को आप प्रोटेक्शन नहीं करेंगे तो क्या हो सकता है, वेरियस डिजीज़ के बारे में उन्होंने आपको बताया. He also told about the drugs and the problem with the drugs. My job for the next 5 to 7 minutes is to talk to you about an epidemic. It's a global epidemic which I am talking about. It's a fatty liver disease. And I think fatty liver disease के बारे में बहुत सारे myth हैं. We have myths thinking that it is nothing big. Everybody has it, so there is nothing to worry. At the other end of the myth is कि ये बहुत बड़ी कोई चीज़ हो गई है. Actual fact somewhere बीच में है, और मैं ये next 5 से 7 मिनट में आपके साथ शेयर करना चाहता हूँ. So as Dr. Uday Ghoshal said, liver disease के कई कारण हैं, लेकिन common causes are alcohol. He talked about in alcohol in extreme form or in binge form. Viral hepatitis, particularly hepatitis C से fatty liver हो सकता है. ड्रग्स के बारे में डॉक्टर उदय घोषाल ने बताया. मैं केवल एक चीज़ बोलूँगा, ये एलोपैथिक मेडिसिन से भी होता है और आयुर्वेदिक मेडिसिन से भी होता है. एलोपैथिक मेडिसिन में स्टेरॉयड्स हैं, टीबी के मेडिसिन हैं, और ब्लड प्रेशर के मेडिसिन हैं. और होम्योपैथिक या आयुर्वेदिक मेडिसिन से, पर्टिकुलर आयुर्वेदिक मेडिसिन से, आज हमारा सुबह में डिस्कशन हुआ था हल्दी, जिसको हम बहुत एक सेफ बोलते हैं. हल्दी से सब लगता है काफ़ी कुछ ठीक हो जाएगा. डॉक्टर फोंटाना ने भी बताया द टर्मरिक से ही हैड केसेस व्हेन टर्मरिक टॉक्सिसिटी कॉज लिवर डैमेज. एंड हमने बेंगलोर से हमारे एक डॉक्टर आए थे, उनने भी ये बताया कि टर्मरिक या हल्दी से भी एक्सेस किसी भी चीज़ की अच्छी नहीं होती है. तो हल्दी भी यदि बहुत ज़्यादा ली जाए तो उससे भी हो सकता है. गिलॉय, हमने कोविड के समय बहुत गिलॉय लिया है, काढ़ा पीते थे हम 1 बार 2 बार 4 बार. Believe me when I am saying that we have lost lot of patients because of Giloy induced liver disease. Ashwagandha. Ashwagandha का नाम आप लोगों ने सुना होगा. It is supposed to be a magic medicine, but again we were told today that ashwagandha से भी liver की disease हो सकती है. So drugs are a very important cause of liver disease, genetic causes. But what I'm going to talk about is NAFLD. और मैंने बोला कि fatty liver disease एक global epidemic हो रखा है. पूरे वर्ल्ड में फैला हुआ है और शायद ये बीमारी जितनी है वो और कोई बीमारी नहीं है। यदि हम देखें अमेरिका में 25 से 37% ऑफ द पॉपुलेशन और इंडिया में भी करीब करीब 35% ऑफ द पॉपुलेशन। तो मोदी जी रोज बोलते हैं 140 करोड़ भारत, 140 करोड़ भारत। यदि आप 37% देखें 140 करोड़ में से, तो करीब करीब 50 करोड़ लोगों को फैटी लिवर डिजीज़ है। 50 करोड़ इंडियंस को फैटी लिवर डिजीज़ है और ये एक एपिडेमिक है जो हमें समझना पड़ेगा ना। ये एक ऑल इंडिया इंस्टीट्यूट से स्टडी हुई थी, मैंने कुछ पॉइंट्स हाईलाइट किया है कि इंडिया में प्रेवलेंस देखा गया था स्टडी में 38.6%, माने 3 में से 1 आदमी को फैटी लिवर डिजीज है। उसको हाई रिस्क है उनको 52%, समटाइम्स 60% को फैटी लिवर डिजीज होती है। और सबसे बुरी बात है कि बच्चों में, इन चिल्ड्रन ऑल्सो, पर्टिकुलरली इन द ओबीज चिल्ड्रन, इट कैन बी 63%. दैट मीन्स 2 out of 3 चिल्ड्रन हैव फैटी लिवर डिजीज। नाउ किसको ज़्यादा होती है? एंड वी जस्ट हर्ड मेटाबॉलिक सिंड्रोम। मेटाबॉलिक सिंड्रोम मतलब होता है एक कॉम्बिनेशन है एलिवेटेड ट्राइग्लिसराइड। ट्राइग्लिसराइड आप सुना होगा, लिपिड प्रोफाइल में हम करते हैं। रिड्यूस्ड एचडीएल, एचडीएल इज द गुड कोलेस्ट्रॉल। तो यदि लेस हो, ब्लड प्रेशर हाई हो, शुगर जिसको है या शुगर की मेडिसिन जिसको चल रही है, और डॉक्टर उदय ने बताया अबाउट बीएमआई और उन्हें फॉर्मूला बताया। लेकिन इंडिया के लिए यदि आपकी कमर का डायमीटर 90 सेंटीमीटर से ज़्यादा है मेल में और 80 सेंटीमीटर से ज़्यादा है फीमेल में, तो आपको ओबीज बोला जा सकता है या ओवरवेट बोला जा सकता है। तो इसमें से 3 यदि 5 में से हैं तो इसका मतलब आपको मेटाबॉलिक सिंड्रोम है। और मेटाबॉलिक सिंड्रोम जिसको है उसकी 60% चांस है कि उसको फैटी लिवर होगा। 60%, इट्स नॉट ए जोक, 60%। नाउ फैटी लिवर डिजीज का एक स्पेक्ट्रम है। हेल्दी लिवर, जिसको 5% से ज़्यादा फैट है उसको हम फैटी लिवर बोलते हैं। उसके बाद उसमें इन्फ्लेमेशन होता है, उसको हम नैश बोलते हैं या स्टिएटो हेपेटाइटिस बोलते हैं। और उसके बाद होता है लिवर सिरोसिस, और लिवर सिरोसिस एक प्री कैंसरस कंडीशन है, उससे कैंसर हो सकता है। तो यहाँ तक तो रिवर्सिबल है, मतलब स्टिएटो हेपेटाइटिस तक तो यदि आप केयर करें अपना, मैं जो बताऊंगा आगे, तो उससे रिवर्स हो सकता है। लेकिन एक बार सिरोसिस हो जाए तो आप कुछ भी कर ले, चांसेस ऑफ रिवर्सल इज रिड्यूस्ड इफ नॉट प्रिवेंटेबल। नाउ ये एक साइलेंट किलर है। NAFLD या फैटी लिवर या जो भी टर्म आप यूज करें, मोस्टली सिम्टोमेटिक नहीं होता है। मोस्टली आपको पता भी नहीं लगेगा कि आपको फैटी लिवर डिजीज है। और मोस्टली ये पेशेंट्स होते हैं जो एक अल्ट्रासाउंड करवाते हैं या लिवर फंक्शन टेस्ट करवाते हैं। একটা अल्ट्रासाउंड করলে কিংবা লিভার ফাংশন টেস্ট করলে বোঝা যায়, একটা ডাউট পাওয়া যেতে পারে যে ফ্যাটি লিভার ডিজিজ আছে। কিন্তু সিমটমস যদি হয়, ইট ক্যান বি ভেরি মাইল্ড সিমটমস লাইক ফটিগेबिलिटी, एनोरेक्सिया माने एपेटाइट कम हो गया, वीकनेस या वेट लॉस। सो ये एक अर्ली सिम्टम्स हो सकते हैं। और लेट स्टेज में यदि आप इसका ट्रीटमेंट नहीं करें और सिरोसिस डेवलप कर जाए तो जॉन्डिस, पेट में पानी होना या पैरों में पानी जमा होना, और कॉम्प्लिकेटेड केस में ब्लीडिंग होना या कोमा में चले जाना, दीज आर द एडवांस्ड फीचर्स ऑफ फैटी लिवर डिजीज। सो डायग्नोसिस कैसा किया जाए? जैसा कि मैंने बोला कि ज़्यादा टाइम आपको इन्वेस्टिगेशन, ये हेल्थ चेकअप्स होते हैं, ये करवाने चाहिए। हेल्थ चेकअप में पकड़ में आ सकता है, एक अल्ट्रासाउंड में एक डायग्नोसिस हो सकता है, या फिर ब्लड टेस्ट में SGOT, SGPT या ALT, AST जिसको बोलते हैं, वो यदि हाई है तो उससे भी समझ में आ सकता है कि हमको एक लिवर डिजीज है। लेकिन कई बार अल्ट्रासाउंड मिस कर सकता है, कई बार लिवर फंक्शंस एबनॉर्मल नहीं भी हो सकते हैं। तो अच्छा है कि एक रेगुलर मेडिकल चेकअप किया जाए। पर्टिकुलरली जिनको मेटाबॉलिक सिंड्रोम है, जो मोटे हैं, जिनको ब्लड प्रेशर है, जिनको कोलेस्ट्रॉल की प्रॉब्लम है, ट्राइग्लिसराइड है, जिनको ये दवाई मिल रही है, उनको रेगुलर चेकअप होना चाहिए। क्योंकि ये एक डिजीज़ है जिसको यदि अर्ली स्टेज में डायग्नोसिस कर लिया जाए तो इट इज़ टोटली प्रिवेंटेबल। तो यदि फैट देखना है तो अल्ट्रासाउंड इज वन मेथड, बट अब फाइब्रो स्कैन पे कैप बोल का एक स्कोर होता है, जो यदि 250-260 से ज़्यादा है तो फैटी लिवर डिजीज इंडिकेट करता है। और सबसे अच्छा होता है MRI DFF, जो इसके बारे में बोलूँगा। लेकिन फैट ना घातक नहीं, जब वो फाइब्रोसिस हो जाता है या स्कारिंग हो जाती है तब वो सिरोसिस की तरफ जाता है। उसके लिए हम इलास्टोग्राफी कई तरह की होती है, वो कर सकते हैं। सो ये होता है, को हम फाइब्रो स्कैन बोलते हैं। बड़ा इजी है करना, 5 मिनट का टेस्ट है, जिससे पता लग जाएगा कि फैट है, फाइब्रोसिस है कि नहीं। और जो हमारे पास अपोलो में हम रेगुलर यूज करते हैं और जो बहुत सेंसिटिव मेथड है, जिसको हम MRI PDFF कहें। ये देखिए, जब हम MRI कर रहे हैं तो ये नॉर्मल कलर ब्लू होता है, जैसे जैसे ये फैट जमा होता जाता है वैसे वैसे इसका कलर ग्रीन की तरफ होता जाता है। और इसके स्टेज से हम बता सकते हैं कि कितना फैटी लिवर है। ये मोस्ट एक्यूरेट वे विदाउट बायोप्सी होता है, जिससे कि हमें फैटी लिवर डिजीज का पता लगता है। करीब करीब 3 से 4 हज़ार रुपये का खर्चा होता है, इससे हमें एग्जैक्ट परसेंटेज ऑफ फैट पता लग सकता है। ना मैं 2 या 3 मिनट और लूंगा कि हम ट्रीटमेंट है तो मेनली है एक्सेस वेट कम किया जाए। जो भी एक्सेस वेट है उसको कम कीजिए। वेरी इंपॉर्टेंट, और इसके लिए एक्सरसाइज इंपॉर्टेंट होती है। एरोबिक एक्सरसाइज होती है, एनारोबिक एक्सरसाइज होती है, योगा से भी फायदा हो सकता है, बट मोस्ट इंपॉर्टेंट है डाइट करना। द वेट लॉस, यदि आप 3% भी वेट लॉस कर लें, आपका यदि वेट 80 किलो है, उसमें से 3% भी कम कर लें तो फैट कम हो जाएगा, स्टेटोसिस कम हो जाएगा। यदि 5% कर लें तो इन्फ्लेमेशन कम हो जाएगा, और 10% कर लें तो फाइब्रोसिस कम होने के भी चांसेस हैं। तो इट इज जस्ट अ मैटर ऑफ योर 80 kg ऑफ वेट, यू रिड्यूस इट बाय 8 kg एंड देयर इज अ वेरी गुड चांस that your fibrosis will come down, and the best method of reducing the fat. Diet क्या लिया जाए? I think this is an healthy diet. इसको हम कई बार मेडिटेरियन डाइट बोलते हैं। मेडिटेरियन डाइट का मतलब हो गया फल लिया जाए, सब्जी लिया जाए, और जैसा कि डॉक्टर उदय बोल रहे थे कि अवॉइड व्हाट इज अल्ट्रा प्रोसेस्ड फूड। ये चिप्स होते हैं, कुकीज होते हैं, आइसक्रीम, ये सब अल्ट्रा प्रोसेस्ड फूड होते हैं। कोला, इवन डाइट कोला, जो हम सोचते हैं कि डाइट कोला बहुत अच्छी चीज़ है, डाइट कोक लेते हैं कि भाई कोई कैलोरी नहीं जाएगी, उसका यदि अंदर देखा जाए तो उसके अंदर अल्ट्रा प्रोसेस्ड फूड होता है। ये एक हेल्दी डाइट है जिसको मेडिटेरियन डाइट बोलते हैं। ये सब समय संभव नहीं भी हो सकता है हमारी इंडियन डाइट में, लेकिन आई थिंक इसी के आजू बाजू घूमना चाहिए और हमें उसी तरह का डाइट लेना चाहिए। तो यदि क्या डूज एंड डोंट्स हैं फैटी लिवर के लिए, तो ईट होल ग्रेन सीरियल्स, इंक्लूड मोर सैलड इन योर मील्स, ईट फ्रूट्स इन बिटवीन मेन मील्स, यूज नट्स लाइक आमंड्स एंड स्प्राउट्स, ईट होल फ्रूट इंस्टेड ऑफ फ्रूट जूस, एंड प्लान फॉर फूड। डोंट टेक मोर ऑयल, फास्ट फूड एंड फ्राइड फूड अवॉइड करना है, स्वीट पेस्ट्रीज, बेक फूड्स अवॉइड करना है, रेड मीट अवॉइड करना है, एल्कोहल एक लिमिट के बाहर अवॉइड करना है, एक्स्ट्रा सॉल्ट नहीं लेना है। ट्रीटमेंट और भी हैं, मैं इसमें ज़्यादा डिटेल्स में नहीं जाना चाहता। विटामिन ई और कई तरह की मेडिसिन हैं, कई बार सर्जरी की ज़रूरत पड़ सकती है, लेकिन जो मैं कहना चाहता हूँ कि ये प्रिवेंटेबल डिजीज़, ये क्योरेबल डिजीज़ है, लेकिन अर्ली डायग्नोसिस होना बहुत ज़रूरी है। ये हमारी टीम है अपोलो की। इसके बाद मैं डॉक्टर रॉबर्ट फंटाना को बोला इन हिज टर्म्स, इफ़ ही वांट्स टू स्पीक अ लिटिल बिट टू आवर जनरल पब्लिक फॉर द अवेयरनेस। डॉक्टर फंटाना, Dr. Robert Fontana, will you like to make some comments? And then I'll request Dr. Ajit Bhadoria to briefly tell you about preventive hepatology. You want to come here?
Yeah.
Yes, thank you for having me here on this wonderful meeting and venue. It certainly is, as we heard, this is a worldwide problem. And the U.S., where we've had excess calories and poor diets for many years, we're really suffering the consequences of this with very high rates of obesity, as high as 50 to 60%, diabetes, and then now we're seeing the hepatic component or the fatty liver. But it's not all doom and gloom. There are things that we all can do as a community, and that's part of the point of these types of programs, is to sort of educate the leaders and the members of the community to know that you can be empowered to do something about this. But it's hard work because those ultra-processed foods taste very good. They're your favorite foods, and they're marketed to all of us. Whereas we're learning we need to go back in time and get fresh foods and vegetables. That takes more time, and all of our societies have sped up. So we don't want to take the time to make a meal. We'd rather buy something off the shelf, and particularly things that are preserved for long periods of time have additives to them, and that's also not good for your liver, yet alone your general health. So I think my message would be that this is a worldwide problem. It's not unique to India. It's in China, the U.S., Europe, etc. That we need to start paying more attention. And the solutions come on an individual level, metal level, and sort of a governmental level. Certainly in the U.S., we're starting to see changes in the way that foods are labeled so that the average person who's not necessarily a medical provider can begin to learn what is an ultra-processed food and what's more of a natural food and what's better for you. So we have a long ways to go with education, but I certainly hope that you'll leave here today realizing that there's things that we all can do as individuals and as part of our own communities to tackle this problem. Thank you.
Thank you, Dr. Fontana. The last talk for today, and this will be just 5 minutes, will be Dr. Ajit Bhadoria, who has come from Rishikesh All India Institute, and he will tell you about how we can prevent the disease. कैसे हम prevention कर सकते हैं. उसके बाद हम question लेंगे, both from our respected friends from the city as well as from the press. Dr. Bhaduria.
थैंक यू सो मच। आप सभी को नमस्कार। मैं ऋषिकेश से आया हूँ योग से। यू नो इट इज़ इंटरनेशनल कैपिटल फॉर योगा। सो मैं इसमें जो स्लाइड्स में मोस्ट ऑफ द थिंग्स दे हैव बीन रिपीटेड बता दिया है आपको बार बार। तो लीवर के बारे में जो चीज़ आपको मुझे लगता है जानना ज़रूरी है कि लीवर इज़ अ वेरी इंपॉर्टेंट ऑर्गन। लीवर इंपॉर्टेंट ऑर्गन क्यों है? क्योंकि ये हमारे शरीर का एब्डोमेन का सबसे बड़ा ऑर्गन है, 1.5 किलो का होता है जैसा सर ने बताया था। इस 1.5 किलो के ऑर्गन में अगर आपका 60 किलो का शरीर है, उसमें इस 1.5 किलो के ऑर्गन में 25% हमारे हार्ट जो ब्लड है वो पंप करता है इस ऑर्गन को। तो आप खुद ही सोच लीजिए, अगर टोटल 100% में से 25% ब्लड हमारा कहाँ जाता है? लीवर में जाता है। तो दिस इज़ हाउ इट इज़ इम्पॉर्टेंट। और इस 25% के अलावा काफ़ी ब्लड या जो भी हम खाना खाते हैं, जो भी हम वॉट एवर वी ईट, वॉट एवर वी ड्रिंक, हर चीज़ हमारी इंटेस्टाइन से डाइजेस्ट होके सबसे पहले लीवर में जाती है। लीवर उस पर चेक लगाता है एंड देखता है क्या चीज़ अच्छी है, क्या चीज़ ख़राब है। जो चीज़ अच्छी है हमारे लिए यूज़फुल है उसको आगे भेजता है, जो चीज़ उसको लगता है ख़राब है वो खुद अपने पास रखता है और ट्राई करता है उसको ब्रेक डाउन करके उसको नष्ट करने की। इस प्रोसेस में कई बार वो अपने आप को नुकसान पहुंचा लेता है। अब ये कौन कौन सी चीज़ें हैं जो हमारे लीवर को नुकसान पहुंचाती हैं, जो बता चुके हैं। एक तो वायरल हेपेटाइटिस है। तो हेपेटाइटिस की बीमारी 5 तरह की होती है, A, B, C, D, E, जिसमें आपको ध्यान रखना है A और E जो होता है वो फीको ओरल ट्रांसमिशन से होता है। मतलब अगर किसी इंसान को हेपेटाइटिस A है तो उसके पॉटी के रास्ते से वायरस निकलेगा, वो वाटर को या फूड को कंटेमिनेट करेगा। अगर हमने अपने हाइजीन का ध्यान नहीं दिया या पानी कहीं कंटेमिनेट हुआ वो हमने पी लिया, या खाना या कोई सब्जी फल जहाँ पर वो कंटेमिनेट साफ धुली नहीं है वो हमने खा लिया, तो उससे हमें हेपेटाइटिस A और E हो सकता है। इसमें कुछ % में लीवर फेल तक हो जाता है। तो अच्छी बात यह है कि हेपेटाइटिस A की वैक्सीन है, हेपेटाइटिस E की वैक्सीन है। जहाँ पर लगता है डॉक्टर्स को कि उनको वैक्सीन देना चाहिए, उनको वैक्सीन देते हैं। हेपेटाइटिस B, C और D जो बीच वाले 3 हैं, ये HIV की तरह फैलते हैं। HIV हम सब जानते हैं HIV के बारे में। तो HIV फैलता है अनसेफ सेक्स से, अनसेफ ब्लड से। तो अगर इस तरह का कुछ भी एक्सपोजर होता है तो हेपेटाइटिस B, C और D आपको हो सकता है। अच्छी बात यह है कि B को हम प्रिवेंट कर सकते हैं वैक्सीन से, C को हम प्रिवेंट कर सकते हैं टेस्ट कराकर, दवाई लेकर। बहुत अच्छी दवाइयाँ अवेलेबल हैं C के लिए, जिसे आप 3 महीने से 6 महीने खाते हैं और बीमारी जड़ से खत्म हो जाती है। तो आपके लिए जानना ज़रूरी है कि जो हेपेटाइटिस है उसके लिए हमारे देश में, हमारी गवर्नमेंट में नेशनल वायरल हेपेटाइटिस कंट्रोल प्रोग्राम चलाया गया है। तो आपके आसपास कहीं भी किसी को हेपेटाइटिस B या C होता है तो आप उसको बता सकते हो कि ये दवाइयाँ सरकार की तरफ से फ्रीली अवेलेबल हैं, तो वो जाकर इन सेंटर्स पे दवाइयाँ ले सकते हैं। दूसरी दो और चीज़ें हैं वो भी हमारे हाथ में। एक्स्ट्रा फैट है अगर हमारी बॉडी में, तो फैट को कैसे कम करें? फैट को कम करने का एक ही तरीका है, रेगुलर एक्सरसाइज करें और डाइट में ध्यान रखें। ऐसी चीज़ें नहीं खाएं जिसमें फैट ज़्यादा है। आजकल हमारा लाइफस्टाइल सेडेंट्री हो गया है, बैठे बैठे खाते अच्छा है, खाने की कमी नहीं है अब हमारे देश में। रात का खाना हमें बहुत अच्छा चाहिए। दिन भर हम काम करते हैं, फिर हम शाम को फ़ोन करके पूछते हैं घर पे आज क्या बनाए, फिर हम बहुत सारा खाना खाते हैं और टीवी देख के सो जाते हैं। और यही कारण है कि हमारे लीवर में, हमारे पूरे शरीर में एक्स्ट्रा फैट होता है। जब ये एक्स्ट्रा फैट हमारे लीवर के सेल्स में जाता है तो उनको नुकसान करता है। जैसा सर ने बहुत डिटेल में बताया कि फैटी लीवर से लेकर सिरोसिस और लीवर कैंसर तक हो सकता है आपको इस फैट की वजह से। ये भी हमारे हाथ में, अगर हम अपना ध्यान रखें, रेगुलर एक्सरसाइज करें, खाने पीने का ध्यान रखें, तो हम इस फैट से बच सकते हैं। चौथी जो चीज़ है वो है अल्कोहल, वो भी हमारे हाथ में। अगर हम अल्कोहल नहीं पिए तो जैसे सर ने बताया, देयर इज़ नो सेफ लिमिट ऑफ अल्कोहल। WHO कहता है देयर इज़ नो अल्कोहल विच इज़ सेफ फॉर लीवर। तो आपको अल्कोहल बिल्कुल नहीं लेना है। अगर आप शराब नहीं पीते हैं, फैट का ध्यान रखते हैं, वायरल हेपेटाइटिस से जैसे मैंने बताया, आप अगर उससे अपना ध्यान रखते हैं तो आप सारी लीवर की जो कॉमन बीमारियां हैं उससे बच सकते हैं। तो यही मैं कहना चाहूँगा आपसे, और बाकी आप लोगों के जो क्वेश्चंस हैं विल बी हैप्पी टू आंसर। थैंक यू।
हमने कुछ और भी तैयारियां की थी। डॉक्टर आकाश रॉय ने कुछ प्रिपरेशन किया था कि सिरोसिस क्या है, लेकिन मेरे को लगता है इससे अच्छा होगा कि आप प्रश्न पूछें और हम उसका उत्तर दें, रादर देन कि हम टॉक पे टॉक देते रहें। हमने जो मोटा मोटी बात बतानी थी, डॉक्टर अजीत ने बड़े संक्षेप में आपको बताया कि सारा हमारे हाथ में है। जितने कारण हैं, अल्कोहल है, ड्रग्स हैं, वायरस हैं, फैटी लीवर हैं, मोस्टली हम इसको इजीली कंट्रोल कर सकते हैं, प्रिवेंट कर सकते हैं, अर्ली डायग्नोसिस से ट्रीट कर सकते हैं। लेकिन आज हम जिसकी बात कर रहे हैं वो एक एपिडेमिक फॉर्म में है। आप समझिए कि हमारे देश में 40 करोड़ लोगों को यदि फैटी लिवर डिजीज़ है तो ये तो एक ऐसी डिजीज़ है जिसके बारे में हमें बार बार बात करना चाहिए, आपस में बात करना चाहिए, आप अपनी कम्युनिटी में बात करें, आप मॉर्निंग वॉक करते समय बात करें कि हम कैसे इसको कम कर सकते हैं। तो इसके बाद मैं आप लोगों को सबको निमंत्रण देता हूँ कि आप प्रश्न पूछें। हाँ, बच्चे को क्या क्या लिवर डिजीज़ होता है? बच्चे के लिवर डिजीज़ होने के लिए हम काफ़ी हद तक उसके लिए रिस्पॉन्सिबल हैं। ये मैं कल परसों एक टॉक दे रहा था यहाँ पर रात को, जब मैंने बोला कि हम सारे एडवर्टीजमेंट देखते हैं। मैं किसी कंपनी के बारे में नहीं बोलना चाहता, लेकिन वो आपने सुना होगा, बॉर्नविटा लीजिए बड़े हो जाएंगे बच्चे, तो वो चिप्स के एडवर्टीजमेंट आते हैं, कुकीज़ के एडवर्टीजमेंट आते हैं। ये देखा गया है कि जितने एडवर्टीजमेंट न्यूज़ में टीवी चैनल्स में आते हैं, 10 चैनल में 170 करोड़ रुपए एक साल में खर्च होते हैं इन प्रोडक्ट्स को प्रोपेगेट करने के लिए। 170 करोड़ रुपए, ये WHO की स्टडी है कि इंडिया में 10 चैनल एक साल में 170 करोड़ रुपए खर्च करके बच्चों को दिखाते हैं कि ये खाना चाहिए जो एक्चुअली नहीं खाना चाहिए। और ये क्या है? आइसक्रीम, प्रोटीन बार, चिप्स, कोलाज, पेस्ट्रीज, बर्गर्स। और आप अपने बच्चों को देखिए, यही तो खाते हैं वो। तो ये देखा गया है कि ये खाने पीने से ही होता है। जो ओबीज मोटे बच्चे होते हैं उसमें 60 to 70% में फैटी लिवर डिजीज होता है। और ये घातक इसलिए हैं कि फैटी लिवर डिजीज, जैसा कि मैंने बोला और आपने सुना, कि फैट से फाइब्रोसिस होगा, सिरोसिस होगा। इसमें टाइम लगता है, ये कम से 15 से 20 साल लग जाते हैं। तो यदि आपकी बीमारी 70 साल की एज में होती है तो उस सिरोसिस तक पहुंचने में टाइम लग सकता है कि नहीं भी हो सकता, उसके पहले ही भगवान आपको बुला सकते हैं कि बुला लिया ऊपर। लेकिन जो बच्चे को हुआ है, जो 10 साल की उम्र में जिसको बीमारी हुई है, वो तो इसकी बड़ी अच्छी चांस है कि 30, 35, 40 साल तक पहुंचते पहुंचते उसको सिरोसिस हो जाए और 50 साल तक पहुंचते पहुंचते उसको लिवर कैंसर हो जाए। तो इसलिए बच्चों के लिए ये बहुत इंपॉर्टेंट है कि बच्चों को कैसे फैटी लिवर डिजीज से अवॉइड किया जा सके। और मैंने इसको एम्फेसाइज किया है कि अल्ट्रासाउंड और ब्लड टेस्ट एक इंडिकेटर हो सकते हैं, लेकिन उससे अच्छा इंडिकेटर होगा जो सोफिस्टिकेटेड टेस्ट हैं जो आपके शहर में अवेलेबल हैं। MRI बेस्ड टेस्ट है, MRI PDFF हुआ, MRI इलास्ट्रोग्राफी हुआ, ये सब करके हम बच्चों की डायग्नोसिस भी कर सकते हैं। एनीबडी वांट्स टू ऐड समथिंग? डॉक्टर भिदोरिया।
इसमें बच्चों के लिए मैं एक और ऐड करना चाहूँगा, जो स्क्रीन टाइम है बच्चों का वो बहुत बढ़ गया। आजकल आपने देखा होगा मोबाइल पे लगे रहते हैं या फिर लैपटॉप पे काम करते हैं। तो हमें अपने बच्चों को मोटिवेट करना है कि वो घर से बाहर निकलें और खेलें। ये खेलने वाली जो चीज़ है वो धीरे धीरे करके हमारे बच्चों में कम हो रही है। मोटापा और फैटी लिवर, सर ने डेटा नहीं बताया, बच्चों में 35% बच्चों को फैटी लिवर मिलता है, विच इज़ इक्वलेंट टू एडल्ट। तो ये ऐसा क्यों हो रहा है? ये इसीलिए हो रहा है कि हमारे बच्चे घर में रहते हैं, बैठे बैठे टीवी देखते हैं, खाना बहुत अच्छा खा रहे हैं और या ऐसी चीज़ें खा रहे हैं जो कि बिल्कुल हाई कैलोरी हैं, पुअर इन न्यूट्रिएंट्स हैं। तो एक्स्ट्रा फैट बच्चों में बहुत जल्दी आ रहा है और ये आगे चल के ना सिर्फ फैटी लीवर की बीमारी, बट डायबिटीज़, हाइपरटेंशन, ये सब होने की चांसेस बहुत ज़्यादा हैं। तो अगर हमें अपने बच्चों को ये सब
प्लीज गांव में देखिए, आज से 3 डिकेड पहले क्या होता था? फुटबॉल होता था, क्रिकेट होता था, वॉलीबॉल होता था। आज नहीं है। आज मोबाइल है, इंटरनेट है, चैट जीपीटी है, फेसबुक है। तो वो देयर इज अ क्लियर कन्वर्सन। फुटबॉल, वॉलीबॉल, क्रिकेट, हाडू-डू-डू, गुली डांग चेंज हो गया टू इंटरनेट, चैट जीपीटी, एंड वो साइलेंटली हुआ। डॉक्टर ने नहीं किया, वो तो इंफॉर्मेशन टेक्नोलॉजी से हुआ। बट अगेन हमारा काम है आपको मैसेज देना, जो आपका मदद से हम फिर से बैक जाएं। हम अच्छी चीज वेस्ट का लें लेकिन बुरा चीज ना लें।
एक मैं न्यूज़ आप लोगों को देना चाहता हूं, और ये मैंने कहा था सैन फ्रांसिस्को, आप लोगों ने सुना होगा, द एक्सट्रीम पार्ट ऑफ अमेरिका। सैन फ्रांसिस्को ने 10 कंपनी को नवंबर के एंड में स्यू किया है। और ये कंपनी कौन सी है? पेप्सिको, यूनिलीवर। इन कंपनी को स्यू किया गया है कि आप जो प्रोडक्ट हमें दे रहे हो, हमारे बच्चे जो प्रोडक्ट खा रहे हैं, उनसे उनको बीमारियां बढ़ रही है। ये सैन फ्रांसिस्को के ऑर्गेनाइजेशन ने सारी कंपनियों को स्यू किया है आज से ठीक 1 महीने पहले। अब ये अमेरिका के कोर्ट में चलेगा। इंडिया में 2017 में एक बड़ी हाई लेवल गवर्नमेंट ने एक कमेटी बनाई थी, और उस कमेटी ने बोला था कि 2 चीज़ होनी चाहिए। एक तो है कि हर प्रोडक्ट के ऊपर में लिखाना होना चाहिए कि उस प्रोडक्ट का कंस्टिट्यूएंट क्या है, उसमें कितना अल्ट्रा प्रोसेस्ड फूड है, कितना कैलोरी है, उसमें आप देखेंगे कि डाइट कोक ने गलत लिखा हुआ है। तो मैं किसी कंपनी के अगेंस्ट में यहाँ नहीं बोल रहा हूँ, लेकिन हमें समझना पड़ेगा कि ये कंपनी फूड इंडस्ट्री है जिनको बड़े इन्फ्लुएंसर्स हैं। मेरे को पता है सम ऑफ यू मे बी इन द चेंबर ऑफ कॉमर्स ऑल्सो, बट उनका एसोसिएशन है चेंबर ऑफ कॉमर्स से, अमेरिकन चेंबर ऑफ कॉमर्स की मैं बात कर रहा हूँ, अभी कैलकाटा की बात नहीं कर रहा हूँ। अमेरिकन चेंबर ऑफ कॉमर्स से उनका एसोसिएशन है, वो उनको सपोर्ट करते हैं, जिससे कि ये मिली भगत है और ये एक नेटवर्किंग चल रही है जिससे कि हम अपने आप को खराब कर रहे हैं। और कोई प्रश्न है तो बताइए। यस, डॉक्टर मिस्टर खंडेलवाल।
Good evening to everybody. On the very outset, we thank Bengal Liver Summit, Dr. Mahesh Goenka and his team for inviting us from the Kolkata Senior Citizens Forum. We are here and it's an eye-opener for us. Before I start, may I ask Purushottam Ji Agarwal to start the session.
Good evening. I will go with a question because Indian food habit and Western food habit. As it is said, the processed food, Western food habit is having more processed food. Indian food habit is fresh food. Which do you think is more advisable?
मैं बाकी लोगों से भी पूछूंगा, बट इसमें कोई दो मत नहीं है। इंडियन फूड हैबिट इज मच बेटर, बट ट्रेडिशनल इंडियन फूड हैबिट, अब वो डिफरेंस रह नहीं गया है। हम भी बर्गर खाते हैं, हम भी चिप्स खाते हैं, हम प्रोटीन बार लेते हैं, हम आइसक्रीम खाते हैं, तो अब वो डिफरेंस रहा नहीं। लेकिन ट्रेडिशनल इंडियन फूड की बात करें तो ट्रेडिशनल इंडियन फूड जिसमें वेजिटेबल्स होती थे, फ्रूट्स होते हैं, वो मच बेटर है कंपेयर टू द वेस्टर्न फूड। मैं फिर बार बार एक ही बात को दोहरा रहा हूँ कि बॉम्बे में, महाराष्ट्र में एक डब्बा वाला का कॉन्सेप्ट है। आपने जरूर देखा होगा कि एक आदमी 100 टिफिन लेकर जाता है, वो बड़ा अच्छा कॉन्सेप्ट है। और वो ये है कि होममेड फूड ऑफिस में पहुँचाया जाता है, तो वो ऑफिस में फिर कॉफ़ी, चिप्स और आइसक्रीम और पिज्ज़ा नहीं खाते हैं, बर्गर नहीं खाते हैं, वो घर का खाना खाते हैं। तो आई थिंक हमें इनकरेज करना चाहिए, गवर्नमेंट को इनकरेज करना चाहिए कि होममेड फूड कैसे खाया जाए।
The purpose of this question was to make it eye opener for all those who are sitting here, because ये inducement एक चल रहा है कि वेस्टर्न फूड स्टाइल जो है इंस्टेंट किक देता है और इंडियन फूड तो जो है ये जंक फूड है।
ये फैक्ट है। जो अल्ट्रा प्रोसेस फूड का ना बात कर रहे हैं उसी को जंक फूड भी बोलते हैं, रेडी टू ईट फूड भी बोलते हैं। ये सारा फूड जिसकी बात कर रहे हैं, ये अब नेक्स्ट 5 साल में आप इसके बारे में बहुत सुनेंगे कि ये अल्ट्रा प्रोसेस फूड को कैसे अवॉइड किया जाए। इनफैक्ट सुप्रीम कोर्ट ने आज से ठीक 2 महीने पहले गवर्नमेंट को चेतावनी दी है कि अल्ट्रा प्रोसेस फूड को कम किया जाए, और WHO ने 2026-27 के लिए ये अपने प्रायोरिटाइज किया है कि हम पूरे वर्ल्ड में अल्ट्रा प्रोसेस्ड फूड के बारे में एजुकेशन देंगे।
नहीं, ये देखिए, उसमें एक सिंपल कॉन्सेप्ट बताता हूँ। वेस्ट का मजबूरी है। क्यों मजबूरी है? आप वेस्ट में होटल में जाइए, ब्रेकफास्ट में आपको कोई आदमी नहीं मिलेगा, कोई कुक नहीं मिलेगा, वो मिलेगा पैकेज फूड, बिकॉज फॉर देम मैन पावर इज वेरी एक्सपेंसिव। हमारा देश में लोग जॉबलेस है, सो इन ए लो कॉस्ट वी कैन गेट फूड मेकर। इसमें कोई डाउट नहीं है प्रिजर्व फूड आर बैड, प्रिजर्व फूड आर बैड। मैं एग्जाम्पल दिया, कोई साइंस में गया ही नहीं। मैंने बोला एक एनिमल में जो मीट है वही मीट मेरा शरीर में है। अगर उसका मीट को मैं केमिकल दे के 1 महीना रख सकता हूं, तो मेरा शरीर का अंदर वो मीट जब जाएगा वो वही काम करेगा जो उसको किया ना। तीसरा चीज है, उसके बाद भी कोई अगर फेल आ रहा है जो हमारा फूड जंक है, तो वो प्रोपागंडा है। एंड हमें बहुत अच्छी पता है मनी हैज द बिगेस्ट पावर, सो मनी कैन क्रिएट द रियल थिंग इनकरेक्ट एंड करेक्ट इनकरेक्ट थिंग करेक्ट। उसको एटलीस्ट हम अपना कोलाबोरेशन में एक के साथ एक हाथ रख के हम प्रॉमिस करें, जो ये बिग 170 करोड़ का प्रोपागंडा चल रहा है उसका अगेंस्ट में हम एटलीस्ट थोड़ा सा वॉइस एक साथ करें।
Just to add on, sir. Yes. Here, Dr. Ajit. So just to add on, अगर जब हम बात कर रहे हैं कि इंडियन फूड इज गुड, तो ऐसा क्यों हुआ कि हमारे देश में वेस्टर्न फूड इतना पॉपुलराइज हुआ? तो तो कहीं ना कहीं डिमांड भी जनरेट हो रही है हमारी तरफ से, जहाँ पर हम अपनी किचन पे कम रिलाई करके, जैसा सर ने बताया कि वेस्टर्न में क्या रीजंस हैं, हम उसकी तरफ जा रहे हैं. सो वी आर गोइंग मोर टुवर्ड्स टेस्ट. जब हम अल्ट्रा प्रोसेस्ड फूड की बात करते हैं, अल्ट्रा प्रोसेस्ड फूड का मतलब है इट इज़ नॉट अ फूड, इट इज़ सम एक्सट्रैक्ट फ्रॉम दैट फूड. और उस फूड को, जैसे सर ने बताया, मीट को 30 दिन तक रख सकते हैं. तो जिस मीट को कीटाणु भी नहीं खा रहे हैं उसको हम खा रहे हैं. जिस प्रोसेस फूड को बैक्टीरिया वायरसेस भी नहीं खा रहे हैं, वो खराब नहीं हो रहा क्योंकि उनको शेल्फ लाइफ बढ़ानी है, उनको टेस्ट बढ़ाना है, उनको एडिक्टिव्स डालते हैं उसके अंदर. उस चीज़ को अगर हम खाएंगे तो डेफिनेटली वो हमारे लीवर को जाके ज़्यादा नुकसान करेगा. तो वी हैव टू चेंज दिस हैबिट ऑफ गोइंग टुवर्ड्स अल्ट्रा प्रोसेस फूड. हमें अपनी किचन पर रिलाई करना चाहिए. अपने बच्चों को भी टिफ़िन घर से बनाकर देना चाहिए, ना कि उन्हें पैसे दें कि आप जाके अपनी स्कूल की कैंटीन से खाना खा लो.
डॉक्टर लीला कोई क्वेश्चन पूछेंगे. एक पॉइंट में और हाईलाइट करना चाहता तो जो हमारा ये नॉलेज लास्ट 3 या 4 साल में हुआ है कि हम पहले एक हेपेटाइटिस ए होता था, आप लोगों ने सुना होगा, बच्चों में जॉन्डिस होता था, पीलिया होता था, कई बार हम माला पहना देते थे, सब ठीक हो जाएगा. लेकिन अब हम देख रहे हैं कि उसका भी चेंज हो रहा है, मेटामॉर्फोसिस हो रहा है. हमारे लास्ट 2 या 3 साल में अपोलो में हेपेटाइटिस ए, जो बहुत सेफ बीमारी बताई जाती थी, उसके कारण हम बच्चों को, एडल्ट्स को लूज़ कर रहे हैं, उनको ट्रांसप्लांट करने की ज़रूरत पड़ रही है. तो हेपेटाइटिस ए जो पहले हम समझते थे बहुत माइल्ड बीमारी है, अब वो हमें समझ में आ रहा है कि उसको चेंज हो रहा है. ये क्यों हो रहा है मैं नहीं बता सकता, बट लेकिन चेंज हो रहा है. अब हेपेटाइटिस ए एक डेंजरस बीमारी होती जा रही है. इतनी बीमारी खराब हो गई कि शायद हेपेटाइटिस बी के बराबर की खराब बीमारी हो गई है. और डॉक्टर आकाश रॉय यदि कुछ उसके बारे में बोलना चाहें.
बिल्कुल सही है. आजकल के दिन में हम जो देख रहे हैं कि जो हेपेटाइटिस ए, आई थिंक जो हम में से अबाव 40s है या 50s है, हमको सबको बचपन में हुई जॉन्डिस हुई, चली गई. बट अब क्या हुआ है, इसके 2-3 कारण है. एक तो हमारी सोसाइटी की जो सोशियो इकोनॉमिक कंडीशन है वो बेहतर होती जा रही है. और जैसे डॉक्टर भदौरिया बता रहे थे कि ये फीको ओरल, मतलब आपकी जब सैनिटरी फैसिलिटीज़ खराब होती है तब ये होने के चांसेस ज़्यादा होते हैं. अब क्या हुआ है, आपके सैनिटरी फैसिलिटीज़ तो इम्प्रूव हो गए, इसलिए बचपन में अभी और वो जो जॉन्डिस होनी चाहिए थी वो नहीं हो रही है. तो जब एक अडल्टहुड में हो जाता है ये, आप जब 25 से 30 साल से 35 साल पे होता है, तब ये वायरस जब आपके शरीर में आती है तो ये डिफरेंटली बिहेव करती है. बच्चों में जब होता है तो वो जॉन्डिस होकर चला जाता है, पर ये जब अडल्ट में होने लगती है, क्योंकि अडल्ट में उसको होना नहीं था, हमारे बॉडी की इम्यून सिस्टम ऑलरेडी तब डेवलप हो चुकी है, तो वो जो सिवियरिटी होती है वो बहुत बहुत ज़्यादा हो चुकी है. और मैं ये डेटा थोड़ा शेयर करूँगा. इस साल की 2025 की लैंसेट की जो पेपर है उसने ये क्लियरली दिखाया है कि पुराने दिनों में हम सोचा करते थे कि हमारे देश में 90% लोग को आइदर हेपेटाइटिस ए हो चुका है या फिर उनको हेपेटाइटिस ए की वैक्सीनेशन लगी है. इस बार की जो पेपर है उसने बोली है कि पूरे देश में मैक्सिमम स्टेट्स में ये 90% से कम होके 60 से 65% हो चुकी है. और 2 स्टेट जो सबसे कम है, मतलब जिनमें इम्यूनिटी टू हेपेटाइटिस ए, मतलब बच्चों को हो ही नहीं रही है, अडल्ट्स को हो सकती है. टॉप 2 स्टेट्स, नंबर 1 वेस्ट बंगाल, नंबर 2 केरला. और हम लोग देख रहे हैं कि ये दोनों स्टेट में ये प्रॉब्लम सबसे ज़्यादा जरूरी है. और ये उस डेटा से इस बार क्लियर हो गया है कि अब और वो हेपेटाइटिस ए एक नॉर्मल बीमारी नहीं है, एक बहुत ही गंभीर बीमारी हो चुकी है.
डॉक्टर लीला.
Actually, there was a little bit of reference about the vaccinations, but then real details about the vaccinations should be given to the public.
I would very important question. और ये मैं 2 तरह से important समझता हूँ. डॉक्टर भदौरिया ने बताया कि हेपेटाइटिस ए और हेपेटाइटिस बी की वैक्सीन हमारे पास बहुत टाइम से थी. हेपेटाइटिस ए बी की वैक्सीन तो गवर्नमेंट के प्रोग्राम में है कि 3 वैक्सीन मिलना चाहिए, एक जन्म के बाद, एक महीने बाद और एक साल बाद, 0, 1, 6 months या 0, 1 year जो भी हो, तो 3 वैक्सीन मिलना चाहिए. 3 वैक्सीन के बाद और वैक्सीन की ज़रूरत नहीं है. सो 3 वैक्सीन से 98% ऑफ द पीपल को और हेपेटाइटिस बी नहीं होगा. इसी तरह से हेपेटाइटिस ए की वैक्सीन भी होती है, दोनों कॉम्बिनेशन भी आता है, नहीं अदरवाइज हेपेटाइटिस ए की वैक्सीन अलग से 2 डोज लेने से हो जाता है. तो ये हेपेटाइटिस ए की वैक्सीन अब इम्पॉर्टेंट हो गई है, क्योंकि अब यदि बचपन में हेपेटाइटिस ए नहीं होता है तो एडल्ट में अवॉइड करने के लिए हेपेटाइटिस ए के वैक्सीन भी ले सकते हैं. और एक अच्छी न्यूज़ ये है कि अभी तक सी के लिए और ई के लिए वैक्सीन नहीं थी. अभी इस महीने ई के लिए भी वैक्सीन लॉन्च हुई है और अब ई के लिए भी वैक्सीन मिल सकती है. तो ए के लिए वैक्सीन है, बी के लिए वैक्सीन है, ई के लिए वैक्सीन है, और बी नहीं हो तो डी भी नहीं होता है, क्योंकि डी के लिए बी होना जरूरी है। तो अब केवल सी रह गया है जिसके लिए वैक्सीन नहीं है। और जो अच्छी बात डॉक्टर अदीज भदौरिया ने भी बताई कि सी फॉर्चुनेटली ऐसी दवाई अब हैं कि 3 महीने से 6 महीने तक यदि दवा ले लें तो सी पूरा पूरा गायब हो जाता है। तो अब वायरस को कंट्रोल करना इतना डिफिकल्ट नहीं है, लेकिन हमारे को नॉलेज होना चाहिए, वैक्सीन लेना चाहिए, तभी ये प्रिवेंट हो सकती है। आई होप आई एम क्लियर डॉक्टर लीला।
Yes, yes.
मैं एक चीज इसमें ऐड करूंगा
I
सर।
want you to, give it to the public so that they can understand.
सो मैं एक चीज और बोलूंगा कि एक गलतफहमी है लोगों को कि हेपेटाइटिस बी का वैक्सीन हर 5 साल में फिर लेना चाहिए। मैं ड्रग इंडस्ट्री में या कुछ फार्मास्यूटिकल कंपनी को बोलूंगा कि वो चाहते हैं कि हर आदमी 5-5 साल पर वैक्सीन लेता रहे, कि 80 साल का रहेगा तो कम से कम उनकी 14 वैक्सीन बिक्री हो जाएगी। लेकिन ऐसी ज़रूरत नहीं है, केवल 3 वैक्सीन हेपेटाइटिस बी के लेने से काम हो जाता है। ज़िंदगी में मैक्सिमम लोगों को जिसकी इम्यूनिटी ठीक है और वैक्सीन लेने की ज़रूरत नहीं है।
There is a lot of confusion about the oil which is to be used or the ghee to be used. Yes.
Let me first answer and maybe Dr. Bhadoria or others can add. ये बड़ा important question है। मेरे को पता था ये question आएगा, लेकिन इतनी देरी से आएगा मेरे को नहीं पता था। तो ऑयल बड़ा important है, और ऑयल में 3 चीज़ important है। एक है कि क्वांटिटी क्या होनी चाहिए, जितना कम ऑयल खाने से काम हो जाए वो लेना चाहिए। दूसरी बड़ी इंपॉर्टेंट बात है कि रीहीट नहीं करना चाहिए। ऑयल को रीहीट करना, आपने बाजार में देखा होगा, पकोड़े बनते हैं, ऑयल ठंडा हो गया, उसको फिर से गर्म कर दिया गया, दैट इज डेंजरस। हाइड्रोजनेशन होता है, इट्स ए डेंजरस चीज। कभी भी घर पे भी ऑयल को फिर से गर्म करके चीज मत बनाइए, ऑयल कम से कम लीजिए। और तीसरा है कौन सा ऑयल लें, तो सबसे खराब है वनस्पति, जो हाइड्रोजनेटेड ऑयल होता है। सबसे अच्छा ऑयल है जिसको अलसी का ऑयल बोलते हैं, फ्लैक्सीड ऑयल या वर्जिन ओलिव ऑयल। ऑलिव ऑयल आपने सुना होगा। सो ऑलिव ऑयल और पीनट ऑयल और फ्लैक्सीड ऑयल्स आर द बेस्ट ऑयल। बट इवन इफ यू लुक एट कोकोनट ऑयल इज ऑल्सो गुड। सो ये अच्छे ऑयल में आते हैं। खराब ऑयल में आएगा वनस्पति का घी, जो सॉलिड ऑयल बन गया है, जिसको सॉलिडिफाई कर दिया गया है, जिसको हम ट्रांस फैट बोलते हैं। उसकी परिणाम पूरे दिन में 1% से ज़्यादा में नहीं लेना चाहिए। डॉक्टर भदौरिया, यू वांट टू ऐड समथिंग?
मस्टर्ड ऑयल और ऐड करना चाहूँगा मैं, दैट इज ऑल्सो वेरी गुड। अदरवाइज सारे पॉइंट्स कवर कर लिए।
हेलो, वनस्पति अवॉइड करना है टोटली, लेकिन गर्म करके, पैसे बचाने के लिए गर्म करके बार बार ऑयल को नहीं यूज़ करना चाहिए।
हाँ डॉक्टर साहब, मेरे 2-3 क्वेश्चन थे। एक तो फैट पर आप लोगों ने काफ़ी इम्पोर्टेंस दिया है, तो ए फैट पर्सन इज वल्नरेबल टू फैटी लिवर।
आपके सारे प्रश्न कर ले तो एक साथ हम उत्तर दे देंगे।
ठीक। दूसरा था, आपने बताया जेनेटिक, तो जेनेटिक में जैसे हम लोग कई बार ये डायबिटिक बोलते हैं, भाई हेरिडेटरी है, तो इज इट ऑल्सो द केस विद दिस लिवर मैटर ऑल्सो? और दूसरा था फूड में, जैसे हम लोग इंडियन लोग भी कई बार फूड जैसे रात में पकाया, उसको फ्रिज में रख दिया, नेक्स्ट डे लेते हैं, तो हाउ फार इट इज़ एडवाइजेबल दैट वी शुड टेक सच फूड? और एक आजकल हम लोग ब्रेड, पिज़्ज़ा, केक, ये बहुत कॉमन सी हो गई है। व्हाट यू सजेस्ट जे वेदर दीज आर ओके और शुड नॉट बी टेकन?
मैं आपके लास्ट प्रश्न से फर्स्ट प्रश्न में आता हूं, एंड आई वुड वांट ऑल ऑफ देम, ऑल द एक्सपर्ट्स टू आंसर
ब्रेड का क्वेश्चन।
पहली बात है कि हम बार बार यही बात बोल रहे हैं कि पिज्ज़ा, बर्गर्स, इनको अवॉइड करना है, ये खराब चीज़ है। फ्रिज में रखा हुआ खाना, फल यदि आपने रखा है और नेक्स्ट डे खा रहे हैं तो उसमें कोई खराबी नहीं है, लेकिन आप उसको एक लिमिट तक ले सकते हो। जेनेटिक, यस, डायबिटीज़ जेनेटिक बीमारी है, हाइपरटेंशन जेनेटिक बीमारी है, और उनके साथ फैटी लिवर डिजीज़ का क्लियर एसोसिएशन है ही। और एक पहला प्रश्न आपका था फैट के बारे में, हमने बताया कि एक अजीब चीज़ देखी गई है जो इंडिया में ज़्यादा होता है, कि ये फैटी लिवर डिजीज़ केवल मोटे लोगों को नहीं होता है। 15% ऐसे होते हैं जो देखने में पतले दुबले हैं लेकिन उनको फैटी लिवर होता है। ये उसका कारण है कि ये मोटापा अंदर का नहीं है, अंदर का, बाहर का नहीं है, अंदर का मोटापा है, विसरल फैट ज़्यादा है उनको, इसलिए इसको हम लीन फैटी लिवर डिजीज़ बोलते हैं। और ये देखा गया है कि इंडिया में ये काफ़ी कॉमन है। काफ़ी कॉमन मतलब 15 से 20% जो फैटी लिवर होते हैं वो पतले लोगों को होता है। तो इसका मतलब ये नहीं है कि पतले होने से और फैटी लिवर नहीं हो सकता। एनीबडी वांट्स टू ऐड?
नहीं, देखिए, जेनेटिक जो है ये तो हमको पेरेंट से मिला, इसको तो हम चेंज नहीं कर पाएंगे। सो जेनेटिक फैक्टर तो हैं, लेकिन ये चेंज नहीं किया जा सकता है। लेकिन दूसरी जो है जो ऊपर से हम हमारा ऊपर डाल रहा है वो है मोटापा, क्या हम खा रहा है, कितना एक्सरसाइज कर रहा है, वो हम चेंज कर सकते हैं। तो डायबिटीज में भी जेनेटिक फैक्टर है, फैटी लीवर में भी जेनेटिक फैक्टर है, लिपिड प्रॉब्लम में भी जेनेटिक फैक्टर है, प्रेशर में भी जेनेटिक फैक्टर है, लेकिन उसको हम चेंज नहीं कर सकते हैं। हम मोटापा चेंज करें, अपना आदत चेंज करें, खाना चेंज करें, एक्सरसाइज बढ़ाएं।
और जेनेटिक फैक्टर्स में मतलब आप लोग कैसे समझ सकते हैं जेनेटिक फैक्टर है कि नहीं? अगर परिवार में डायबिटीज़ है, हाइपरटेंशन है, हार्ट डिजीज़ है, गॉल ब्लैडर स्टोन्स हैं, फैटी लीवर है, ये सारी आप देखो ना, दीज आर ऑल बिकॉज ऑफ एक्स्ट्रा फैट इन द बॉडी। अगर इस तरह की बीमारियां परिवार में चल रही हैं तो इसका मतलब आपको भी ये बीमारी होने के चांसेस बहुत ज़्यादा हैं। मगर जैसे सर ने कहा, आप उससे बच नहीं सकते, मगर आप उसको डिले कर सकते हैं। अगर आप अपनी एक्सरसाइज पे ध्यान देंगे, हेल्थ पे ध्यान रखेंगे, तो हो सकता है जो आपके पिताजी को 50 या 60 साल पे हुई वो शायद आपको ना हो, या आपको भी 50-60 साल पे लेट हो। आजकल क्या हो रहा है, जिनको जेनेटिक हिस्ट्री है, जिनको फैमिली हिस्ट्री है, अगर वो अपना ध्यान नहीं देते तो पता चला 10-15 साल पहले उसको बीमारी हो रही है। तो ये चीज़ ऐसी है जो उसको जिससे बच नहीं सकते, मगर उसको डिले कर सकते हैं बाय टेकिंग केयर ऑफ योर गुड हेल्थ।
Dr. Fontana, you think your liver diseases are decreasing in USA, or they're increasing, or they're static in USA?
Yeah, there's certainly, again, these things track in parallel. So I think excess calories, it's quantity and the quality that we're saying. It's too much and the wrong foods. But in general, the US, the rates of obesity are starting to plateau. They haven't come down yet. And I know you've been really emphasizing diet and activity, physical activity, which I agree. We also have new medications that you briefly mentioned in one of your slides. And we're hopeful that with a combination of behavioral therapy, diet, exercise, and some people needing medications, that we're going to start to turn the corner here soon with a reduction in fatty liver and other problems.
Haji.
Hello. Hello, doctors. I am Mahavir Gupta. I have been diagnosed with fatty liver, NAFL, last June 2024. My fibro scan reading was 25. My SGPT was 72, SGOT was 72, SGPT was 50. And my GGT was also on higher side. So I visited a doctor and he advised me what I understood with the doctor's advice, that my weight was 74 at that time in June 2024. So what I understood from my doctor's advice that I have to reduce my weight and change my lifestyle, and so gradually within a year I reduced my weight from 74 to 59, and my fibro reading gradually decreased from 25 to 13. So, okay, fine. But now, after coming to 13, my fibro reading, it is recently increased slightly, 14, it is now 14. So I just want to know with doctor, what should be the course of my action in future to reduce it more?
So आपने जो बोला फाइब्रोसिस स्कोर का 14 आप बोल रहे हैं, वो आपने फाइब्रो स्कैन की बात कर रहे हैं?
फाइब्रो स्कैन।
हाँ, तो एक तो पहली बात मैं आपको लोगों को एक चीज़ बड़ा इंपॉर्टेंट बताना चाहता हूँ कि फाइब्रो स्कैन की मशीन कई तरह की है। कलकत्ते में ज़्यादा सेंटर्स में जो मशीन है वो स्टैंडर्ड मशीन नहीं है, उसको फाइब्रो टच बोलते हैं। तो आप अपनी रिपोर्ट जरूर देखिए कि वो फाइब्रो टच से किया गया है कि इकोसेंस की एक मशीन होती है जो ज़्यादा अच्छी मशीन है, या हमारे पास एक सैमसंग की मशीन है वो बहुत अच्छी मशीन है। तो आप किस टेस्ट पे डिपेंड करते हैं?
सर आपके यहाँ ही किया गया था।
हाँ, तो ये डिपेंड करता है कि यदि हमारे यहाँ किया गया है और
अपोलो में,
हाँ अपोलो में किया गया है और वैल्यू यदि 1 पॉइंट इधर या उधर हो रही है तो वो कोई बड़ी बात नहीं है। इनफैक्ट हमने ये भी देखा है, और ये डॉक्टर आकाश रॉय ने रिसेंटली मेरे को बताया कि हम जब लिवर के डिफरेंट पार्ट्स को देखते हैं तो जरूरी नहीं कि फाइब्रोसिस का स्कोर हर जगह सेम हो,
नहीं, मेरा स्कोर सर सेम आया था दूसरी जगह भी।
थोड़ा सा डिफरेंस हो सकता है। नहीं, मैं बोलता हूँ एक लीवर के अंदर भी थोड़ा बहुत डिफरेंस आ सकता है। तो इतना 1 पॉइंट ज़्यादा कम होने से इतनी घबराने की बात नहीं है। लेकिन अपने वेट को आप मेंटेन करें, ये बहुत इंपॉर्टेंट है। अपने वेट को आप जरूर मेंटेन करें।
नमस्कार सर, मेरा
सवाल पूरा हुआ नहीं।
हम अपनी जनरल बात करें तो ज़्यादा अच्छा रहेगा।
मेरा जनरल क्वेश्चन है कि दूध, मिल्क या मिल्क प्रोडक्ट, बहुत से लोग बोलते हैं, बहुत से डॉक्टर सजेस्ट करते हैं कि डो नॉट टेक एनी मिल्क प्रोडक्ट, ये दूध है, दही है, ये नहीं लें। बहुत से डॉक्टर बोलते हैं नहीं, यू मस्ट टेक मिल्क एंड थर्ड। तो ये क्या थ्योरी है?
मैं आपको बताऊं इस बारे में कि इंडिया में या इंडिया के रीजन में एडल्ट्स में 40 to 50% को मिल्क टॉलरेट नहीं होता। इसको हम लैक्टोज इंटॉलरेंस बोलते हैं। ये 40 to, अभी हम ये लिवर की बात नहीं कर रहे, मैं अभी मिल्क इंटॉलरेंस की बात कर रहा हूँ कि इंडियन पॉपुलेशन में एडल्ट में 40 to 50% आर लैक्टोज इंटॉलरेंट। इसका मतलब हो गया कि ज़्यादा अमाउंट ऑफ मिल्क लेंगे तो आपको टॉलरेंट नहीं होगा, वो आपको गैस फॉर्म करेगा, ब्लोटिंग हो सकती है, लूज मोशन हो सकता है। तो ये तो मिल्क की बात हो गई। लेकिन इसका मतलब ये नहीं है कि आप जनरल में मिल्क बंद कर दें। ये हो गया कि यदि आप मिल्क का इंटॉलरेंस है तो उसकी टेस्टिंग भी होती है, हमारे यहाँ भी टेस्टिंग होती है, तो उदय घोषाल रेगुलरली करते हैं, जिससे पता लग सकता है कि आपका मिल्क का इंटॉलरेंट है कि नहीं है। तो वो सांस का टेस्ट करने से भी पता लग सकता है। लेकिन ये ऑल और नन फेनोमेनन नहीं है कि ऐसा जरूरी नहीं है कि आपको नहीं होता है तो आप बिल्कुल नहीं सकते। आप 1 कप चाय में यदि 2 चम्मच दूध लें तो वो खराब नहीं होता है। दूसरा, जहाँ तक आपने गेहूं की बात करी, व्हीट इंटॉलरेंस, ये एक मिथ है। ये हम तो बेसिकली ज़्यादा लोग हम या तो चावल खाते हैं या गेहूं खाते हैं, तो व्हीट इंटॉलरेंस इतना कॉमन नहीं है। ये लेस देन 5% ऑफ द पॉपुलेशन इन इंडिया हैव व्हीट इंटॉलरेंस एज कम्पेयर टू 50% फॉर मिल्क। तो व्हीट को जनरली अवॉइड करना मैं उचित नहीं समझता। किसी को बीमारी है वो बात अलग है।
तो इसमें मैं थोड़ा सा ऐड करता हूँ। देखिए ऐसे है ना, नेचर ये नियम बनाया। क्या नियम बनाया? जो दूध बच्चा पिएंगे, लेकिन नेचर को पता था जो हम लोग उनका बात सुनेंगे नहीं, इसलिए उन्होंने क्या किया, जैसे हम लोगों को जो बाल होता है उम्र होते होते ज़्यादातर लोगों को निकाल जाता है, तो नेचर नहीं किया, ऐसे एक जीन दे दिया अंदर, सो दैट बाल धीरे धीरे चला जाएगा। सिमिलरली उन्होंने एक जीन दे दिया हमारा अंदर, जो जैसे हम एडल्ट हो जाएंगे मिल्क पाचने का क्षमता हमारा खत्म हो जाएगी। ये इसलिए किया सो दैट हम मिल्क छोटे वाला का नहीं पिए, वो छोटे के लिए,
बच्चों के लिए छोड़ दे।
भाई अभी क्या है, फिर आपको तो पीना है, क्यों? उस मिल्क में कैल्शियम है। इधर आप कैल्शियम का टैबलेट ले जिससे कब्ज होता है, तो आप मिल्क फिर कैसे लेंगे? उसको दही बना लीजिए। जब दही बनाते हैं, हम क्या कर रहा है, पहले दिन का दही उसमें डालते हैं, तो पहले दिन का दही में एक बैक्टीरिया है जिसका नाम है लैक्टोबैसिलस। वो क्या करता है, मिल्क का अंदर जो लैक्टोज नामक शुगर है वो शुगर को ब्रेक करता है, तो ग्लूकोज और गैलेक्टोज उससे बन जाता है। वही हमारा बॉडी का अंदर भगवान ने नॉकआउट किया, जो वो हम ग्लूकोज और गैलेक्टोज ब्रेक नहीं कर पाएंगे, हम बाहर से कर लिया। तो आप दूध नहीं पीजिए, दही पीजिए, और दही से जो जो मिठाई बनता है वो खाइए, और टेस्ट करना है वो ब्यूटीफुल टेस्ट। सिर्फ सांस लेंगे, कोई एंडोस्कोपी नहीं करेंगे, कुछ नहीं करेंगे, आपको बता देंगे आपका एक इंटॉलरेंस है कि नहीं, दूसरा कितना है वो भी बता दें।
एक बात मैं बिफोर वी लिसन टू द नेक्स्ट क्वेश्चन, एक चीज़ जो डॉक्टर आकाश ने मेरे को भी बोला कि हमने अभी तक मिठाई की बात ही नहीं की। हमें मिठाई को भी कम करना है, कार्बोहाइड्रेट्स। लेट मी टेल यू, हम फैटी लिवर की जब बात करते हैं तो इसका मतलब ये नहीं है कि हमको फैट कट डाउन करना है, हमें कार्बोहाइड्रेट ज़्यादा कट डाउन करना है। बिकॉज जो कार्बोहाइड्रेट बॉडी में जाकर फैट में कन्वर्ट होता है, जो एक्सेस कार्बोहाइड्रेट होता है वो बॉडी में लाइपोजेनेसिस करता है, फैट प्रोडक्शन करता है। तो आई थिंक मिठाई का कंट्रोल करना बहुत जरूरी है।
कोलकाता में मिठाई को बीच में नहीं लाना चाहते ना।
मैं
बदनाम नहीं करना चाहते मिठाई को।
नो, बट इसमें एक चीज जो बोल दूं, मैं लखनऊ में रहा, वहाँ का मिठाई अच्छा नहीं, बहुत चीनी डालता है, लेकिन यहाँ का मिठाई अच्छा है, चीनी बहुत कम डालता है, तो चीनी कम डाला हुआ मिठाई लीजिए।
हाँ जी, प्रश्न।
So, good evening panel of doctors. One of them esteemed traveled from overseas, one of them from Rishikesh. So good evening to all of you. My question is very limited. Like there are basically 2 or 3 एज रिलेटेड डिजीज़, 2 या 3 एज रिलेटेड होती हैं. एक है मधुमेह जिसे हम डायबिटीज़ के नाम से जानते हैं, दूसरा है हाइपरटेंशन जिसे हम उच्च रक्तचाप के नाम से जानते हैं, और तीसरी कोलेस्ट्रॉल, लाइक आपकी ट्राइग्लिसराइड्स लेवल यदि हाई है तो कोलेस्ट्रॉल लेवल हाई पाया जाता है. एंड नॉर्मली द डॉक्टर्स प्रिस्क्राइब्स कोलेस्ट्रॉल के लिए आपको स्टैटिन दिया जाता है, हाइपरटेंशन के लिए आपको कोई ना कोई दवाई प्रिस्क्राइब दी जाती है, सिमिलरली फॉर शुगर के लिए भी आपको दवाई. सो हाउ दिस मेडिसिन्स are relating or you are hampering your liver. My limited questions, because the senior citizens or the people who are aging, they have to take this medicine and they have to go by this medicine. They have to take Rosubus or say statin or any other medicines, but are they really affecting your liver gradually? Because in this case, should they also go for that SGOPT or SGPT test on a regular basis or LFT test on a regular basis, or you have suggested वो MRI और FADD आपने जो टेस्ट की बात कही थी, उन लोगों के लिए ये टेस्ट कितने अंतराल में ज़रूरी है? What is the intervals of this test, those who are in this kinds of medicines? Thank you so very much.
तो पहला तो मैं आपकी बात से डिसएग्री करना चाहूँगा कि जैसे जैसे उम्र बढ़ती है तो डायबिटीज़, हाइपरटेंशन, कोलेस्ट्रॉल होना ही होना है. ठीक है, ये होने के चांसेस ज़्यादा हैं. और चांसेस क्यों ज़्यादा हैं? क्योंकि जैसे जैसे आपकी उम्र बढ़ती है वैसे वैसे आपका एक्सरसाइज कम हो जाता है, काम का प्रेशर ज़्यादा हो जाता है, स्ट्रेस ज़्यादा होती है, नींद कम होती है, बैड हैबिट्स कुछ कुछ ऐड होती चली जाती हैं. तो अगर हम अपनी लाइफस्टाइल को हेल्दी रखेंगे तो डायबिटीज़, हाइपरटेंशन, कोलेस्ट्रॉल वगैरह आपका नहीं बढ़ेगा. दूसरी चीज़, जिनका बढ़ गया है फिर भी बिकॉज ऑफ जेनेटिक रीजन से किसी वजह से बढ़ गया है, अगर वो दवाई खा रहे हैं, जो सारी दवाइयाँ हैं डायबिटीज़ की, हाइपरटेंशन की या कोलेस्ट्रॉल को कम करने के लिए, ये मोस्टली सारी दवाइयाँ बहुत सेफ़ हैं. ऐसा नहीं है कि इन दवाइयों को खाने से आपको लीवर में प्रॉब्लम होगी होगी, और कोई रेगुलर लीवर फंक्शन टेस्ट इन दवाइयों के लिए करानी चाहिए. तो ये मेरी तरफ से है. कुछ ऐड करना चाहते हो?
उसमें एक चीज़ और बता दूं, हम लोग पूरा क्लियर समझे, हम दोस्त को दुश्मन ना समझ ले. तो किसी को अगर डायबिटीज है तो डायबिटीज का जो मेडिसिन ले रहा है वो दोस्त है, और डायबिटीज खुद दुश्मन है. तो आपने जो बताया बिल्कुल ठीक बताया. डायबिटिक जो है उनको फैटी लिवर ज़्यादा होता है, डायबिटिक जो है उनको लिपिड ज़्यादा होता है. लेकिन वो फैटी लिवर इसलिए नहीं होता है जो आपने डायबिटीज का दवा खाया. उस फैटी लिवर इसलिए हुआ जिसको भी डायबिटीज है उनको फैटी लिवर होने का रिस्क ज़्यादा है. ये एग्जाम्पल दे रहा हूँ, मेटफॉर्मिन करके एक दवा है, डायबिटिक ऑलोग दिया जाता है. वो मेटफॉर्मिन इतना अच्छी दवा है, आपको ओबीज नहीं होने देता इजीली, आपका अंदर कैंसर प्रिवेंट करता है, हार्ट का बीमारी प्रिवेंट करता है. सो देयरफॉर दोज आर गुड. बट येस, कुछ कुछ एंटी डायबिटिक दवा है, कुछ लिपिड लोअरिंग दवा है जो लिवर को अफेक्ट करता है. उसलिए एटलीस्ट जब पहले बार आपको डायबिटीज डायग्नोसिस हुआ, ये सब हो जाना चाहिए. लिपिड होना चाहिए, ईसीजी होना चाहिए, लिवर फाइब्रोस्कैन होना चाहिए, सब कुछ होना चाहिए. उसके बाद 1-2 साल अंतर आप कर सकते हैं जस्ट फॉर द चेक, बट इट इज रीजनेबली, दोज मेडिसिन्स आर रीजनेबली सेफ.
केवल एक चीज़ मैं ऐड करूंगा कि लिपिड के लिए जो आपने बताया स्टैटिन ले रहे हैं, जनरल स्टैटिन भी सेफ हैं. किसी को यदि लीवर की बीमारी है तो उसको स्टैटिन प्रॉब्लम कर सकता है, लेकिन ऐसा बात नहीं है कि इनको, जैसा कि डॉक्टर उदय ने बोला, इनको आप दुश्मन मत समझिए. ये ज़्यादा इंपॉर्टेंट है कि बीमारी को कंट्रोल किया जाए बाय प्रॉपर मेडिसिन रादर देन अवॉइडिंग द मेडिसिन. लेकिन मैं एक बात जाते जाते फिर से कहना चाहूँगा, ये काढ़ा पीने की जो हैबिट हो गई है हम लोगों का, कोविड के समय मेरे को पता है 3-3 कप 4-4 कप लोग काढ़ा पी रहे थे, उसमें गिलॉय था और गिलॉय के कारण डैमेज हो रहा था. प्लीज़ ये समझिए, मैं कोई आयुर्वेदिक या होम्योपैथिक मेडिसिन के अगेंस्ट में नहीं बोल रहा हूँ, लेकिन मैं कहना चाहूँगा कि मेडिसिन जो चाहे वो आयुर्वेदिक हो, उसमें भी कई मेडिसिन हैं जिसके कारण डैमेज होता है. हल्दी भी ज़्यादा मत लीजिए, काढ़ा ज़्यादा मत लीजिए, दवाई जो भी ले रहे हैं आप ये सोचिए कि उसके अंदर भी डैमेज हो सकता है. I think we would close it down, and I thank once again. I thank the press people also. Is there any question there, madam?
Yes.
You want to ask a question?
Hello.
Yes.
Hello.
We
Hello.
would. Ladies have to be the first and the last.
One
आप पूछ सकती हैं. इसके बाद मैं चाहूंगा आप कुछ चाय और कॉफी का इंतजाम है पीछे जरूर लेकर जाएं, और कॉफी लिवर के लिए अच्छी होती है. 2 कप कॉफी यदि रोज पिएंगे तो लिवर के लिए बहुत अच्छा है. मैडम पूछिए.
हेलो सर, आई एम अ बेसिक काउंसलर अटैच विथ अ गायनेकोलॉजिस्ट, एंड एवरी डे एटलीस्ट 15 to 20 रिपोर्ट्स और पेशेंट्स, गायनी पेशेंट्स, मैं उनसे मिलती हूँ. मैक्सिमम लेडीज़, चाहे वो यंग है, 18 ईयर है या 45 है, प्राय सब में फैटी लीवर निकलता है, होल एब्डोमेन का। और इसमें जो भी मैं क्वेश्चन 2-4 कर रही हूँ, इट्स कॉमन क्वेश्चन, मेरे लिए कोई भी क्वेश्चन नहीं है अभी तक। तो एक तो ये जो हो रहा है कि यंग हो या जो भी, सबको ये फैटी लीवर आ रहा है, तो मैं एक एक क्वेश्चन पूछूं या जितने हैं मैंने?
ये मैं आपको अभी इसका आंसर मैंने ऑलरेडी दिया है कि इंडिया में 1 in 3 को फैटी लीवर है। तो ये हो सकता है कि आपके पास जो पेशेंट आ रहे हैं वो ज्यादा मोटे पेशेंट्स हैं या उनको और हाइपरटेंशन डायबिटीज हैं।
हर एज के हैं
हाँ,
पेशेंट्स।
मैंने आपको ये भी बोला कि 20% नॉर्मल हेल्थ वालों को भी, लीन लोगों को भी फैटी लीवर हो सकता है। आपका एक अगला प्रश्न एक और कर लें ना, मैडम को करने दीजिए, प्रश्न और करने दीजिए।
आई एम नॉट आस्किंग फॉर मी,
पूछने दीजिए मैडम।
एक दूसरा जो आजकल प्रोटीन पाउडर, आप घर में हो, बच्चे हो, बड़े हो, सबको एक ही है प्रोटीन पाउडर, मगर अगर उनको दाल खाने बोलो,
खतरनाक चीज है प्रोटीन पाउडर और प्रोटीन बार, खतरनाक चीज है, बस इतना ही बोलूंगा मैं, खतरनाक चीज है।
दूसरा, एक मिल्क के लिए जो एक मिथ हो गया है कि नहीं, मिल्क नहीं लेना चाहिए बिकॉज ये आजकल प्योर नहीं है, कैल्शियम तो है ही नहीं।
अभी ये प्रश्न किया गया था 50% को एडल्ट में मिल्क टॉलरेट नहीं होता।
आई एम नॉट आस्किंग कि मिल्क टॉलरेंट और समथिंग।
नहीं, मैं मिल्क की बात कर रहा हूँ। मिल्क एक परिमाण से ज्यादा 50% ऑफ द एडल्ट्स इन इंडिया कैन नॉट टॉलरेट।
मगर जो इसमें बोला जाता है कैल्शियम है, और एक तरफ बोलते हैं कि नहीं, आजकल तो मिल्क सब पैकेट के आते हैं, उनमें कोई कैल्शियम नहीं, बच्चों के लिए।
इसलिए धूप का सेवन कीजिए,
है ना, और कैल्शियम है उसमें।
और ये जो एक गेहूं का लिए आपने बताया भी कि ये मिथ हो गया है कि गेहूं मत खाओ, इंटॉलरेंस है, बट इसके बदले मल्टीग्रेन हम लोग बहुत ज़्यादा कंज्यूम कर रहे हैं। इनफैक्ट मेरे भी घर हो या किसी का भी कि मल्टीग्रेन लो, तो एक ग्रेन यूज़ करना चाहिए या आप मिक्स मल्टीग्रेन यूज़ कर सकते हैं?
मल्टीग्रेन ठीक है, अच्छा है, मल्टीग्रेन ठीक है, इनफैक्ट हाँ मल्टीग्रेन ठीक है।
1 ग्रेन एट ए टाइम, और या सब मिक्स करके कि आप रागी एंड ज्वार, बाजरा।
देखिए एक चीज बड़ा सिंपल है, मल्टीग्रेन अच्छा है, लेकिन आप ऑलवेज देखिए जो पैकेज आइटम होता है उसका रेगुलेशन इतना स्ट्रांग नहीं है। बट अदरवाइज अगर आपने चना का आटा, गेहूं का आटा सब मिला दे रहा है, इज वेरी गुड, बिकॉज चना का आटा हैज मोर प्रोटीन देन गेहूं का आटा। बट गेहूं का आटा जो पुलाव बनाता है, जो रोटी का शेप होता है, वो चना का आटा नहीं देता है।
थैंक यू।
थैंक यू।
सो मैं आप सबका एक बार धन्यवाद करता हूं, और हम ऐसे प्रोग्राम और करना चाहेंगे आप लोगों के साथ, जिसमें हम आपस में आपका सोच और हमारा सोच में क्या डिफरेंस है, उसको कैसे ब्रिज किया जाए, ये हम करना चाहेंगे। एक वो ग्रुप फोटो मांग रहे हैं। Can I ask my other people from Apollo also to join for the group photo?
Hello, हमारा एक
Please don't cast out. It's over. Program is over now. 5:30 हो गया. आपने भी ले लो। हाँ ले लो कितना? अरे आना ले जो ऑफिस बेर आना ले मना। तो दाल भात में मुसल चल रहा है।
अरे मुसल में तो काम चल रहा है।
खड़े हो सब आइए। आइए
मुसल पे ये।
अरे आ जाओ। आइए ना। आ बेटा
चल ले।
हाँ आइए लीला जी आओ। अरे मेरी बहू ने दे दो, ले लेगी। बेटा जाओ, आ जाओ।
फोटो कर दो।
Join us for the coffee.
पापा ने दे दो, पापा ने दिया है। आ जाओ, साहू है।
आ गया बेटा।
X minus